Good evening, everyone.
Good evening, Dr. Trimurugan, sir.
Sir, yes, sir. Good evening, sir. Good evening, sir.
Good evening, Srinivasan, sir. Good evening.
Good evening, sir. Everybody has mistaken and congratulating me. I said you're all this thing, you know. So I don't deserve, and I don't think I'll be getting any awards. So I said, how can you mistake me getting it? Some of the people, they were congratulating me.
Yes, sir.
Then I knew it is this Srinivasan, so I immediately called him and congratulated him. So out of Ramachandran has written 3 Srinivasans, yes, Srinivasans. I said anybody would have known this Srinivasan doesn't deserve it.
Sir,
Hello, Dr. Bala.
Srinivasan, great, sir.
All Srinivasans are great people.
Thank you, sir. Bala had asked me repeatedly every year for doing something, but I declined because my conscience didn't permit me to apply for that.
Sir, you never applied, sir. You would have got it right, right royally. You deserve it.
I'm still a student, sir.
Good evening, sir.
Good evening, PRC, sir.
Good evening, sir.
Lakshmi, good evening.
Hello, good evening. Dr. Jacob John has come.
Secretary sir vantaru and Ponalingam sir vantaru.
Rajendran, DME sir the link சரியா போலையாம்ல கொஞ்சம் பாருங்க.
திருமுருகன் அத மட்டும் பாருங்க, மறுபடியும் ரீசெண்ட் பண்ணுங்க திருமுருகன்.
யார் சார்?
நாராயண பாபு சாருக்கு. DME.
இதோ நீங்க ஏதோ அலோ பண்ணீங்க பாருங்க. ஏனா அவர் ட்ரை
நாராயண பாபு இருக்காங்க பாருங்க. இல்லனா ரீசெண்ட் பண்ணுங்க.
சார் அவரோட இமெயில் ஐடி சார்
நான் போட்டுருக்கு மேல ஆல்ரெடி.
அந்த இமெயில் ஐடி போயிருக்கு. அதோ இருங்க சார், திருப்பி ட்ரை பண்றேன் சார். ஜஸ்ட் கிவ் மீ 1 minute.
பண்ணுங்க டாக்டர் ஸ்ரீனிவாசனுடைய வாட்ஸ்அப் அனுப்பி கொடுங்க.
ஒரே ஒரு செகண்ட் சார், ஜஸ்ட் 1 செகண்ட் சார், ஜஸ்ட் கிவ் மீ 1 minute.
திருமுருகன் அந்த மியூட் பண்ணுங்க. டாக்டர் லட்சுமி சாந்தி ப்ளீஸ் மியூட்.
சார்
அனுப்பிட்டீங்களா?
ஒரே ஒரு செகண்ட் சார், I'm just getting it ready sir.
ஓகே ரைட்.
அது பெரிய லிஸ்ட்னால ஜஸ்ட் தேட வேண்டியதா இருக்கு சார், வேற ஒண்ணும் இல்ல.
உங்களுக்கு அந்த டிஎம்எஸ் ஆபீஸ்ல இருந்து ஒரு 5 அனுப்பி விட்டு இல்லைங்களா லிஸ்ட்? டிஎம்இ அதுல இருக்கும் பாருங்க.
இல்ல அது இதுல இருக்கு சார். ஒரே ஒரு நிமிஷம், நானு ஜஸ்ட்
Again, good evening, sir.
சார் குட் ஈவினிங் சார்.
Good evening, Janani madam.
Good evening, sir.
சார் உங்களுக்கும் ஸ்ரீனிவாசன் சாருக்கும் அந்த இது அனுப்பிச்சிருக்கேன் சார்.
நான் அவருக்கு ஃபார்வர்ட் பண்ணி விட்டேனுங்க.
நான் ஃபார்வர்ட் பண்ணிட்டு
Welcome,
உங்களுக்கு
Dr. Jacob John, sir. Good evening.
Good evening, sir. Good evening.
டாக்டர் ஸ்ரீனிவாசன் சார் அனுப்பியாச்சுங்க. மறுபடியும் சார் ரீசெக் பண்ண சொல்லுங்க.
Jacob John, good evening, sir. Srinivasan
Good
from Pondicherry.
evening. Good evening.
To be a part of this team. And,
Good evening, Dr. Jacob John.
I'm eagerly
Namaskaram.
looking towards hearing from Dr. Neeraj Awasthi. Is like my younger.
அல்ல அதை அப்படியே காப்பி பண்ணி நீங்க மெயில் போங்க. அதை காப்பி பண்ணி நீங்க மெயில் பண்ணுவோம்னா அப்படியே வரும். இல்ல நீங்க செல்போன்ல ஆன் பண்ணிடலாம். இப்ப நீங்க வந்துடலாம்.
சார் மெயில் அனுப்பியிருக்க அவருக்கு மெயில் போட்டிருக்கேன்.
செல்போன் வாங்க.
Sir, Dr. Dhiren Gupta, sir, welcome.
Good afternoon.
From Gangaram Hospital, Delhi.
Schoolmate Dr. Jacob John joined பண்ணிருக்கு.
Dr. Jacob John, sir. Welcome, sir.
Thank you. Thank you.
Yeah.
Good evening, Dr. Sir. Radhakrishnan here, sir. Dr. Jacob John, sir, good evening.
Good evening.
Our health
Yeah,
science,
such a pleasure seeing you.
Yes, sir.
Dr. Bornalingam, sir, also there, sir.
I saw it. I saw him also. Thank you.
No, Dr. Jacob John he's talking about. Anyway.
Four, six ஆயிடுச்சு சார். ஆரம்பிக்கலாமா?
இல்ல அவரு மினிஸ்டர் வரணுங்க, லைன்ல இருக்காரு.
Okay.
He's waiting for minister entering அவ்வளவுதான்.
Professor Jacob John, welcome, sir. Your session is preponed as suggested by you, sir.
Okay. I'll be here from now. Don't worry.
Yes, sir. Thank you, sir. Thank you, sir. Thank you very much.
Thank you. Table dining table.
Good evening, Amal.
Good evening, sir. Good evening,
Good
Ismail,
evening.
sir. Good evening, sir. Rajendran, sir. Good evening, sir.
Good evening, good evening.
Yeah, fix.
அமல் இனிய மாலை வணக்கம்.
Good evening, sir. Malay vanakkam, sir.
அஜேந்திரன் கொஞ்சம் வெயிட் பண்ணுங்க. டிஎம்இ இது ஜாயின் பண்ணிட்டு இருக்காங்க.
வந்துட்டார், மினிஸ்டர் வந்துட்டார். வணக்கம் சார். வணக்கம் சார். வணக்கம் சார். ராஜேந்திரன்.
பரவாயில்ல சார். இல்ல சார், ஆன் பண்ணி ஜூம் ஆல்ரெடி டவுன்லோட் பண்ணிருக்கேன்.
Rajendran, you are unmute yourself. Rajendran.
Before starting EPO, we have to palpate the apex and auscultate to find out where is our apex field. So to know about the cardiac position, I have already described that. So
Dhiren, sir, please mute yourself.
Sir, shall we start, sir?
Enida, sir?
Okay. Okay. Health secretary, sir, start பண்ணலாங்களா?
Definitely start பண்ணலாம்.
Sir, permission minister, sir, start பண்ணலாங்களா? Yeah. Yeah. Good evening to everybody. On behalf of IAPT and say welcome one and all. We'll start with pediatrician prayer. Dr. Gopal Subramaniam, Treasurer IAP. குழந்தை மருத்துவமனையின் இறைஞ்சுதல்.
குழந்தை மருத்துவமனையின் இறைஞ்சுதல் எங்களுக்கு முழுமையாக குணமளிக்கும் திறனை தாரும். நோயினின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பது பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்தன் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும், நல்லவற்றை உள்வாங்கவும், மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal. Now welcome address by me. Our respected Honorable Minister for Health, Medical Education, Family Welfare, through Ma Subramaniam, sir. Respected Purnalingam IAS, Chairman, State Task Force for COVID-19 Management, Dr. J. Radhakrishnan, IAS, Principal Secretary to Government of Tamil Nadu for Health and Family Welfare, our DME, Dr. R. Narayana Babu, DMS, Dr. Gurunathan, DMS ESI, Dr. Ashok Kumar, Dr. Kulandaisamy, State COVID Task Force Committee Member, Director of Public Health, Selva Vinayam, sir, and Dr. Srinivasan, State Nodal Officer, and Pediatric COVID-19 Update CME Convener, Dr. S. Balasubramaniam, our dynamic President, Dr. M. Ismail, President IAP TNSC, Dr. Somasekar, South Zone VP IAP, Dr. Aram Sendil, President 2020, Dr. Ramesh Babu, President 2022, Dr. Gopal Subramaniam, Treasurer, Dr. Ilamurugan, Vice President, Dr. Thirumurugan, Joint Secretary, Central and State EP members, international and national faculties, other dignitaries, and all delegates. On behalf of IAP TNSC, now I welcome a leader of action who understands the value of fitness and has run more than 100 marathons and obtained honorary doctorate by the World Records University for competition. He is a role model and motivation to many youngsters and has handled COVID-19 in an efficient way in a short period of time, and a lawyer by profession, and none other than today's chief guest, our Honorable Minister for Health, Medical Education and Family Welfare, Government of Tamil Nadu, Thri Ma Subramaniam. I welcome you, sir. Next, I welcome a dynamic IAS officer who has done major assignments in central and state government during his tenure. As a Health Secretary of Government of Tamil Nadu, he had achieved unprecedented success by improving drug availability throughout the state by establishing the TNMC. It has been adopted as a model by the World Bank and WHO. Now he is the chairman of State Task Force for COVID-19 Management and today's guest of honor, Mr. Purnalingam IAS. I welcome you, sir. Next, I welcome the person who has been credited for tackling natural and man-made disasters in Tamil Nadu over the years and headed the disaster management team of United Nations Development Program in India. His relief work was widely acclaimed internationally. Former US President Bill Clinton hailed his administrative skills for tsunami relief work in 2005. A humble, hard-working administrator and a man of action, our beloved Principal Secretary to Government of Tamil Nadu for Health and Family Welfare, Dr. J. Radhakrishnan, IAS. I welcome you, sir. I welcome all the IAP TNSC office bearers, Central, State, EB and OB members. I welcome all the renowned international and national faculties and delegates. I once again welcome one and all for this important CME on preparing for third wave pediatric COVID-19 update. Thank you. Now I welcome our dynamic President, Dr. Ismail sir, deliver the presidential address.
Honorable Minister of Health and Medical Education, Thiru Ma Subramaniam sir, Dr. Purnalingam sir, Dr. J. Radhakrishnan sir, DME Narayana Babu sir, DPH and DMS, and our nodal officer Srinivasan sir, South Zone Vice President Somashekar, all the faculties today and all the IAP TNSC members. Good afternoon, all of you. As the President of IAP TNSC, I feel very happy and honored that our minister is there attending this meeting. மாண்புமிகு அமைச்சர் அவர்களுக்கு எங்களுடைய மகிழ்வான பணிவான வணக்கங்கள். முதற்கண் இந்த அரசின் செயல்பாடு குறித்து இந்த கோவிட் தொற்று பெருந்தொற்றினை அழகாகவும் அற்புதமாகவும் மக்களுக்கு நலன் பெறும் வண்ணமும் தமிழக அரசு செயல்பட்டு கொண்டிருக்கிறது. அதில் உங்கள் பங்கு மிகவும் போற்றுதலுக்குரியதாக இருக்கிறது, பாராட்டுதலுக்குரியதாக இருக்கிறது. ஐஏபி டிஎன்எஸ்ஐ உங்கள் சேவைகளை மிகவும் கவனத்துடன் பார்த்து மகிழ்ந்து பாராட்டுகிறது. உங்களுக்கு உறுதுணையாக இந்த இந்திய குழந்தை மருத்துவ சங்கமும் எங்களுக்கும் இந்த அரசினோடு தொடர்பு கொண்டு நாங்களும் சிறப்பாக செயல்பட வேண்டும் என்ற நோக்கத்தில் 19 டிஸ்ட்ரிக்ட் பிரான்ச்சஸ் எங்க கிட்ட இருக்கு சார். அந்த 19 டிஸ்ட்ரிக்ட் பிரான்ச்சஸ்லயும் ஈச் டிஸ்ட்ரிக்ட் பிரான்ச் இஸ் கோயிங் டு ஹேவ் அ கோவிட் செல். அந்த கோவிட் செல்ல ஒரு 5 அஜெண்டா வச்சிருக்கோம் சார். அந்த 5 பாயிண்ட் அஜெண்டா வாட் இஸ் தட் அப்படின்னு சொன்னா, முதற்கண் நாங்கள் எங்கள் மருத்துவர்களை எஸ்பெஷலா பெரிஃபரல் பிராக்டிசிங் பீடியாட்ரிஷியன்ஸ், அதாவது அவங்களுக்கு ஒரு இந்த நுண்ணறிவுகளை ஊட்டும் வண்ணம் கோவிட் பற்றிய விழிப்புணர்வுகளையும் பாடத்திட்டங்களையும் மிஸ்ஸி போன்ற காம்ப்ளிகேஷனுடைய ட்ரீட்மெண்ட் முறைகளையும் பல்வேறு விதமாக அவர்களுக்கு வகுப்பு பயிற்சி வகுப்புகள் எல்லாம் அரசாங்கத்துடன் இணைந்தும் நாங்கள் தனிப்பட்ட முறையிலும் செயலாற்றி கொண்டிருக்கிறோம். 19 டிஸ்ட்ரிக்ட் பிரான்ச்சும் எல்லா பெரிஃபரல் பிராக்டிஷனரையும் ரீச் பண்றது. அது மாத்திரம் இல்ல சார், எங்களுடைய ஜாயிண்ட் செக்ரட்டரி திருமுருகன் அவர்கள் ஒரு ஆப் டெவலப் பண்ணியிருக்காங்க, ஒரு செயலி டெவலப் பண்ணியிருக்காங்க. அந்த செயலி மூலமா எல்லா பிராக்டிஷனருமே ஒரு நொடி பொழுதுல ஒரு டயக்னோஸ் பண்ணி ட்ரீட்மெண்ட் புரோட்டோகால ஈஸியா புரிஞ்சுக்க கொள்ளும்படி இருக்கும். அந்த செயலியை விரைவில் வெளியிட போறோம் சார். அது ரொம்ப பயனுள்ளதாகவும் இருக்கும். உங்களுக்கு அந்த விஷயங்கள் அதோட சாராம்சங்கள் எல்லாம் நாங்கள் அனுப்பி வைக்கிறோம் சார். இரண்டாவது, இந்த அடித்தள கோவிட்ல நம்ம பண்ணணும்னு சொன்னா செவிலியர்களின் பங்கு மிக மகத்தானதாக இருக்கிறது. அந்த வகையிலே தமிழக அரசு செவிலியர்களுக்கு எவ்வளவு ட்ரைனிங் கொடுக்குறாங்கிறது எங்களுக்கு தெரியும். ஆனாலும் தனியார் மருத்துவமனைகளில் இருக்கக்கூடிய செவிலியர்களும் தொலைதூரங்களிலே குக்கிராமங்களிலே பணிபுரியக்கூடிய செவிலியர்களுக்காகவும் இந்த IAPTNSC பயிற்சி வகுப்புகள் எடுத்து ஏறக்குறைய டாக்டர் தங்கவேலு சார் எங்க IAPTNSC மூலமா ஒரு சிறந்த ஒரு பாட வடிவத்தினை எடுத்து நேற்றைய தினம் ஹெல்த் செக்ரட்டரி அவங்க ஆரம்பிச்சு வச்சிருந்தாங்க. இது ஒரு 30,000 நர்சுகளுக்கு வாரந்தோறும் கொண்டு செல்ல இருக்கிறோம் சார். அது வாரத்திற்கு 3 வகுப்புகள் எடுக்க போறோம். பொருளாதார ரீதியாக பல குடும்பங்கள் பாதிக்கப்பட்டிருக்கின்றன. அது மட்டுமல்ல, குழந்தைகள் ஸ்கூலுக்கு போகாம இருக்கிறதுனால ஃப்ரஸ்ட்ரேஷன்ல இருக்காங்க. எஸ்பெஷலி குடும்ப தலைவிகள் தாய்மார்கள் மிகுந்த மன உளைச்சலுக்கு ஆளாயிருக்காங்க. அந்த விஷயத்த IAPTNSC கவனத்துடன் அணுகி இருக்கிறது சார். மென்டல் ஹெல்த் இஷ்யூஸ் அதை நாங்க கவனத்துல கொண்டு ஒவ்வொரு டிஸ்ட்ரிக்ட் பிரான்ச்ல இருந்து எல்லா அந்த குழந்தைகள் பெற்றோர்களுக்கும் சரி, குழந்தைகளுக்கும் சரி, ஆசிரியர்களுக்கும் சரி, இந்த மென்டல் ஹெல்த் இஷ்யூஸ் அட்ரஸ் பண்ணி பயிற்சி வகுப்பிலும் கவுன்சிலிங்களும் நடத்த திட்டமிட்டு இருக்கோம் சார். இது 19 பிரான்ச் மூலமா எல்லாருக்கும் ரீச் பண்ண இருக்கும். 4வது, அரசாங்கத்துடன் இணைந்து இந்த இன்ஃப்ராஸ்ட்ரக்சர் பெட் கோவிட் ரெஜிஸ்ட்ரி மெயின்டைன் பண்ணி ஒரு சுனாமி போல் அலை தாக்கினாலும் அதற்காக தனியார் வசமும் உள்ள படுக்கை வசதிகளை அரசாங்கத்துடன் இணைத்து மாவட்ட ஆட்சியருடன் தொடர்பு கொண்டு IAPTNSC ஒவ்வொரு பிரான்ச்சும் செயல்படும் என்பதை மகிழ்வுடன் உங்களுக்கு நாங்கள் தெரிவித்துக் கொள்கிறோம் சார். லாஸ்ட் அஜெண்டா, ஒரு சைல்டு ஹெல்ப்லைன் டெவலப் பண்ண போறோம். அதே மாதிரி அந்த சைல்டு ஹெல்ப்லைன் நீங்க வச்சிருக்கிற வார் ரூம் மாதிரி எங்க மெம்பர்ஸும் அந்த தனியார் மருத்துவமனைகளுக்கு எல்லா இடத்துலயும் பெட் கிடைப்பதற்காக எல்லா IAPTNSC மருத்துவர்களும் இந்த நேரத்திலே சிறப்பாக செயல்பட உள்ளார்கள் என்பதையும் உங்களிடம் தெரிவித்துக் கொள்கிறோம். சோ இதோட உங்ககிட்ட 2 கோரிக்கையும் வைக்கணும்னு நினைக்கிறோம் சார். IAPTNSC சார்பில் ஒரு கோரிக்கை இந்த வேக்சினேஷன் பத்தி நீங்க கடுமையா உழைச்சிட்டு இருக்கீங்கன்னு எங்களுக்கு தெரியுது. இருந்தாலும் குழந்தைகளுக்கு தடுப்பூசி போடுவதை நாம் கொஞ்சம் அவசரம் காட்ட வேண்டிய நிலையில் இருக்கிறோம். உங்கள் முயற்சியினால் மத்திய அரசிடமிருந்து இந்த வேக்சினை அதிகமாக பெற்று நீங்கள் தர வேண்டும். அப்படி தந்தால் IAPTNSC அரசாங்கத்துடன் இணைந்து உங்களுக்கு எந்த விதையெல்லாம் நாங்கள் உதவ முடியுமோ அந்த வகையிலெல்லாம் நாங்கள் உதவ தயாராக இருக்கிறோம் என்பதை உங்களுக்கு மகிழ்வுடன் தெரிவித்துக் கொள்கிறோம். கடைசியாக ஒரே ஒரு விஷயம், தாய்ப்பால் பற்றியது சார். தாய்ப்பால் பற்றிய ப்ரொபோசல் உங்களுக்கு அனுப்ப இருக்கிறோம். அதையும் நீங்க கவனத்தில் ஈர்க்குமாறு இந்த நேரத்திலே கேட்டுக்கொண்டு வாய்ப்புக்கு நன்றி கூறி உங்கள் சிறப்பான பணியை மேலும் தொடர வேண்டும் என்று கூறி விடைபெறுகிறேன் சார். தேங்க்யூ.
தேங்க்யூ சார். நவ் ஐ வெல்கம் Dr. J. Radhakrishnan, IAS, Secretary to Government of Tamil Nadu, Health and Family Welfare, to deliver keynote address.
A very good evening to everybody. First of all, I thank Indian Academy of Pediatrics, Tamil Nadu State Chapter, for having organized this particular web meeting for preparing for the 3rd wave pediatric COVID-19 update. Always I believe that scientific support to all these issues are very important. I am extremely delighted that for such an important meeting, Honorable Minister Thiru Ma Subramanian Sir, Health and Minister for Medical Education, Health and Family Welfare, is the chief guest, and who himself has been going around to almost today it would be 34th and 35th district, which he is going to personally review various activities along with a team of officials and health department doctors, nurses and all. I welcome him also, and I am equally delighted that Tamil Nadu, which was perhaps the only state after learning perhaps a bitter lesson in the second wave, which Honorable Chief Minister constituted a state task force, and we have this task force headed by one of the most eminent bureaucrats who has led health department, was pioneer in setting up TNMSC, and has also served in the government of India, and also has been an expert in guiding procurement and various activities all over India. He was designated as the task force chairman, along with very competent people who are assisting him, and I'm sure that itself is an indicator that government of Tamil Nadu is not taking anything lightly. And corona, for that purpose, I can say corona வந்து எக்காரணத்தை கொண்டும் நம்ம யாருமே லைட்டா எடுக்க முடியாத ஒரு சூழல்ல நம்ம இருக்கோம். Most respected Dr. M. Ismail, President, Dr. K. Rajendran, Secretary, Dr. Somashekar, Dr. Gopal Subramaniam, other Dr. Kulandai Sami, அப்புறம் DME Dr. Srinivasan, Dr. Narayan Babu, and DME Dr. Gurunathan Sellavinayagam, and Dr. Srinivasan, State Nodal Officer. All the distinguished people who are participating, people I have seen from Gangaram Hospital, all over India they have participated. Most respected Dr. Jacob John and other eminent virologists and other senior people who have joined as panelists and speakers. I'll come directly to the issue. See, now that the third wave is coming or not coming is one debatable point, but one I always have been insisting into the people. Even today morning I went to several areas where I found பல பேர் இன்னமும் நீங்க ஹோட்டல்ல பார்த்தீங்கன்னா கும்பலா தான் இருக்காங்க. பாதுகாப்பு வந்து படிப்படியாக சோஷியல் டிஸ்டன்ஸ்ல பிகஸ்ட் கிரைம் விச் பீப்புள் ஆர் டூயிங் இஸ் ஆன் சோஷியல் டிஸ்டன்சிங். நானே இன்னைக்கு வந்து அந்த ரோட் சைடு ஒரு கோவில்ல பார்த்தேன், ரொம்ப கூட்டமா இந்த பீப்புள் ஆர் கூடு ஊத்திட்டு இருக்காங்க. வித்வுட் நோயிங் தட் unknown to them they are likely to be one of the, that is individual choice. Individual choiceல unlike of course முதல் அலைய போது ரொம்பவே கேர்லெஸ்ஸா இருந்தோம். இப்போ எல்லாருமே மாஸ்க் பெரும்பாலும் ஒரு அளவுக்கு போட்டுக்கிறாங்க, பட் சோஷியல் டிஸ்டன்சிங் இல்லை. ஸோ இது ஒன் ஆஃப் த பிக்கஸ்ட் ஸ்பரிங் ஒன் ஏரியா வேர் இட் கேன் கிரியேட் அ வேவ். செகண்ட் சேலஞ்ச் ஆஃப்கோர்ஸ் இஸ் த லெவல் ஆஃப் வேக்சினேஷன். நமக்கு கிடைக்க போட்டுட்டா கூட இன்னைக்கு வந்து நம்ம ஆல்மோஸ்ட் ஒரு நம்பர்ல 2 crore பண்ணா கூட ஒரு ஃபர்ஸ்ட் டோஸ் வந்து ஒரு 1.5 to 1.6 crore பீப்புள் போட்டிருப்போம். குழந்தைகளுக்கு இல்லை இது வரைக்கும். இப்பதான் பிரெக்னென்ட் உமனுக்கும் லாக்டேஷன் மதர் கொடுக்குறோம். இது செகண்ட். வேக்சினேஷன் இஸ் அதர் ஏரியா விச் கேன் பிரிவென்ட் அ வேவ். நம்ம நிறைய பேருக்கு வேக்சினேஷன் கொடுத்தா அதுதான் எல்லா எக்ஸ்பர்ட்ஸும் சொல்றாங்க, எல்லாரும் சொல்லிட்டு இருக்கோம். அது ரெண்டாவது. மூணாவது நமக்கு தட் இஸ் த $1 million கொஸ்டின் இஸ் அன்லைக் மர்ஸ், சார்ஸ் ஆர் த ஏற்கனவே இருக்கிற கொரோனா, இந்த கொரோனா வந்து அவ்வப்பொழுது உருமாறுறது முக்கியம் இல்லை. அந்த உருமாறும் போது அந்த இட் இஸ் கோயிங் பியாண்ட் தி our capacity to produce நமக்கு ஆன்டிபாடி இருக்கோ இல்லையோ, டக்குன்னு என்ன வேகமா பரவுறது, பழைய வேக்சின் பிரேக் த்ரூ கேசஸ் இருக்கு. இட் இஸ் ஆல்வேஸ் நமக்கு ஒரு சர்ப்ரைஸ் கொடுத்துட்டே இருக்கு. இந்த பர்டிகுலர் COVID-19 ஓட வேரியன்ட்ஸ் வந்து they are creating surprises. நம்ம எப்பவுமே நினைக்கும் இட் கேன் கோ இன்டு டம்மி, இதா போய் அப்படியே மறைஞ்சிடுமா, ஆகாம இட் இஸ் ஒன்லி கிரியேட்டிங் சர்ப்ரைஸ். இதுதான் நம்ம ஈகோ சிஸ்டம். அந்த ஈகோ சிஸ்டம்ல நம்ம கோல் என்ன? நமக்கு இப்போ எல்லாரும் என்ன சொல்றாங்க, மல்டி சிஸ்டம் இன்ஃப்ளமேட்டரி சிண்ட்ரோம் ஏற்கனவே சில கேசஸ் இருந்தது. நமக்கு இப்போ பீடியாட்ரிக்னு நமக்கு அதிகாரப்பூர்வமா சொல்லாட்டா கூட கேன் வி பி கேர்லெஸ்? Even today I am telling you, second wave maximum deaths were for obese people, those with sugar and also diabetes, apart from many other things. But pediatric, what is the challenge? I personally feel ரொம்ப பச்சிலம் குழந்தையும் இருக்காங்க, நியோனேட்டல் பேபிஸும் இருக்காங்க. 600 grams to 100 grams 1 kg பிறந்த அந்த மாதிரி பேபிஸையும் நீங்க ட்ரீட் பண்றீங்க நியோனேட்டாலஜிஸ்ட் எல்லாம். அதே மாதிரி ஒரு 100 கிராம் உள்ள ஒபேஸ் பேபியும் நீ 100 kg உள்ள ஒபேஸ் பேபி. ஸோ வைட் வேரியேஷன். Second is many of the doctors, நம்ம தமிழ்நாட்டில் எப்பவுமே சொல்லிக்கிறோம் நிறைய டாக்டர் இருக்காங்க, we have got so many doctors, so many nurses and all, but pediatric cases need, I myself am a veterinarian and a postgraduate in genetics. I myself feel the challenges which we feel, the similar challenges. It doesn't speak. A baby will not speak. Children particular, of course, children beyond 4 or 5 years, they will speak. So there are multivarious challenges. Doctors may be trained, but they may not be trained enough to put an intubation. properly. Nurses may be trained. The earlier cases, and again, when you look at, despite our claims for having maximum facilities, we need to upgrade it and we need to increase. Even in Tamil Nadu, what we find is, one is a number, but treatable beds is the issue. It is very easy to, we can keep telling 1,70,000 beds, so many oxygen beds, so many ICUs, but how many are available for treatment? That is one critical thing. Similarly, for pediatric beds, how many we have earmarked? I am very, very happy our Honorable Minister will share with you that from Namakkal to Tiruvarur to Nagapattinam to Mayiladuthurai, everywhere, because of your pediatricians' efforts, and also the task force has been forewarning us about the challenges. People are creating more and more PICUs, pediatric intensive care units. We have been creating ICUs, but will they be sufficient? The second wave was a pointer that in COVID, we just cannot. If we plan well, probably we may never have a wave, or even if it is a wave, it will be a very small wave. But if we don't plan well, we'll be caught in surprises. The next challenge which we face, which I feel all of you should know, is the training and transferring the skill. Many deaths probably in May and June could have been prevented if we had little bit. I'm not talking only about Tamil Nadu. I'm talking very frankly that all over India, if you look at the peaking of deaths, both COVID and non-COVID, which happened in May and June, is a pointer that despite our best facilities, we get overwhelmed. We should not get overwhelmed with regard to the number of cases which we can handle. That is the planning which I think the task force has been pushing us to keep working. On the other hand, it is very easy to create a hardware. The software, that the brilliant doctors which you have, unless you translate the skills to the nurses and also train the other regular doctors. If you look at PHC level, how do you catch the cases? I always recall the kind of contribution IAP made for dengue management. Namman, the entire death rate, 2012, it was a shock. But 2017 onwards, even though dengue cases were there, the clinical protocol which you arrived, looking at hematocrit values, looking not just at platelet values, looking at 20% when dengue shock syndrome will occur, when dengue therapy, breathlessness come when it gets absorbed. The minuteness with which pediatricians guided us, that is the challenge which you will have. The other challenge which you are going to have is to get the immunoglobulins. That is the one which is very to get last time, just like remdesivir, or for that matter mucormycosis for amphotericin B, the challenges which we have even now, it is centrally controlled. So we have to keep planning. One is on prevention, another is on treatment. I can assure you that government of Tamil Nadu, Honorable Chief Minister, is very particular that we should do it in a very systematic way. That is why our task force committees regularly, not only as an oversight, as a guide, it has been showing us the mirror that what all things we have to do. We also have an expert group. All of us are concerned, but only thing at the cutting edge level I would request is, ultimately when a spike or a cluster comes, or if pediatric cases increase, it is our job to ensure that the mortality is not there and prevention is taken care of. I am sure in your safe hands that training which should be done in a regularity, and we enlist training of trainers so that it can be spread out, can happen. I thank all of you, and also thank the panel which has been brought together today, and also the various lectures you have kept. I am sure we will get a lot of learnings from your thing based on your recommendation. We will also bring it to the knowledge of task force, and as secretary, it is my duty to, with our Honorable Minister, to bring it to the knowledge of Honorable Chief Minister and take necessary further action as would be required in such cases. Last but not, I would like to say that even now we all should keep on spreading the message that we have to be humble. The moment cases come down, everybody thinks that we have won over. That is not the case. We still have a long way to go. COVID is throwing surprises. So only humility and real work will see us through. If we just think that one good statement here and there could see us through, I am telling you as secretary, COVID has always hit back at any state or any individual or any person, whether in our state or other state or throughout the world, claims that they have done everything and they are safe. it ensures that they have to eat the humble pie. We have always been very conservative in Tamil Nadu. We work very hard and we'll be very sincere to hear your recommendations based on your various meetings and this COVID update. Thank you one and all, and I wish all the speakers all the best. Thank you.
Thank you, sir. Now I request guest of honor, Mr. R. Purnalingam, IAS, formerly Health Secretary, Government of Tamil Nadu, Chairman, State Task Force COVID-19 Management to speak.
Honorable, am I audible?
Yeah, audible, sir.
Honorable
yes, sir.
Minister for Health, the President of the Pediatric Association, the Dynamic Secretary of the Association, and other office bearers of the association, my good friend and the Dynamic Health Secretary, Dr. Radhakrishnan, and other colleagues and doctors. I would like to first of all thank you for inviting me for this excellent training program. And as you all know, the Tamil Nadu government is very keen that we handle the COVID third wave in a very efficient and orderly manner with the least amount of problems for the public, least amount of deaths, least amount of severe infection, etc. And as Dr. Radhakrishnan himself said, we know the public and they are free. It's a very democratic country. They don't follow the rules. Only in Chennai, I find the most people don't wear even helmets. So it is a great task for us to make them wear masks. So it's difficult, given that constraint, how well we handle this COVID third wave. In fact, I had a very good interaction with the pediatric doctors and associations representatives about 10-15 days back. They opened at least my eyes that this could be a problem for pediatric cases. And they mentioned about our need for training, planning for beds, and also for drugs. Then we put it as a kind of an action point in our program. And they offered to help us in training the doctors. Some of the doctors told us very clearly they need training. I was a bit surprised about it. How to handle COVID among children, they wanted to be trained. And I think Dr. Rajendran has taken the initiative, and the government has also cooperated. And my good friend, Dr. Radhakrishnan, has taken our recommendation so seriously that Minister has also come, and this training program is being organized. We have requested him to organize similar training programs in 11 areas which are necessary for COVID, not only for pediatricians, diabetologists, cardiologists, etc. 11 areas we have spelled it out. He has also agreed. Here is a government which is on the move, which is willing to take your help and move forward. Two more things which the government has done recently, I would like to give them credit and bring it to your notice, is that we have completed a zero survey in the entire state, and I completed it about a few days back. They are in the process of preparing the report. This report will give us some indication about the likely severity of the COVID third wave. Experts like Dr. Jacob John, Dr. Jayaprakash Mulayal, all of them are looking at it. Even National Institute of Epidemiology Director is also looking at it. We will get some light into how the third wave is likely to be, how intense it will be, how we can handle it. Another thing is, as the Health Secretary remarked, COVID has a lot of surprises. We have variants. Suddenly Alpha, then Delta, now the Beta, the Delta, and then now Lambda is being talked about. Whether we will have surprises. One of the problems was genome sequencing. We have not been able to do it very fast in the past. Now Dr. Radhakrishnan has taken the initiative to get it done quickly. Every month, the intention is to do the genome sequencing survey in the entire state with 95% accuracy, which is needed for any such survey, in order that we can catch a variant very quickly, in about, say, let us say 10 days, instead of waiting for 2 months or 3 months. If we can catch the mutation quickly, we can take effective steps to stop its spread from that area. That also the state government has taken. And I will be failing in my duty if I don't express my thanks to the Honorable Minister and the Honorable Chief Minister and the Government of Tamil Nadu, and also particularly to Dr. Radhakrishnan, Health Secretary, for helping us to do our job as a task force very efficiently, listening to our suggestions in a very impassioned way, not in a bad way. Particularly Radhakrishnan thinks that it is a mirror. He calls us a mirror. And then we show the true picture to them. As we see it, they take it in the light, he takes it in the light spirit. And we are moving forward. I can assure you this is the way in which we are moving forward. I am sure that COVID will run away from our states and go to other states. 3, they will think that the state is so well prepared with pediatricians and doctors and health department, so well prepared that think that there is no point in us wasting our time in Tamil Nadu and may go away to other states. I hope it happens. I once again thank the Pediatric Association for giving me this opportunity to interact with you. Thank you. Thank you very much.
Thank you, sir. Now I request through Ma Subramanian, Honorable Minister for Health and Medical Education, Family Welfare, Government of Tamil Nadu, to deliver Chief Guest Address on the inauguration of COVID CME.
இந்திய குழந்தை மருத்துவ குழுமத்தின் சார்பில் நடைபெற்றுக் கொண்டிருக்கிற இந்த நிகழ்வில் பங்கேற்று சிறப்பித்திருக்கிற பெருமதிப்பிற்குரிய முன்னாள் சுகாதாரத்துறையின் செயலாளர் அவர்களே, இந்நாள் துறையின் செயலாளர் அவர்களே, வருகை தந்து சிறப்பித்துக் கொண்டிருக்கிற 600க்கும் மேற்பட்ட மருத்துவர் பெருமக்களே, இந்த அமைப்பின் ஆற்றல் மிக்க நிர்வாகிகளே, உங்கள் அத்துணை பேருக்கும் முதற்கண் என்னுடைய நன்றி கலந்த வணக்கத்தினை தெரிவித்துக் கொள்கின்றேன். இந்த நிகழ்வின் நோக்கம் குறித்தான செய்தியினை தலைமை பொறுப்பேற்ற மரியாதைக்குரிய மருத்துவர்களும் மரியாதைக்குரிய துறையின் செயலாளரும் முன்னாள் செயலாளரும் மிக சிறப்பாகவே எடுத்துச் சொல்லியிருக்கிறார்கள். கொரோனா பேரிடரிலிருந்து குழந்தைகளை காப்பதற்கான ஒரு அற்புதமான ஒரு நிகழ்வு இது. துறையின் செயலாளர் சொன்னதை போல இது வருமா வராதா என்கின்ற சர்ச்சை இருந்து கொண்டிருந்தாலும் எய்ம்ஸ் மருத்துவமனையை சேர்ந்த மருத்துவ வல்லுநர்கள் இது யூகம்தான், பெரிய அளவில் உறுதிப்படுத்தப்பட்ட செய்தி அல்ல என்கின்ற விஷயத்தை சொன்னாலும் கூட மாண்புமிகு தமிழக முதல்வர் அவர்கள் வந்தால் முதல் அலைக்கும் 2ஆம் அலைக்குமான அந்த நிலையினை நாம் பார்த்தோம். முதல் அலையின் போது சொல்லப்பட்டது என்பது 2வது அலை வராது என்கின்ற அந்த உறுதியோடு இருந்த காரணத்தினால்தான் 2வது அலைக்கான அந்த கட்டமைப்பை ஏற்படுத்துவதில் சற்று சுணக்கம் ஏற்பட்டது. அதன் விளைவாக நாம் அனுபவித்த கஷ்டங்கள் கொஞ்சம் நெஞ்சம் அல்ல. எனவே அந்த மாதிரியான சூழல் வந்துவிடக் கூடாது என்பதற்காகத்தான் மாண்புமிகு தமிழக முதல்வர் அவர்கள் இந்த துறைக்கு இட்ட கட்டளை என்பது மாவட்ட மருத்துவமனைகளில் இருக்கிற அனைத்து அரசு மருத்துவமனைகளிலும், குறிப்பாக சீமாங் அமைந்திருக்கிற எல்லா பகுதிகளிலும் இந்த கூடுதல் படுக்கைகள், அதுவும் குறிப்பாக ஓட்டு வசதியுடன் கூடிய படுக்கைகள், அதேபோல் அந்த அதிதீவிர சிகிச்சை பிரிவுகள், குழந்தைகளுக்கான கொரோனா தீவிர சிகிச்சை பிரிவுகளை அமைத்திட வேண்டும் என்று அறிவுறுத்தினார்கள். அந்த வகையில் அறிவுறுத்திய 2 நாட்களில் நானும் துறையின் செயலாளரும் நாமக்கல் சென்றிருந்த போது அந்த நாமக்கல்லில் கொரோனா சிறப்பு சிகிச்சை வார்டு ஒன்றினை காட்டி, அதேபோல் தீவிர சிகிச்சை பிரிவு வார்டினை ஒன்றையும் அந்த கல்லூரி முதல்வர் காட்டினார்கள். உண்மையிலேயே மகிழ்ச்சியாக இருந்தது. இதே போன்றது ஒரு கட்டமைப்பை எல்லா இடங்களிலேயும் நிறுவிட வேண்டும் என்று சொல்லி தொடர்ந்து நாங்கள் செல்லுகிற இடங்களிலெல்லாம் அது இப்போது நிறுவப்பட்டு திறந்து வைக்கப்பட்டுக் கொண்டிருக்கிறது. சமீபத்தில் திடீரென்று ஒரு நாள் ஒரு 12 மணிக்கு மாண்புமிகு முதல்வர் அலுவலகத்திலிருந்து ஒரு தொலைபேசி எண், நீங்கள் எந்த மாதிரியான இந்த குழந்தைகள் சிறப்பு சிகிச்சைக்கு, கொரோனா சிறப்பு சிகிச்சைக்கு முன்னெச்சரிக்கை நடவடிக்கையாக எந்த மாதிரியான நடவடிக்கை எடுத்திருக்கிறீர்கள் என்பதை அறிய வேண்டும் என்று முதலமைச்சர் விரும்புகிறார். எங்கேயாவது ஒரு மருத்துவமனைக்கு சென்று பார்க்க வேண்டும் என்று சொன்னார்கள். சொன்ன அரை மணி நேரத்தில் கிளம்பி விட்டார். அந்த வகையில் எழும்பூரில் இருக்கிற குழந்தைகள் நல அரசு மருத்துவமனையில் ஏற்கனவே அங்கு திட்டமிடப்பட்டு அங்கே வைக்கப்பட்ட ஏற்பாடு செய்யப்பட்ட 250 குழந்தைகளுக்கான இந்த கொரோனா சிகிச்சை வார்டை மாண்புமிகு முதல்வர் பார்த்து மிகுந்த அளவில் மகிழ்ச்சி அடைந்தார். அது அனைத்துமே 250 படுக்கைகளுமே வெண்டிலேட்டர் மற்றும் ஆக்சிஜன் வசதியுடன் கூடிய படுக்கைகளாக இருப்பதை பார்த்து பிரமித்து போனார். அந்த வகையில் தான் இன்றைக்கு எல்லா மருத்துவமனைகளிலும் அதற்கான ஏற்பாடு செய்யப்பட்டிருப்பதை நீங்கள் பலர் அறிவீர்கள். அந்த வகையில் இன்றைக்கு தொடர்ந்து நாங்கள் செல்லுகிற இடங்களில் எல்லாம் ஏறத்தாழ 38 மாவட்டங்களில் 33 மாவட்டங்களுக்கு நேரடியாக கள ஆய்வுக்கு சென்றிருக்கிறோம். ஆய்வின் போது வெறும் மாவட்ட ஆட்சித்தலைவர் அலுவலகங்களில் உட்கார்ந்து மாவட்ட ஆட்சித்தலைவர்கள் சொல்லுகிற குறிப்புகளை மட்டுமே பார்த்துவிட்டு வருவதல்ல, கிராமங்களுக்கும் சென்று வேக்சினேஷன் சென்டர்களுக்கும் சென்று லாக்டவுன் ஏரியாக்களுக்கும் சென்று அதேபோல் ஒரு மாவட்ட அரசு தலைமை மருத்துவமனைக்கு வந்தால் அங்கே குழந்தைகள் சிகிச்சை பிரிவு அமைக்கப்பட்டிருக்கிறதா, கொரோனாவுக்கு பிந்தைய நலவாழ்வு மையம் அமைக்கப்பட்டிருக்கிறதா, இந்த மாதிரியான எல்லா விஷயங்களையும் ஆய்வு செய்ததுக்குத்தான் வருகிறோம். இன்று இரவு கூட நான் கிருஷ்ணகிரிக்கு போய் தங்கி நாளை கிருஷ்ணகிரியும் நாளை மறுநாளும் தர்மபுரியிலையும் இது போன்ற ஆய்வுகளை மேற்கொள்ளவிருக்கிறோம். அடுத்த வாரத்தில் அரியலூர், பெரம்பலூர், கரூர் என்று முடிக்கும் போது தமிழகத்தில் இருக்கிற 38 மாவட்டங்களிலும் இது போன்ற ஆய்வுகளை மேற்கொண்டு வருகிறோம். எல்லா மாவட்டங்களிலும் இந்த குழந்தைகளுக்கான கொரோனா சிகிச்சை மையங்கள் கட்டாயம் என்று சொல்லி இன்றைக்கு எல்லா மாவட்டங்களிலும் அது அமைக்கப்பட்டு கொண்டிருக்கிறது. இங்கே பேசிய இந்த அமைப்பின் சார்பில் எதிர்காலத்தில் இந்த வார் ரூமை போல சைல்டு ஹெல்த் கேர் அமைக்கப்படும் என்கின்ற ஒரு அற்புதமான செய்தியை சொன்னீர்கள். உண்மையிலேயே மகிழ்ச்சியான ஒரு விஷயம். அந்த வகையில் இன்றைக்கு குழந்தைகள் நல மருத்துவமனைக்கு நேற்றைக்கு கூட நான் ஒரு ஆய்வுக்கு சென்றிருந்தேன். அங்கே சென்று நானும் துறையின் செயலாளரும் துறையின் அலுவலர்களும் இந்த நியூமோகோக்கல் கான்ஜுகேட் என்று சொல்லக்கூடிய அந்த வேக்சின் தடுப்பூசி போடும் பணியினை இங்கே சென்னையில் தொடங்கி வைத்தோம். ஏற்கனவே ஒரு 10 நாட்களுக்கு முன்னால் திருவள்ளூரில் அந்த பணியினை தொடங்கி வைத்தோம். அது இந்தியா முழுவதிலும் 21 மாநிலங்களில் அந்த தடுப்பூசி போடும் பணி நடைபெற்றுக் கொண்டிருந்தாலும் தமிழகத்தில் சற்று காலதாமதமாக தொடங்கி இருக்கிறது. அது ஒரு 10 நாட்களுக்கு முன்னாலேயே திருவள்ளூரில் தொடங்கி வைத்து அது எல்லா மாவட்டங்களிலும் இப்போது அந்த தடுப்பூசி போடும் பணி நடைபெற்றுக் கொண்டிருக்கிறது. 5 வயதுக்குள்ளான குழந்தைகளுக்கு போடப்படுகிற அந்த தடுப்பூசியை பொறுத்தவரை 1.5 மாதத்திற்கு ஒரு முறை, 3.5 மாதத்திற்கு ஒரு முறை, 9 மாதத்திற்கு ஒரு முறை என்று போடப்படுவதாக இன்றைக்கு அறிவிக்கப்பட்டிருக்கிறது. அதையும் கூட துறையின் சார்பில் சொல்லி இருக்கிறோம். ஏறத்தாழ 9,23,000 குழந்தைகள் தமிழகத்தில் அந்த தடுப்பூசி போட்டுக்கொள்ள வேண்டும் என்கின்ற நிலை இருக்கிற போது இந்த குழந்தைகளுக்கு தடுப்பூசி போடும் அந்த முதல் தடுப்பூசி, 2வது தடுப்பூசி, 3வது தடுப்பூசி எந்தெந்த காலகட்டங்களில் போடப்படுகிறது என்கின்ற விவரங்களை SMS மூலம் தாய்மார்களுக்கு தெரிவிக்க வேண்டும் என்கின்ற செய்தியினை சொல்லியிருக்கிறோம். அதற்கான ஏற்பாடுகள் நடைபெற்றுக் கொண்டிருக்கிறது. அண்மையிலே கூட நானும் சேப்பாக்கம் தொகுதியின் சட்டமன்ற உறுப்பினர் திரு உதயநிதி சார் அவர்களும் திட்டக்குடியில் பெண்ணாடம் பகுதிக்கு ஒரு மருத்துவமனை ஒன்று, கோவிட் கேர் சென்டர் ஒன்று திறப்பதற்காக சென்றிருந்தோம். அங்கே போன போதுதான் இரவு ஒரு தகவல் சொல்லப்பட்டது. ICMR சார்பில் இந்த கர்ப்பிணி தாய்மார்களுக்கு தடுப்பூசி போட்டுக் கொள்வதில் தடை இல்லை என்கின்ற வகையிலான ஒரு செய்தி இரவு சொல்லப்பட்டது. சொன்ன உடனே மறுநாள் காலையில் 9 மணிக்கெல்லாம் இந்த பெண்ணாடம் பகுதியில் அந்த கர்ப்பிணி தாய்மார்களுக்கான தடுப்பூசி போடும் பணியினை தொடங்கி வைத்தோம். இந்த தொடங்கி இந்த ஒரு 15-20 நாட்களில் இதுவரை 1,04,987 கர்ப்பிணி தாய்மார்களுக்கு தடுப்பூசி போடப்பட்டிருக்கிறது. அதே போல் பாலூட்டும் தாய்மார்களுக்கு தடுப்பூசி என்கின்ற வகையில் இதுவரை 94,993 பேருக்கு அந்த தடுப்பூசிகள் போடப்பட்டிருக்கிறது. அது மட்டுமல்ல, நேற்றைக்கு நான் இந்த எழும்பூர் நல மருத்துவமனைக்கு சென்றபோது இசக்கியம்மாள் என்கின்ற ஒரு 5 வயது குழந்தை 4 மாதங்களுக்கு முன்னால் ப்ளீச்சிங் பவுடரை சாப்பிட்டு விட்டு உணவு குழாய் முழுவதும் பாதிக்கப்பட்ட நிலையில் ஒரு 6-6.5 கிலோ எடையுடன் தென்காசியில் மருத்துவம் பார்க்க இயலாமல் சென்னை மருத்துவமனைக்கு அனுப்பி வைத்திருந்தார்கள். அந்த குழந்தையை நம்முடைய எழும்பூர் குழந்தை நல மருத்துவர்கள் மிக சிறப்பாக கண்காணித்து அதற்கு வயிற்றில் ஒரு துளையிட்டு அந்த துளையின் மூலம் உணவு செலுத்துகிற பணியினை செலுத்தி ஒரு 10 நாட்களிலேயே 1.5 கிலோ எடை கூடியுள்ள அளவுக்கான ஒரு மகத்தான சிகிச்சை செய்திருக்கிறார்கள். ஒரு மகிழ்ச்சியான விஷயம். நிச்சயம் அந்த குழந்தை உயிர் பிழைத்துக் கொள்ளும் என்கின்ற அளவில் ஒரு நம்பிக்கை இருக்கிறது. அந்த வகையில் இன்றைக்கு நம்முடைய குழந்தை நல மருத்துவர்கள், அந்த அரசு மருத்துவர்கள் மிக சிறப்பாகவே தங்களுடைய பங்களிப்பை செய்து கொண்டிருக்கிறார்கள். மாண்புமிகு முதல்வர் அவர்களுடைய அறிவுரைப்படி அந்த குழந்தைகளுக்கான கொரோனா சிகிச்சை மையங்கள் எல்லா இடங்களிலும் அமைக்கும் பணிகளும் நடைபெற்றுக் கொண்டிருக்கிறது. அதோடு இங்கே இப்போது சொல்லும் போது 2 கோரிக்கைகள் என்று சொன்னார்கள். அந்த நேரத்தில் தான் இணையத்தில் அந்த உங்களுடைய பேச்சு சரியாக கேட்க இயலாமல் போய்விட்டது. எனவே அந்த 2 கோரிக்கைகள் அநேகமாக வேக்சின் தடுப்பூசி போடுகிற அந்த பணி குறித்தான் சொன்னீர்கள் என்று நினைக்கிறேன். நான் இந்த நிகழ்ச்சி முடிந்தவுடன் உங்களிடத்தில் தொலைபேசியில் அந்த கோரிக்கைகள் சம்பந்தமாக கேட்டு தெரிந்து கொள்கிறேன். தெரிந்து கொண்டதற்கு பிறகு என்ன செய்ய முடியும் என்பதை நிச்சயம் துறையின் செயலாளர் போன்ற உயர் அலுவலர்களுடன் உட்கார்ந்து பேசி அதை செய்வதற்கு தயாராக இருக்கிறோம். நிச்சயம் நம்முடைய தமிழகத்தை பொறுத்தவரை இன்றைக்கு இந்த சீமாங் கட்டடம் தெரியும் உங்களுக்கு, எல்லா இடங்களிலேயும் மாவட்ட தலைநகரங்களில் கட்டப்பட்டுக் கொண்டிருக்கிறது. மிக சிறப்பான கட்டமைப்புடன் கூடிய அந்த கட்டடங்களை மாண்புமிகு தமிழக முதல்வரிடத்தில் சொன்னோம். திருவாரூரில் உள்ள கட்டடம் அந்த பணி நிறைவடைகிற தருவாயில் இருக்கிறது, நீங்கள் அதை திறந்து வைக்க வேண்டும் என்று சொன்னோம். அவரே நேரடியாக வந்து அந்த கட்டிடத்தை திறந்து வைத்ததோடு மட்டுமல்லாமல் அந்த குழந்தைகளுக்கான சிறப்பு மருத்துவமனையில் இருக்கிற எல்லா வசதிகளையும் ஒரு 4 அடுக்குகளை கொண்ட அந்த மாடிக்கு எல்லா மாடிக்கும் நடந்தே வந்து ஒவ்வொரு அறையாக வந்து பார்த்து ஒரு மகிழ்ச்சி அடைந்தார்கள். அந்த அளவுக்கு இன்றைக்கு அவரும் இந்த குழந்தைகள் நல மருத்துவமனையில் செய்யப்பட்டு கொண்டிருக்கிற அந்த விஷயங்களை முன்னெடுப்புகளை மிக வேகமாக பார்த்து பாராட்டுகிறார்கள். அந்த அளவுக்கு நமக்கு ஒரு நல்ல நிர்வாகம் என்கின்ற வகையில் நம்முடைய மாண்புமிகு தமிழக முதல்வர் அவர்கள் இந்த துறைக்கு பல யோசனைகளை சொல்வதும் ஆலோசனைகளை சொல்வதுமாக இருந்து கொண்டிருக்கிறார்கள். பெருமதிப்பிற்குரிய திரு பூர்ணலிங்கம் சார் அவர்களை நான் நேரில் சந்தித்த போது கூட அவர் பல்வேறு விஷயங்களை எடுத்து சொன்னார்கள். கொரோனா காலத்தில் நாம் மேற்கொள்ளப்பட வேண்டிய அந்த விஷயங்கள் அவர் குறித்து நான் ஏற்கனவே அறிந்திருக்கிறேன். ஏற்கனவே ஓரிரு முறை தொலைபேசியில் பேசியிருக்கிறேன் என்றாலும் அவரிடத்தில் நேரடியாக கலந்துரையாட போது அவர் கொடுத்த அந்த தகவல்கள் என்பது இந்த கொரோனா காலகட்டத்தில் நாம் இந்த பேரிடரிலிருந்து மீண்டு வருவதற்கான பல முயற்சிகளை அவர் எடுத்து சொன்ன விதம் அவருடைய அனுபவத்தை பறைசாற்றியது. அந்த அளவுக்கான எல்லோருடைய கருத்துக்களும் தமிழக அரசை நல்ல முறையில் இந்த விஷயத்தில் வழி நடத்துவதற்கு உறுதுணையாக இருந்து கொண்டிருக்கிறது. அந்த வகையில் எதிர்காலத்திலும் இந்த குழந்தைகளை கொரோனா என்கின்ற இந்த 3வது அலை வந்தாலும் கூட அதிலிருந்து குழந்தைகளை காப்பதற்கு எல்லோருடைய ஆலோசனைகளையும் கருத்துக்களையும் கேட்டு பெற்று இந்த துறை சிறப்பாக செயல்பட்டு அதிலிருந்தும் மீண்டு வரும் என்கின்ற ஒரு மகிழ்ச்சியான விஷயத்தை தெரிவித்துக் கொண்டதில் பெருமைப்படுகிறேன். அண்மையில் கூட திரு பூர்ணலிங்கம் சார் அவர்கள் சொன்னதை போல இப்போ டெல்டா வைரஸ், ஆல்பா என்று ஏகப்பட்ட அந்த வைரஸ்களின் உருமாற்றம் என்பது பெரிய அளவில் இருந்து கொண்டே இருக்கிறது. இது 3வது அலை மட்டுமா பிரத்யேகமாக இந்த குழந்தைகளை தாக்குமா என்பது ஒரு சந்தேகத்திற்குரிய ஒரு விஷயம்தான் என்றாலும், ஆனால் 2வது அலையில் இது தாக்காமல் போயிருக்கிறதா என்றால் 2ஆம் அலையிலும் குழந்தைகள் ஏராளமான பேர் பாதிக்கப்பட்டிருக்கிறார்கள். ஏராளமான குழந்தைகள் இந்த பாதிப்புக்குள்ளாகி இருக்கிறார்கள். ஏராளமான இறப்புகளும் குழந்தைகள் விஷயத்தில் நடந்திருக்கிறது. இதை நாம் மறுப்பதற்கில்லை. அண்மையிலே கூட உத்தரமேரூர் அந்த ஆதரவற்ற சிறார்கள் மையத்தில் ஒரு 103 பேர் இருக்கிற இடத்தில் 40 பேருக்கு ஒரே நேரத்தில் அந்த பாசிட்டிவ் வந்தது என்று சொன்னார். ஒரு இடத்தில் 40 பேருக்கு ஒரே இடத்தில் பாசிட்டிவ் என்றால் நிச்சயம் அது முதல் அலை கொரோனாவில் அந்த அளவுக்கு வேகமாக ஒரே இடத்தில் 40 பேரை பாதித்திருக்க வாய்ப்பில்லை. அந்த அளவுக்கான ஸ்பீடி ஸ்ப்ரெட் என்றெல்லாம் அதை சொல்ல முடியாது. அது உடனடியாக அது 42 குழந்தைகள், 42 அல்லது 43 குழந்தைகள் காஞ்சிபுரம் மருத்துவமனையில் அனுமதிக்கப்பட்டிருக்கிறார்கள் என்று சொன்னவுடன் நானும் துறையின் செயலாளரும் நேரடியாக சென்று அந்த குழந்தைகளை பார்த்து மாவட்ட ஆட்சித்தலைவருக்கும் இந்த கல்லூரியின் அந்த மருத்துவமனையின் உயர் அலுவலர்களுக்கும் சொல்லி அதை அவர்களுடைய அந்த மருத்துவ சோதனைகளை சிறப்பாக செய்ய சொல்லி தொடர்ந்து கண்காணித்தோம். எல்லா குழந்தைகளும் நலம் பெற்று வீடு திரும்பினார்கள், ஒரு மகிழ்ச்சியான விஷயம். ஆனால் அதே நேரத்தில் அன்றைக்கு நானும் செயலாளரும் சொல்லிவிட்டு வந்தது, அந்த குழந்தைகளுக்கான சாம்பிள் மாதிரியை எடுத்து இது என்ன பாசிட்டிவ் இது வந்து கண்டுபிடிக்கணும் அப்படின்ற மாதிரி சொல்லிட்டு வந்தோம். அதுக்கப்புறமா தான் அதுல ரிசல்ட் வந்ததுக்கு அப்புறம் தெரிஞ்சது அதுல 32 குழந்தைகளுக்கு டெல்டா வைரஸ் பாதித்திருக்கிறது என்கின்ற ஒரு விஷயம் தெரிய வந்தது. எனவே டெல்டா பிளஸ்மே ஏற்கனவே ஒரு 10 பேருக்கு தமிழகத்தில் ஒரு 1000 சாம்பிள் அனுப்பியதில் ஒரு 10 பேருக்கு வந்து போயிருக்கிறது. அதில் ஒருவர் இறந்த உடலை எடுத்த மாதிரி என்பதால் அந்த ஒருவர் தவிர்த்து மீது 9 பேர் நலமுடன் இருக்கிறார்கள். அவரை சார்ந்தவர்களும் இன்றைக்கு பரிசோதனை செய்து கொண்டது நலமாகவே இருக்கிறார்கள், சகஜ வாழ்க்கைக்கு திரும்பி இருக்கிறார்கள். எனவே டெல்டாவும் வந்து போயிருக்கிறது, டெல்டா பிளஸும் வந்து போயிருக்கிறது. இந்த டெல்டா குழந்தைகளை பெரிதாக தாக்கியும் இருக்கிறது என்பதை இந்த நிகழ்வுகள் மூலம் நாம் தெரிந்து கொள்ளலாம். எது எப்படி இருந்தாலும் முன்னெச்சரிக்கை என்பது அவசியம். அந்த அவசியத்தின் அடிப்படையில் இன்றைக்கு ஏராளமான பணிகள் இன்றைக்கு செய்யப்பட்டிருக்கிறது. நிச்சயம் தமிழக அரசு இதிலிருந்து மீண்டு வரும், இதையும் வென்றெடுக்கும். உங்களின் உறுதுணையோடு. வாய்ப்புக்கு நன்றி, வணக்கம்.
நன்றி செயல்திறன் மிக்க மாண்புமிகு அமைச்சர் அவர்களே. நாங்களும் எங்களுடைய இந்திய குழந்தைகள் மருத்துவர் சங்கமும் உங்களுக்கு உறுதுணையாக இருப்போம் என்று உறுதி கூறுகிறேன். Because of want of time, now I request Dr. S. Balasubramanian, Medical Director and HOD, KKCT Hospital, Chennai, the CME convener, to deliver address, and we will start CME.
Honorable Minister of Health, Mr. Subramaniam, Health Secretary, Government of Tamil Nadu, Dr. J. Radhakrishnan, Mr. Purnalingam, and very senior officials of the Health Administration of Tamil Nadu. At the outset, I thank Dr. Rajendran and Dr. Ismail of the IAP Tamil Nadu for giving me this opportunity to conduct the CME. At the outset, I would like to tell the officials and the administrators here that Tamil Nadu has been in the forefront of good COVID care for children. In fact, Tamil Nadu reported the first case of MIS-C not only in India, but also in the entire Asia in the world. The first case in India was reported from Chennai and Tamil Nadu, and it was successfully treated. Second is that the pediatricians belonging to the Indian Academy of Pediatrics have been following a disciplined approach to management of not only COVID-19, but also MIS-C. And I assure the Honorable Minister of Health and the Secretary that this CME today, which consists of several panel discussions on various difficult topics related to COVID-19 and MIS-C, will improve the knowledge, skills of the members of the Indian Academy of Pediatrics, who will continue to work together with the government of Tamil Nadu for the benefit of people. In fact, today's faculty, more than 50% are from Tamil Nadu, and even from those outside Tamil Nadu. One of them is Professor Ramanan, who is from the University of Bristol, London, who is one of the senior most researchers in COVID-19 across the world. He will be talking on recent developments. And we have one Dr. Jagdish Chinnappa, who has escaped from Tamil Nadu and settled down in Bangalore to talk on vaccination. And we are honored to have Professor Jacob John, the eminent virologist and pediatrician, and a father and the father of vaccinology in India, who's going to discuss vaccines today. In addition, we have experts from Tamil Nadu, Dr. Winsley Rose, Professor Srinivasan from ICH, Professor Ramachandran from Ramachandran Medical College, Dr. Thangavelu, and we also have experts from Mumbai, Dr. Tanu Singhal, and we have an expert from Delhi, Dr. Dhiren Gupta. We have Dr. Sanjay from Hyderabad, and all of them will deliberate on difficult topics and come out with good messages to the pediatricians. I am very confident that with the messages from this, the outcome of COVID-19 and MIS-C in Tamil Nadu will be excellent. Thank you very much.
Sir, Dr. Narayana Babu, Director of Medical Education, to felicitate. Dr. Narayana Babu, sir. Dr. Narayana Babu. Now I welcome Dr. Thirumurugan to tell vote of thanks.
Sorry, sir. Just நன்றி மறப்பது நன்றன்று என்ற தமிழ் கூற்றுக்கு இணங்க இங்கே நன்றி உரை கூற நான் வந்துள்ளேன். Let me start with offering my vote of thanks on behalf of IAP TNSC to our chief guest, Honorable Health Minister Thiru Subramaniam, for his valuable presence, his support and continued encouragement. We assure you that we will be in support with you, and then we'll support you and then work towards the welfare of all children, not only just those with COVID alone, sir. My sincere thanks to our guest of honor, former Health Secretary and Chairman of the Task Force of COVID Management, Tamil Nadu, Mr. Purnalingam IAS. Your words were of great value to us. My humble thanks to our Health Secretary, Dr. J. Radhakrishnan IAS, We have just had him 2 days back on Friday, and again to have him amongst us is a delight. Thank you very much, sir. My thanks to all the eminent officials of the Health Department, Dr. Kulindeswamy, Dr. Narayana Babu, Dr. S. Gurunathan, Dr. T.S. Selvavinayagam, and our nodal officer, Dr. S. Srinivasan, who have continuously encouraged us in this venture. This CME is only possible by the efforts of two real stalwarts of IAPTNSC, our president, Dr. Ismail, and our secretary, Dr. Ayendran. My special thanks to him from the rest of us to both of them. This CME again has been organized by Dr. SBS, a real stalwart, and we are very happy to have such a stalwart from Tamil Nadu on pediatric COVID. We are blessed by his presence. Thank you very much, sir. We thank all the faculty, including the father of vaccinology in our country, Dr. Professor T. Jacob John, for enlightening us on COVID, pediatric COVID third wave. I thank all the office bearers, the EB members, both state and central EB members, and the delegates of the CME. So thank you one and all.
Yeah, thank you. Now it's over to Dr. S. Balasubramanian, sir.
Thank you, Dr. Rajendran. We will start our sessions with three portions. First is a session on essentials in pediatric COVID. The expert moderator for this session is none other than Dr. Srinivasan. Of course, Dr. Srinivasan needs no introduction to this crowd. All of us know he is the nodal officer for the COVID-19 care in Tamil Nadu, and he has been instrumental in setting up management centers for COVID across government hospitals in Tamil Nadu. And he has had the experience of handling and supervising management of over 1,000 cases. I always call him more than a doctor, he's a social worker. He works for the welfare of children in ICH and HC and all over Tamil Nadu 24/7. And he's the moderator. And this session will consist of three sessions: immunology and pathogenesis to start with in pediatric COVID. What is known and unknown, we'll start from basic sciences. That will be done by Dr. Winsley Rose, Professor of Pediatrics, Christian Medical College, Vellore, an expert in pediatric infectious diseases. That will be followed by a discussion on management of pediatric COVID by Dr. Tanu Singhal, consultant in infectious diseases, Dhirubhai Ambani, Kokila Bahan Ambani Hospital in Mumbai, a well-known figure in Indian Academy of Pediatrics, and an expert in pediatric COVID. That will be followed by a session on PICU management of COVID-19 by Dr. Dhiren Gupta, the pediatric intensivist from Gangaram Hospital, Delhi. Over to Professor Srinivasan. Thank you, sir.
Thank you, Bala sir. With due respect to the Honorable Minister, Health Secretary, and our task force chairman, Sri Purnalingam sir, and all the faculties, and nice words from our KKCTH Balasubramanian sir. So today I'm going with the opening batsman, and it's going to be a 20-20 match, where I want the speakers to hit the ball hard and finish the match in 25 minutes or 30 minutes, whatever the time allotted. Because we should restrict our timing so that 15 minutes can be given for the good question and answer session. Because 716 people have joined, I think we can expect a lot of questions from the people. Okay, the first topic is going to be talked about by Dr. Winsley Rose. So what is the importance of this topic? See, we all know that we had an epidemic like dengue. Initially, we lost many children, but slowly we learned the pathophysiology, that is the coagulopathy and the capillary leak. Then we mastered the dengue. In fact, there is no vaccine or drug for dengue so far, but still we are mastering the dengue. Similarly, if you take respiratory syncytial virus causing bronchiolitis, again no vaccine or drug, but still we know, we mastered since we know the pathogenesis very well. What about COVID? During the first wave or during the second wave, and we are anticipating the third wave. You all come across in the daily newspapers and WhatsApp, but every week or every 15 days, the drugs got changed, starting from hydroxychloroquine, ivermectin, lopinavir, remdesivir, whatnot. So many drugs have been utilized. Because in the initial period, we have many people, they don't know what is sure of pathogenesis, what is happening, what pathogenesis is happening. If we know the pathogenesis perfectly, I think we can conquer, even without vaccine and without drug, what we are doing for dengue and respiratory syncytial virus. So Professor Winsley Rose from CMC, and he is a research person for scrub typhus and enteric fever. And he is also a member in the Lancet COVID Commission expert group. So I request Professor Winsley Rose to talk about immunology and pathogenesis of COVID, and with the time allotment of 25 minutes for you, sir. Please, sir, take over, sir. Professor Winsley Rose.
Yes, sir. Am I audible?
Yes, sir, you are audible. Yeah.
Yes, Winsley. So I'll just share my screen. Just tell me if it's visible as well.
Yeah, it is visible. It is visible.
Yeah. Okay. 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 Thank you. Thank you for the opportunity. So, I mean, I guess this is not an easy topic to actually talk on, considering that there is so much which we've learned over the past year about the immunology and the pathogenesis of COVID-19. So it's a complex topic, but I'll try and see what I can do to actually distill it into a sort of in a manner that is understandable by most people here. So the outline of my talk, I'm just going to talk a little bit about the virus itself, then immune responses to the virus, then immunopathogenesis of COVID-19, and finally, I'll end with immunopathogenesis of MIS-C. As we all recognize, MIS-C is probably the most important thing when it comes to children. The virus, I mean, as we all know, it's a coronavirus. The coronavirus, there are many coronaviruses which cause human disease, of which the coronaviruses which cause disease, the SARS-CoV, the original SARS-CoV, which happened in 2002, 2003, then the MERS-CoV, which happened sometime in 2013, the Middle Eastern respiratory syndrome virus, and the SARS-CoV-2, they all belong to the beta coronavirus, virus 2. The four alpha and delta coronaviruses, of which all the really pathogenic coronaviruses belong to this beta coronavirus group. And there are few other coronaviruses which can cause human disease, but they all cause milder human disease. Now, out of these, the SARS-CoV-2, even though the closest virus to the SARS-CoV-2 is actually the bat coronavirus, the rat G13 coronavirus, which actually has about 96% similarity to the SARS-CoV-2, the one which has got pathogenesis which is similar to SARS-CoV-2 is the SARS-CoV virus, which has only about 80% similarity to the SARS-CoV-2 virus. Now, we all recognize that the coronavirus is a sort of like a spherical virus. It's got a lipid bilayer onto which there are these structural proteins, of which the most important proteins are the spike protein, then you have the membrane protein and the envelope protein. And the spike protein itself is the one which is responsible for attaching to the human cell and entering the human cell. You have another structural protein, which is the nucleocapsid protein, the nucleocapsid protein actually gives sort of a backbone to the RNA. It's a single-stranded RNA virus. The spike protein, there are two components to it, the S1 and the S2 component. The S1 component is the outer component which attaches to the host cell, and the receptor binding protein, which is actually present in the S1, and it's the S2 protein, which is the stalk which attaches the S to the lipid bilayer of the SARS coronavirus. Now, if you look at the life cycle of the virus itself, the virus actually uses the ACE2, the angiotensin converting enzyme 2, as its receptor for binding onto the host cell. And it uses another protein, which is the transmembrane serine protease, which is important for fusion of the virus to the host cell. So, and there is endocytosis which happens, and the virus, the viral genome gets incorporated into the, into the cell, and then your translation of the single-stranded RNA, there is RNA replication, and finally there is transcription, and the membrane protein, the envelope and the accessory proteins are produced in the Golgi apparatus, and the viral assembly happens within the cell, and the virus matures, and then the virus is released, and that forms the life cycle of the virus. Now, the important parts to this are, I told you there is this transmembrane serine protease which is there, and it is also a target for a particular drug called Carmostat, which is a serine protease inhibitor. So it is one of those areas where it can actually work to prevent entry of the cell into the host cell. We all are well aware of the antiviral drug remdesivir, and remdesivir itself actually is it's a inhibitor of the RNA-dependent RNA polymerase. It's a mimic of adenosine triphosphate, and that is how it actually works as an antiviral agent, and it works at this stage where RNA replication happens. Now, the ACE2 expression is one of the important features which actually gives tells us where all the virus can be and what all the virus can cause pathology. Now, different tissues in the body actually express these ACE2 enzymes at different levels, and if the expression of the ACE2 enzyme is high, that organ is likely to be infected more. So what are these areas where the ACE2 expression is high? So more than 1% is in the lower respiratory tract, the lung, the heart, ileum, esophagus, kidney, bladder, and very little expression happens in the stomach and the liver. That also goes to show why liver is not actually very much affected with SARS-CoV-2. You must also remember that the endothelial cells also have a significant amount of ACE2 expression, because of which there is endothelial cell damage causing pathology when it comes to infection with SARS-CoV-2. Also, there is among children, there is lower expression of ACE2 in both the nasal and the bronchial epithelium. So because of this, the virus itself actually doesn't get bound to this thing as much as it would with the adults, and probably that might explain some of the reasons why it is a milder illness in children. And we all recognize that comorbidities such as diabetes, obesity are all associated with increased disease severity. And one of the reasons could be this ACE expression, which is actually increased with these comorbidities. Now, I mentioned about the multiple proteins which are there in the SARS-CoV-2 virus. Now, antibodies to this are also produced, and the most important antibodies are the anti-spike antibody and the anti-nucleocapsid antibody. there are IgG, IgM, and IgA antibodies produced. Now, you must remember most of the vaccines are actually against the spike protein. So it produces spike antibodies. So if you have somebody whose antibody is positive for the spike protein, you can imagine that it's not necessarily because of an infection, and it could very well be because of vaccination. Similarly, if the anti-nucleocapsid antibody is positive, it could very well it's not because of a vaccine which is among the vaccines that we have. We have Covishield and Covaxin, and Covaxin, we all know that it's a whole cell vaccine. So the number of antibodies which are produced against the Covaxin, it's a little more wider than what is there in Covishield, because Covishield only produces anti-spike antibodies, whereas with Covaxin, you can also have anti-nucleocapsid antibodies. So if you have anti-nucleocapsid antibodies, it could mean that you've either been vaccinated with Covaxin, or if you've not been vaccinated or vaccinated just with Covishield, it could mean that you've already had the infection as well. Now, another important thing to remember, after the SARS-CoV-2 exposure, the virus actually replicates, and it replicates and becomes transmissible even before the onset of symptoms. So here in this graph, it's actually day 0 is symptom onset, but the RNA levels are much higher. In fact, it sort of peaks around the time the symptom onset happens, which also means that transmission happens transmission is actually highest at the time symptom starts, and it even happens before the onset of symptoms. And then you have the antibody response, IgM, which goes up and then it falls within a few weeks. And the IgG response actually it could last for many months. We don't know whether it will last for years. We don't know, but we do know that it actually lasts for a fairly long period, and how much whether this antibody response, how useful it is in preventing severe disease, we don't know all those information for sure. When you think about COVID natural history, it's important to recognize COVID in these 3 phases. Dr. Srinivasan mentioned, we sort of know the pathophysiology of dengue, which is why dengue is actually a fairly easily manageable disease right now. Similarly, if we understand that COVID also has a certain pattern to its course, we can actually intervene at these different stages with the specific intervention strategies. So what is the 3 stages are: stage 1, which usually happens in the first 5 days. That is stage of early infection. Now, that is when viral replication is maximum. During this period, the patient could be asymptomatic, or they can have mild or moderate symptoms, and the PCR is often positive because the viral loads are higher. Now, if you really want to give an antiviral, this is probably the time to give it. Next comes the stage 2, which is actually the pulmonary phase. Now, replication of the virus slows down, but the lungs get infected. There is pneumonia. The patient is getting sicker. They might have dyspnea. Chest X-ray might show opacities. The CT scan may show ground glass opacities. Now, around this time is also the time when the host cell inflammatory response increases. Now, after this, about 10 days, the first phase is about 5 days, the second phase for another 5 days. So after the 10 days, the virus replication has stopped. But this time is when the patients if they were to become sick, they really become sick because of the hyperinflammation that happens during this phase. This hyperinflammatory response leads to pneumonia. It affects multiple systems. It can cause a sepsis-like picture. There is respiratory failure. There is features like ARDS. All this because of the cytokine storm. So this is something, if there is nothing that you get out of this particular session, I think this is probably the most important thing, that you sort of recognize COVID in these 3 stages: the early infection stage for 5 days, the pulmonary phase for the next 5 days, and after 10 days, you have the hyperinflammatory phase. Now, if you look at any the immune response to any pathogen, what we've shown here is a SARS-CoV-2 infection. First thing that happens is the innate response. And this innate response is often with dendritic cells, which take up the antigens of the SARS-CoV-2 and present it to the other cells. And you have induction of adaptive immunity, which comes into play after that. And you have T helper cells, T regulator cells, you have cytotoxic T lymphocytes, and T follicular helper cells, which help in the induction of antibodies. Now, after this, you have a period where there is recovery to SARS-CoV-2, and there is immune memory. And this immune memory can be T cell mediated as well as B cell mediated. So there is antibodies as well as T cell mediated immunity, which actually can stay on for many months or even years. Now, what happens with COVID-19? Now, there are four important things which happen. First is the depletion and the exhaustion of lymphocytes. Next is the increase in the number of neutrophils. Next, there is an increased production of cytokines. And finally, it is possible there is some amount of antibody-dependent enhancement, which could lead to the pathogenesis of COVID-19. Now, when I say depletion and exhaustion of lymphocytes, that the lymphopenia is actually a marker of severity in COVID-19. So if you have very low lymphocyte count, that actually correlates well with disease severity. Now, why does this happen? The spike protein, which, I mean, the ACE enzyme, which is actually the receptor for the SARS-CoV-2, is also present in T cells. And this itself can actually cause the coronavirus to actually directly infect the T cells. And this causes impairment of the T cells and then cause decrease in the lymphocyte number. Then you have T cells which have an increased sensitivity to TNF-alpha, interleukin-6, and interleukin-10, which actually are produced by macrophages and lymphocytes. And that actually causes T cell depletion and exhaustion, which again causes lymphopenia. And also the virus directly infects the spleen and the lymph nodes. You can have, I mean, in pathological studies, they found that there is actually necrosis of the lymph nodes with COVID. And this again can cause lymphopenia. And finally, there is some amount of lactic acidosis which is produced, which actually causes T cell impairment as well as dysfunction. So the first thing that happens is the decrease in the lymphocyte number as well as the function. Next, there is an increase in neutrophils. Now, this increase in neutrophils is likely because of lymphopenia and associated microbial infection. And there is this microbial infection causes activation and recruitment of neutrophils to the site of infection, causing an increase in the number of neutrophils. And thirdly, which is what happens during the third phase, that the hyperimmune phase, is this cytokine storm. Now, this cytokine storm, one, it could be because of the activation of monocytes, which is with the help of T helper cells, and there is a Th1 response, and there is increased GM-CSF, and the CD14 positive and CD16 positive monocytes produce a lot of IL-6. Now, mind you, I mean, tocilizumab, the drug which is used for acute COVID, is an IL-6 inhibitor. So it's probably one of the ways in which actually that works. Then, secondly, you also have monocytes, which are CD14 positive monocytes, which are activated and they produce a lot of interleukin-1 beta, which again takes part in the cytokine storm. Then there is the Th17 response, which causes increase in IL-17, which recruits many monocytes, neutrophils, and macrophages, which again increases the amount of IL-1, IL-6, etc., which leads on to this cytokine storm. So finally, you have many cytokines which are unregulated, and when they are unregulated is when they contribute to that hyperimmune phase, So we must remember that it is that during that phase, the key answer to the problem is actually decreasing the cytokine storm at that point. And finally, the concept of antibody-dependent enhancement. We all understand antibody-dependent enhancement in dengue, where you have the first infection with a particular dengue virus, and if you have a heterologous viral infection subsequently, there is only partial immunity, and this partial immunity actually enhances the entry of the dengue virus into the host cell, and it increases the pathogenicity of the virus. Now, there is this theory proposed that if you have partial immunity to coronavirus, when the infection happens, there is an increased propensity of entry of the virus into the host cell, causing increased pathogenicity, leading to poor outcome and increased disease progression. Now, it's a good theoretical possibility, but we have not seen this play out as such, because we all recognize that, if this were true, then people who've been infected in the past are likely to have actually more severe disease, especially if they are removed from their first infection. Also, if you're vaccinated, it is possible that you can have more severe disease also. And all these things have not played out like this. So I'm not quite sure whether this forms a significant part in the pathogenesis of COVID-19. This is an important concept to remember. That is, the immunity which happens to COVID-19 could be protective, which means it is lytic to the SARS-CoV-2, which clears the SARS-CoV-2, or the immunity just could go out of hand, and that immunity going out of hand actually leads to the bad cytokine storm, which actually contributes to the increased pathogenesis of the severe disease. So once you have the native T cell, which is activated, it goes into the lymph node, and on one side you have the CD4 cell proliferation, which leads to memory T cells, and also which leads to plasma B cells being activated, and there is production of neutralizing antibodies, and there are cytotoxic T cells which again produce certain cytokines which actually result in SARS-CoV-2 clearance. Now, this is what happens when somebody has mild to moderate disease. But if somebody were to have severe disease, this T cell proliferation, actually there is a downregulation of effector T cells, but there is an upregulation of monocytes as well as neutrophils. And this leads to this cytokine storm. And with the production of these particular cytokines, such as interleukin-1 beta, TNF-alpha, interleukin-6, and many other cytokines, which actually, it forms one vicious cycle where there is more and more cytokine production, and this hyperinflammation actually causes the pathogenesis, the pathological effects of severe COVID disease. Now, there is also direct infection of the vessel walls, causing endothelial damage, and this can lead to thrombosis. There is also hemophagocytosis and reduction in hematopoiesis, which all contribute to the bad effects of SARS-CoV-2, those who actually develop severe SARS-CoV-2 infection. For some good reason, this one, which is actually shown in the pink, doesn't happen so often in children, and it's often what happens in blue, which happens in children. And this, what shown in pink, is often what happens in adults with comorbidities. So why do children have it easier than adults? So these are proposed theories. One we know for sure is that there is actually decreased ACE2 receptor and the transmembrane serine protease expression in the respiratory epithelium of type 2 alveolar cells in children, and it increases with age. So there is just not enough receptors for the SARS-CoV-2 virus to actually attack the alveolar cells. Also, a bulk of the problem is because of the adaptive response which is overactive. Now, children have strong innate responses, but they have poor adaptive responses. And there can be other respiratory tract viruses which inhabit the respiratory tract of children. And so they compete with SARS-CoV-2. So SARS-CoV-2 has lesser area to actually fight with the child's respiratory tract. Also, there are lesser TLR-induced responses and increased T regulatory cells in pediatric lungs, which actually suppress immune response, which prevent a cytokine storm. There is also less lymphocytopenia. I told you lymphocytopenia is correlated with severity. There is less lymphocytopenia among children. And microvascular maturation and alveologenesis, actually it's a continuous process in children, whereas in adults it's already happened, and when there is damage, there is no provision for repair. And the pulmonary endothelial barrier is actually well preserved in children compared to adults. So these are some of the reasons why children have it easier than adults. Now, finally, a little bit about immunopathogenesis of MIS-C. MIS-C, as you all know, it's multi-system inflammatory syndrome, which happens in children, and it's temporarily associated with the SARS-CoV-2 infection. This is a delayed immunological phenomenon which is associated with inflammation. It follows symptomatic or asymptomatic COVID-19 infection, and it is usually about 1 to 6 weeks after the infection. Now, it's often negative, it often associated with negative PCR and positive antibodies. You can imagine if it happens 1 to 6 weeks, if it happens in the second week after infection, PCR may be positive, but anything after that, it's often only the antibodies which will be positive. So, I mean, this looks like a complicated slide because it is a complicated event which happens. So, I told you that there are these three phases after a COVID-19 infection. One is the stage of the early infection. Then you have the stage of the pulmonary phase where it's mainly the lungs which are involved. And finally, the hyperimmune phase. Now, for some reason, children who have mild infection, either asymptomatic or symptomatic infection, skip this pulmonary phase and go directly into this hyperimmune phase, but in a delayed manner. This hyperimmune phase actually happens a little later than acute SARS-CoV-2 infection. Now, there is macrophage activation, which activates helper T cells, which produces which again activates the B cells and plasma cells, leading to a lot of antibodies. And there is also production of this increased amount of cytokines, including TNF beta, IL-12, IL-6, IL-1 beta, IL-23, IL-4, interferon gamma. So there's a whole load of cytokines which are released, which again stimulates macrophages, neutrophils, and monocytes. And this vicious cycle happens, and there is a hyperimmune response. And this causes changes in the many tissues in the body, which can include meningeal irritation. There is pulmonary edema, consolidation, and atelectasis. There are skin changes, there is acute kidney injury, there is coronary aneurysms, shock, and involvement of the abdomen with ileitis, colitis. Now, all of these can happen. Now, there is also a small component which may predispose certain children to actually develop all this. So there may be a genetic predisposition to this happening among children. Now, this is a very recent paper which was published maybe in the last couple of weeks, which have shown that there are monogenic variations, which actually, if these monogenic variations are there is increased inflammation, which leads on to MIS-C. And if these variations are not there, with these genetic risk factors are not there, they usually present with just either mild or asymptomatic disease. So there may be a genetic component to MIS-C. Now, MIS-C, like even the hyperimmune phase of...
Dr. Winsley, another 2 minutes, please.
Yeah, should finish in very quickly. MIS-C, actually, it's the hyperinflation in MIS-C and Kawasaki disease. There is a lot of hyperinflation in both cases, and that actually differs from severe acute COVID-19. How does it differ? With acute COVID-19,
there is IL-8, which is produced, which is associated with lymphopenia, and also increased IL-7 production, which actually causes, which is a T cell maintenance cytokine, which is increased, whereas that is not so in MIS-C and Kawasaki disease. Similarly, immune response, even though MIS-C and Kawasaki disease actually seem similar, the immune responses between MIS-C and KD are also different. Now, this is just a violin graph about, I mean, you can actually look at the graph and make out that there is actually difference in the T cell responses with MIS-C as well as Kawasaki disease, whether it be memory T cells, effector memory T cells, or naive CD4 T cells. So even though they look similar, there is difference in T cell mediated responses with MIS-C and Kawasaki disease. Also, not only is it T cells, it's also cytokine responses. So the cytokines which are produced among MIS-C and Kawasaki disease are also different, which is shown with this violin graphs. There is higher IL-6, IL-17A, CXCL10 in Kawasaki disease. And particularly, there is a cytokine called DCBLD2, which is higher in KD, which is associated with balloon coronaries. We are all aware that KD actually causes more coronary involvement than MIS-C, whereas MIS-C causes more myocardial involvement. Serological responses in MIS-C, it's similar in SARS-CoV-2 and MIS-C patients. There are really no difference in the serological responses between these two. But pre-existing immunity to other coronaviruses are lower in MIS-C compared to those with MIS-C, without MIS-C. And there are many autoantibodies found in MIS-C, which are, however, different from those found in Kawasaki disease. And these elevated autoantibodies related to arterial damage are more in KD compared to MIS-C. Now, finally, about treatment. IVIG is useful both in MIS-C and KD because it can actually neutralize many of these autoantibodies. Similarly, corticosteroids, it causes a more general immunosuppression, but the precise role in MIS-C is unclear. And we all recognize that use of anakinra, which is a IL-1 receptor antagonist, actually neutralizes strong IL-1 responses elicited by endothelial damage due to antibodies as well as complements. Now, TNF-alpha blockade is useful in acute COVID, but not useful in MIS-C because TNF-alpha is not produced much in MIS-C. Similarly, IL-6 blockade, I mean, we all are used to using tocilizumab, which is actually a good drug for acute COVID, but not MIS-C because, again, IL-6 levels are often normal in MIS-C. So finally, to conclude, immunopathogenesis of COVID-19 infection and MIS-C is still far from being fully understood. It's this thing in evolution, and it's useful to consider the pathogenesis of COVID-19 in three phases: early infection, pulmonary phase, and the hyperinflammatory phase. There is lymphopenia, increased neutrophils, and increased cytokine response, which are hallmark of COVID-19 infection. Now, MIS-C, the immunopathogenesis is different from acute COVID and also different from KD, but it is closer to Kawasaki disease than to acute COVID-19. With this, I'll conclude. Thank you for this opportunity.
Thank you, Professor Winsley, for nicely explaining the pathogenesis. It still looks very complicated. And without wasting time, there are questions that will be discussed after the three speakers have finished the session. Now we call upon Tanu Singhal, Professor Tanu Singhal, to take over. Tanu Singhal is a pediatric intensivist from Kokelabai Ambani Hospital, and he is also an IAP Task Force COVID expert, and he has got very rich experience in pediatric and also in adult COVIDs. So over to Tanu Singhal. Sir?
Yes. So thank you so much. I would first like to thank Dr. Balasubramanian for inviting me to this symposium, and thanks to Dr. Winsley for a very nice lecture. So can you see my screen?
Yes, madam.
Yes, yes, Dr. Tanu.
Yeah.
Please make it slideshow.
Yes, yes. Okay.
Perfect.
Yes. So to start talking about management of pediatric COVID, actually most of the things which I'm going to talk about have must been already presented to you earlier, because a lot of slides in my presentation are from the IAP guidelines, which I think you must have been seeing or attending many CMEs with respect to that. So to begin, most children who suffer from COVID-19 have mild and self-limiting infection. And we know why they suffer less. And as per current estimates, less than 1 to 3% of children with COVID need hospitalization, and mortality rates are lower than 0.1%, whereas, in adults, your mortality rates may be 2 to 3%. And children who actually do have severe disease are those who have underlying comorbidities or who are at the extremes of childhood age. That means either they are infants or they are adolescents. Therefore, there's nothing much to talk about management in these patients. Then they do well with supportive and symptomatic care. And in my opinion, social interventions are more needed for childhood COVID than medical, as indirect effects are more than the direct effects. And, while we'll be talking so much about medical thing, the learning crisis, the mental health problems, the other screen time related issues and poverty, missed vaccinations are more important to tackle with. And I hope the government does enough in that area as well. The first thing, so in this management, I'm going to talk a little bit about diagnosis and then treatment. Now, the first is that who is a COVID-19 suspect? Where should you think of COVID-19 suspect? And actually, COVID-19, and you know that this virus can probably go to any organ, because whichever organ has ACE2 receptors, the virus goes there. So your patient may come with any of the following symptoms, either alone or in combination. So they may just have non-specific systemic symptoms like fever, headache, fatigue, lethargy, exhaustion. But even these symptoms are less in children as compared to adults. You can have respiratory involvement like cough, sore throat, runny nose, breathlessness, tachypnea, hypoxia, etc. But again, in most children, your symptoms are very mild. Children can also present with GI manifestations, because we know that the ACE2 receptors are also present in the GI tract, with nausea, vomiting, diarrhea, abdominal pain. They can have rashes, chilblains, seizures, etc. Loss of sense of smell and taste is not commonly reported in children, unlike adults. And one must remember that you have to suspect COVID irrespective of contact history. So even if you have a child who comes to you where nobody else in the family is sick or tested positive for COVID, you should still think of COVID-19. And the other important point is that clinical differentiation of COVID-19 from other common childhood illnesses like flu, RSV, even mild dengue, malaria is often not possible. So you have to rely on laboratory investigations. So once we have a COVID-19 suspect, the next question is who should be tested? So ideally, all children who are suspects should be tested. And during the peak of the COVID wave, especially the second wave, the test positivity rates were very high and there was no other acute illness around. So, whichever child would come to you with whichever acute illness, most of the times that child would test positive for COVID. But at this particular time now, there has been a decline in COVID-19 numbers, and there is an appearance of other new illnesses like flu, RSV, dengue, malaria, chikungunya, etc. And in our city, in Mumbai, the test positivity rate is down from 20% in April to 1% now. In fact, data from our own hospital shows that the COVID-19 test positivity in samples is less than 1%. And in fact, in a recent study in our hospital, just an analysis of data over the past 6 weeks, there were 191 patients with respiratory illnesses who tested negative for COVID. And when we checked them for other viruses, we found that 60% were positive for either flu or RSV. And in fact, there were no co-infections. So, we didn't have any patient who tested positive for both. So therefore, while logically all children who come to us, even at this time with acute illnesses, should be first tested for COVID-19. And if they're negative, tested for other pathogens, it is not practically happening in outpatients. So if you're admitting a child to the hospital with any acute illness, we are still testing for COVID. But now, in the outpatients, you have children coming to you with a very characteristic flu-like illness. And we've tested most of these children for COVID earlier and they were all negative. So sometimes we don't test these children. That shouldn't be done, but that is what is happening, that the testing rates have also gone down as the numbers have fallen. And another thing which one must remember, that if other illnesses have appeared, and if your patient tests positive for COVID, you may also want to keep an eye on other viral infections and other tropical infections, because you may have both of them coexisting at the same time. So a negative COVID test should not be the only factor which triggers investigation for other illnesses. If your patient is not behaving like COVID, then please test for other viruses or other pathogens as well. So as far as the diagnostic algorithm is concerned, you have a suspect COVID patient. You first do an antigen test in the nasopharyngeal swab. Now, some people may say that antigen test, if it's not readily available, you can go directly to a RT-PCR. But if it is available, it can be the first test, because it is cheap, it has a rapid turnaround time, and it is very specific in symptomatic people. If it is positive, your patient has COVID-19, and you don't need to do an RT-PCR, because there's no confusion about the diagnosis. On the other hand, if your patient is negative, then you need to do an RT-PCR, because the sensitivity of the antigen test is just 30%. You do an RT-PCR, or as I said, in some cases, you may do an RT-PCR directly. If it is positive, again, it's COVID confirmed. If your test is negative, then you have to then think of other illnesses. You may want to rule out other illnesses, test for other viral pathogens, or if your suspicion for COVID is still very strong, you may repeat the test again. You can do antibody tests, and I'll come to that in a moment if the symptoms are protracted. The role of CT scan is very less in pediatric COVID because of the risk of, radiation. But if your patient has very protracted symptoms, you don't have any other illness picked up, and the patient needs admission, you may do a scan. And also, these patients, you can't find another illness, you would treat it as a case of probable COVID-19, because you know that the sensitivity of the RT-PCR is at best 70%. So this has already been dealt with by Dr. Winsley, so I'm not going to spend time on it, because it is essential to know the components of the virus to understand the various tests that we do in the diagnosis of COVID. And also, we have already discussed the kinetics of the virus, RNA, antigen, and antibody. So I'm not going to talk about it, but we know that your RNA test is positive even before your symptoms appear. And therefore, if you have an asymptomatic patient who tests COVID positive on the nasopharyngeal swab, you monitor those people for 10 days, because they may just be pre-symptomatic. And then this RNA actually declines over a long time. And while this graph shows you that it becomes negative in 28 days, there are some people who can be positive for even up to 2 to 3 months after infection, because it's a dead RNA which is picked up by the molecular test. And so that is why you have to understand that, a positive test in an asymptomatic patient will not tell you whether the patient is pre-symptomatic or whether the patient is post-symptomatic. And then we know that you have an IgM response, which is short-lived, and you have a more robust IgG response. And therefore, if you're doing antibody tests for detection of COVID, then you actually go in and do either a total antibody test which detects IgM and IgG both, or an IgG alone test. So because this topic about molecular testing is not covered in many lectures, I thought I'll talk about this a little bit. You should test these patients as soon as possible, because with time the viral load goes down, and proper sample collection is important, because if you don't collect your sample properly or you test your patient late, your false negativity goes up even more. And you know that the RT-PCR based tests, they target 2 genes of the virus, and we already know what are the various genes. You have genes SEN, membrane, RDRP, ORF, etc. So all different kits target 2 different types of genes, and these kits have varying performance. And you have 2 types of RT-PCR based tests. One are those tests which need separate extraction and then amplification, and they have a high turnaround time. Whereas you have other systems like Expert Express and TrueNat, which give faster results within 2 to 3 hours. Another important point to understand is that the CT value of the PCR does not correlate with the disease severity, and we should not be looking at it to either think about how severe the disease may be or how infectious the patient is, because the way you collect the sample and the way kit you choose all can influence the CT value. So you can have a high CT value even in a patient who has early disease. There are some other molecular tests which are available, like ID now from Abbott. which is a point of care molecular test that can give a positive result in 5 minutes and negative in 13 minutes. There are some labs in Mumbai which are offering this test, but it is quite expensive. At our hospital, we are routinely doing Expert Express and the conventional test for diagnosis of COVID. You must have heard about CRISPR, which is another molecular test, but I don't have much experience with it. Another important thing you must remember is that the tests can be positive for up to 3 months, and therefore these tests should not be used to determine the need for de-isolation or recovery from COVID. Sometimes patients do it, even if you tell them not to do it, because they feel that unless the test becomes negative, they have not recovered, which is not true. And we know now that most people lose viable virus by 10 days after infection, and therefore they can be de-isolated. So you don't need to do a negative test to de-isolate. And also the results should be interpreted in the clinical context, because if you have a patient who presents with an illness which is not looking like COVID, but the RT-PCR in the nasopharyngeal swab is positive, it may just be there as a bystander. It is possible that the patient had an infection 1 month ago and the PCR has just come positive from that. That is also another thing which you must understand. Now, Dr. Winsley has made my task easy about antibody tests, because I have realized that a lot of people are doing antibody tests in COVID-19, which actually is not correct. So the main clinical indications for doing antibody tests is in diagnosis of MIS-C or in diagnosis of acute COVID-19 when your patient has protracted symptoms for 7 or 8 days and your RT-PCR is negative. But since the natural seroprevalence rates of COVID antibodies are going up, the specificity of this test is declining, because you can have an antibody test positive just because 50% of the population or 60% is positive antibodies, and that antibody may have nothing to do with the illness that the person is presenting with. The research indications are in sero surveys and for vaccine trials, but it is not indicated for routine diagnosis of acute COVID-19 and to know antibody status after vaccination, because there's no correlation between these antibodies and protection against future infection. It is also important to know that there are 2 types of tests. One are the rapid tests, which are the card tests or the lateral flow assays, which are less sensitive, and you have the ELISA or CLIA-based tests, which are more sensitive. And that is why people say that they were suspecting MIS-C, but the antibody test came negative. So you have to also look at what kind of antibody test was done. If it was a rapid card test, the sensitivity is low and it may be false negative. And again, the types of antibodies are the binding antibodies, which indicate infection, and neutralizing antibodies, which indicate protection. So as Dr. Winsley said, that the tests which were available last year were the first generation tests, which were the anti-SARS-CoV-2 antibody tests, which were qualitative tests to detect binding antibodies to the nucleocapsid protein. And the main purpose was to detect previous infection. And these tests centered on high specificity at the cost of sensitivity. And these are not usually positive after vaccination. So that means if you have been vaccinated, but you've not had natural infection, your SARS-CoV-2 antibody test will be negative, maybe except for Covaxin, because it's a whole virus inactivated vaccine. And now the second generation tests which have come in this year are the anti-spike antibody tests. So these are quantitative tests that detect antibodies to the spike protein or the receptor binding domain of the spike protein. And these tests can be positive both after vaccination and after natural infection. In fact, the sero survey, which was recently done by ICMR, was based on this. And therefore, it is important to order the right type of test. Then, what is the role of CT chest in children with COVID-19? I said CT is more sensitive than chest X-ray, but it involves cost, need for sedation and radiation exposure. It is not indicated in mild disease. It is not indicated in moderate to severe disease if your RT-PCR is positive. So the only indications of CT chest are you have a child who's having protracted symptoms, but your COVID PCR is negative. You can't make any other diagnosis. The child needs to be admitted. You can do this test. Also, in an acutely sick child who's coming to your ER with breathlessness, you want to know quickly where to put this patient into a COVID or a non-COVID area, or if your turnaround time for RT-PCR is long, you do this test. Or if you have a patient with severe COVID-19 in the ICU who deteriorates, to know what is the cause of deterioration. And in this, you must understand 2 terms. One is CORADS and CTSS. And now, important thing which you must understand is that many patients have an abnormal CT scan, even if they're asymptomatic or they have mild disease, they may have a CTSS score of 8, 9, 10, and that does not indicate pneumonia, and you don't have to treat them any differently just because their CT is abnormal. You don't have to give them multiple drugs. So moving from diagnosis to talk about disease classification of disease severity, you again have classification as mild, moderate, severe disease. And I'm sure you must have seen this slide in the various IEP modules. Mild disease is only upper respiratory tract involvement. Moderate disease is presence of either fast breathing or a saturation of between 90 to 93% on room air. And severe disease is if your patient is having grunting or increased respiratory effort, or if your patient presents with serious neurological involvement or severe dehydration. Because your management will depend on disease severity. And I'm only going to talk about management of mild disease because the management of moderate to severe disease will be covered by Dr. Dhiren. So actually, there's nothing much to talk about in management of mild disease. You isolate these children at home, you give them paracetamol, nasal decongestants, and antitussive drugs for their cough. While a lot of people are prescribing zinc, vitamin C, and vitamin D, there is no established role of these agents, and you can just give them as placebos, but make sure you don't give high doses of vitamin D. There is no role of any antibiotics, azithromycin, doxycycline, ivermectin, favipiravir, hydroxychloroquine in COVID-19. And despite talking about this in multiple meetings, still these drugs are prescribed. So actually we have to stop using these drugs, and we have to tell the parents that this is a viral illness and will get better on its own. While in adults with mild COVID, budesonide is used, but there's no data in children. And steroids should not be given in this phase, even if the child is running high fever, because we know that steroids increase viral replication and can worsen outcomes and can also cause super infections. You don't need to do any investigations, including CBC, CRP in these patients. No imaging is indicated. And you just have to tell the parents to monitor for red flag signs, which is persistent high fever, lethargy, poor feeding, etc. And in older children, you have to look at saturation. Please don't ask parents to monitor saturation in young children 1 or 2 years of age, because most of the times the saturation is not monitored carefully, and then the parents get all hyper if it shows 85, 87%, and we've seen many parents rushing to the hospital, and actually it was incorrect monitoring. So for young children, you have to really ask them to look for their feeding, lethargy, and fast breathing as danger signs, and not so much the saturation. You de-isolate them 10 days after onset of symptoms. And there is no really near way of predicting future risk of MIS-C at this point in time. So because that question is often asked, and you don't have to do an antibody test to decide whether this child will have MIS-C later. And actually, in my practice, I don't even counsel people that MIS-C can happen later, because, parents then get very, very worried. And you know that MIS-C is actually a very rare occurrence. So all you can tell them is that in the next 1 or 2 months, if your child gets fever again, you better let us know, and that's it. Now, in management of mild disease, you have to be a little more careful in children who have serious comorbidities than mild COVID-19, because these children have higher risk of progression to severe disease. You may have to admit them to hospital to manage their comorbidities, and you have an option of monoclonal antibody cocktail in some of these older children, which I will discuss a little bit more, because maybe that information may not have percolated through. And if you have children with prolonged persistent fever, these children also have to be monitored carefully, preferably admitted to hospital, and you have to do investigations, because you could be dealing with some other infection apart from COVID-19. So you have to do their CBC, CRP, urine analysis, do blood cultures, chest X-ray, and if required, work up for tropical infection like malaria and dengue. You give antibiotics only if bacterial infection is suspected, and you intervene if they progress to severe disease. A little bit about the monoclonal antibody cocktail, just so that we don't misuse it. It is basically, it is antibodies which are against the receptor binding domain of the spike protein, and they act as antivirals by neutralizing the virus. And this combination is now available in India of casirivimab and imdevimab, and it has a total dose of 1200 milligram, which can be given as an IV infusion over 1 hour. The cost of therapy is enormous, 60,000 for 1 dose. And there are RCTs in adults, though not in children, which have shown a 70% reduction in hospitalization or deaths, and faster resolution of symptoms in people who were given this cocktail. But remember that the number needed to treat is 45. That means 45 patients have to be treated, or rupees 27 lakh has to be spent collectively to prevent one hospitalization. So it's not at a public health level, it is not a cost-effective intervention. And basically, this is a drug which you will give in children who have confirmed diagnosis of COVID early in the onset case of the disease, who are above the age of 12 years and weigh more than 40 kg, and who have risk factors for disease progression. Now, these risk factors for disease progression are for adults, but basically they also apply to children. And you would be more, ready to use it if the comorbidity is very significant. So, for example, a child above 12 years who is now having, who's on treatment for leukemia, or who has just undergone a stem cell transplant, you will not consider it for a patient who has asthma or something. And even if of course, this is not relevant vaccination, but even if the patient has had previous infection with COVID, still it may be indicated, because we know that people can still have reinfections and can have severe disease. Should not be given in hospitalized patients, should not be given to people who are already on oxygen, because it worsens the outcome. So very, very small niche area to give the monoclonal antibodies to highly immunocompromised children with mild disease who are above the age of 12 years within the first 2 or 3 days, especially if they have high fever and they're not getting better. Management of moderate and severe COVID-19 will be discussed by Dr. Dhiren. The most important interventions here are oxygen, steroids, and anticoagulation. Remdesivir role is questionable, and I think Dr. Ramanan will be discussing the trials with regards to remdesivir. So very quickly, in the next 4 or 5 minutes, I just want to show a case, which illustrates all these problems which are related to management of mild COVID-19. So this is a patient who is a 14-year-old girl who tested positive, whose parents tested positive for COVID-19 on 15th March, and the parents were admitted. The child was at home. The child was tested on 23rd March. She was negative. And she had fever on 26th. And she, at that time, was started empirically on oseltamivir and paracetamol, and a COVID PCR was done, which was positive with a CT value of 29. Her hemogram, CRP, etc. were all normal, and the patient got better. Now, you can see that there are lots of issues here. So there was no role of giving oseltamivir to this patient, because we didn't have flu at that time, and oseltamivir does not act against COVID-19. You see that this is a patient with early COVID-19 disease, yet her CT value is high. So it means that a high CT value does not always mean that the patient has had the viral infection for some time. It may just mean that the swab has not been collected properly. And while this patient underwent all these investigations, they were not required. Now, this patient went on 4 days later. The patient also underwent a CT scan, though she was not hypoxic. And if you see, she had these involvement, these GGOs in the lower part of the lung with a CTSS scoring of 6/25. She was started on favipiravir and steroids by the GP. Next day, she's a pediatrician, started on other antibiotics, and steroids were continued, and of course got better on 2nd of April. So again, what are the various errors here? That CT scan was not needed, it was done. Favipiravir is not indicated, it was started. Steroids, just because the patient had radiological evidence of pneumonia, were given, which is again not indicated. And then furthermore, the patient was given antibiotics, that 2,2-beta-lactams and aminoglycosides, which is again against all principles of antimicrobial stewardship. So again, all this was not necessary. So many errors in this single case of mild COVID. Now, all did not go well with this patient, because after remaining afebrile for 3 days, while she was on antibiotics and steroids, she again started running high fever. So again, she went to the same doctor, who again did her test. This time her lymphocyte count had fallen, but that could also be because of steroids. CRP was still normal. They did COVID antibodies also. I don't know for what reason, but they were negative. They checked for malaria, which was negative. Saturation was normal, but air entry was reduced on the right side. And again, a CT scan was repeated here, which showed that there was a progression in the illness. And while the earlier left-sided GGOs had gone, the new GGOs had appeared. This is just a real case, and it doesn't mean that you have to do these scans, but these scans were done in these patients. So of course, now the case throws up these questions. So what is the recurrence of fever due to? Is it still an acute COVID illness? because now it's almost 10 days since the, or rather more than 7 days since the problem has started. That seems more likely. Or is it a secondary bacterial infection, which appears unlikely because the patient was already on antibiotics, the CRP didn't go up, and most patients with COVID don't have bacterial infection to begin with. MIS-C is unlikely, that though 1 week had passed since the onset of the illness, but the patients had been on steroids. So it's unlikely that it is MIS-C, the recurrence of fever. So how would you manage this patient? Would you give remdesivir because you think this patient is also having viral replication? Would you continue steroids? What would you do to the antibiotics, or you would just give symptomatic care? And of course, this question does arise in your mind that giving steroids in the early phase have enhanced viral replication. That is possible because you're not allowing your body's own immunity to work against the virus, and you're giving steroids. So remember that the timing of steroid therapy is very, very important. So of course, in this case, we admitted her because she was her fevers were going up to 104. We did her test, which showed that the CRP had jumped up. Sorry, that should be 140 milligram per liter. Her D-dimer was also up. We stopped the steroids and antibiotics, and because she was still within 10 days of onset of the illness, and we believe that this is still active COVID, and she has got steroids, which makes her immunocompromised, we gave her remdesivir, with which she rapidly improved. So the case mainly gives those messages that children with mild COVID-19 actually need no intervention. They don't need investigations, which were done in this patient. They don't need CT scan. They don't need antivirals. To begin with, this patient got oseltamivir and favipiravir. They should never be given steroids, and they should not be given antibiotics. So maybe if this patient was left alone to herself, she wouldn't have gone on to the phase where she needed hospitalization and she needed other treatment. And maybe there is a small window of illness where remdesivir may work in some patients, not in all patients, but because antiviral drugs are most useful in the early part of the illness, there could be a scope for this drug. And that is maybe we can discuss later. And then finally, about newborn COVID, this second wave, it saw worse outcomes in pregnant women as compared to the worst wave in India. But luckily, like children, newborns also do well, even if they're born to COVID-19 infected mothers, because there's very rare intrauterine transmission. Perinatal transmission is there, but it is only between 2 to 10%, usually within the first 5 days. And while the viral RNA has been detected in breast milk, but there is really no role of breastfeeding in transmission. Most infected babies, so even babies don't get infected, but even if they get infected, they have no symptoms or mild symptoms, and only 10 to 20% of the babies may show symptoms, severe symptoms like poor feeding and respiratory distress. And of course, neonatal MIS-C is also being described now. So they are nothing much, in management of a COVID-19 baby born to a COVID-19 positive mother. You do your resuscitation with your full PPE, but you still carry out delayed cord clamping, and you practice skin-to-skin care. You room the baby with the mother unless either the baby is sick or the mother is sick. And you ask the mother to practice exclusive breastfeeding, but wear a mask and practice hand hygiene. Testing of the newborn should be done after 24 to 48 hours to avoid contamination. And if the baby is negative, you can test the baby again at day 5, but that's not really important, especially because most babies will be discharged before day 5. They can go home without a repeat test. But if you have admitted the newborn into a SNCU or an NICU, and if the first test is negative, on day 5, you can repeat a test. And if the second test is negative, you can transfer the baby out to a non-COVID area. But you should also remember to, even if the baby is discharged, that you tell the parents to bring the baby back if there are symptoms, and you test as soon as symptoms appear. These babies should be given BCG, OPV, and hepatitis B as per protocol. They should be discharged with their mothers. If the mother is admitted to the COVID ICU, then you can discharge the baby at 24 to 48 hours after training one family member in care of the baby. But you should also counsel these parents or caregivers about danger signs and try and do a telephonic follow-up for 14 or preferably 28 days, because sometimes delayed symptoms can appear. So finally, to summarize, I think COVID-19 is a mild disease, and we as pediatricians and children are really lucky for this. And it is important to test children, children with suspected COVID, even if symptoms are mild, so that we can triage them later if admission is required and also for epidemiologic purposes. But at the same time, now in the month of July, you have to keep your eye out for other illnesses, because it is quite possible that if a child comes to you with an acute illness at this time, when the cases are coming down, it is more likely to be due to a non-COVID problem. Mild disease needs only supportive and symptomatic care. For severe disease, you need actually good critical care support with steroids and anticoagulation. And if your baby is born to a COVID positive mother, you have to room the baby with the mother and allow for breastfeeding. And finally, as I said in the beginning, it is basically the indirect effects of COVID-19 that are more important than direct effects in children, and they need a whole lot of social interventions. Thank you.
Thank you, Dr. Tanu. There are some questions. I think I will come back with the questions after Dr. Dhiren Gupta finishes his pediatric intensive management of COVID. Dr. Dhiren Gupta is from Gangaram Hospital. It's a well-known hospital in Delhi, and he has got very rich experience in adult and pediatric COVID. And of course, he has got some special interests in radiology. Maybe he'll be giving the clear directions about the taking X-ray chest and CT scan for COVID. Over to Dr. Dhiren Gupta. Sir, Dhiren sir?
Sir.
Yeah, are you ready, sir?
Yeah, just.
Yeah.
Dr. Dhiren is a pediatrician, intensivist, and a COVIDologist all in one. To briefly introduce him, that's the best way to introduce him. Thank you, Dhiren.
I'm saving the time for a lot of questions are there.
Good afternoon, friends. And next 25 minutes, I'm going to talk about intensive care related issues of.
Sir, please unmute yourself, sir. You are muted.
Please unmute, Dhiren.
COVID-19. After Tanu Singh's presentation and the subsequent presentation of MIS-C, my issues are going to be just restricted to the intensive care. I'll try to simplify the things and as much as possible. One thing is very clear when we talk about acute COVID issues, during acute pandemic, we don't have much intensive care issues, especially respiratory one. But of course, whosoever lands up in intensive care, they do have some component of MIS-C, despite their MIS-C, despite their the COVID RT-PCR positive. We all know a lot about MIS-C. So my presentation will be just restricted to the intensive care, what actual issues we face as intensivist. So my aim is very clear. I'm going to talk about acute COVID ICU issues, some issues related with the MIS-C, only ICU related issues. And of course, when we talk about ICU, it's mainly complications we talk about. We all know that there are various spectrum which we see in intensive care. The problem during patient who is suffering from acute COVID, that is RT-PCR positive, you don't get good intensive care. You don't, it's always a little bit compromised. You don't have ultrasound, you don't have manpower to tackle those patients in, you can say, temporary made intensive care as compared to an MIS-C's RT-PCR positive. So still we get a lot of issues related with the patient usually present with hypotension, cardiac involvement. You give IVIG, steroid, and most of time they are uneventful. Recovery is uneventful. Second is you give IVIG steroid to these patients, but they require organ support. They require toxin removal by CRRT, and you need to give repeat IVIG. Same way, at times, patient just present with the organ dysfunction, and you require therapies like ECMO, mechanical ventilation, CRRT. And of course, as I told you, when these patients are suffering from acute pneumonia without MIS-C, most of the time they don't need mechanical ventilation. They are not very critical. They just got okay by simple management and time, just steroid, and you need not give drugs like remdesivir. Let's start with the cases. This is a 12-year-old child who presented last year with fever for 4 or 5 days, respiratory distress for 1 day, though RT-PCR there was negative. In our emergency itself, RT-PCR came positive. When patient came to us, he was quite hypoxic, saturation was 70. And you can see the PaO2 is 41 here. After giving BiPAP, the saturation become 98. The beauty of pediatric patient, pediatric acute COVID pneumonia is that response to therapy. Look at the chest X-ray, you can see bilateral infiltrate, more than just ground glassing. That's a little bit difference between, adult and pediatric. In pediatric patient, you may not get classical ground glassing always, but you can have various sort of pneumonias and various atypical pneumonia. This is a CT scan. You can view this is more than just ground glassing, as you cannot view the vessels inside. So it is just not ground glassing. It is a uniform sort of consolidation. What are the issues we face in these patients? What are the indications of CT chest in pediatric? We don't do CT chest even in adult, unless we find some complication related with acute COVID where hypoxemia is not improving despite of giving everything, or if you're thinking of some other differential diagnosis, or after 7-8 days, somebody is having problem like persistence of fever and RT-PCR time has gone away for 7 days when likely it is going to be positive. For diagnosis, you may rare circumstances, you may get CT chest in pediatric. Regarding ventilator setting, it has to be optimal. You start with non-invasive, don't go for invasive ventilation to start with, because invasive ventilation is difficult in acute COVID pneumonia. Keep everything moderate, like optimum PEEP. Just try to keep minimum PEEP and may require to give a little bit high oxygen. So it is a condition where you give high oxygen and low PEEP setting. As I told you, NIV is preferable over invasive, and you can try conscious prone ventilation. You just apply BiPAP or just apply HFNC and make the child prone. That is much better than invasive ventilation. Even if you land up in invasive ventilation, outcome is much better as compared to adult population. Drugs, of course, you are going to give steroid if there is a significant pneumonia. Remdesivir and anticoagulant is just doubtful. Nobody knows the role of remdesivir, but we usually give a patient of acute pneumonia with COVID RT-PCR positive, we give remdesivir even if patient is not immunocompromised. Regarding course of this patient, as I told you, RT-PCR came positive here. Total leukocyte count was 6,500. Child was big enough, so in this patient could get better in adult ward, adult ICU. And CRP was high, antibodies was negative, D-dimer was high. We gave remdesivir, methylprednisolone. We started with enoxaparin, and the outcome was perfect. The patient was discharged after 10 days. So the beauty of pediatric COVID, despite of sick disease, despite of severity of disease is too high, these patients show very good outcome. Not always, but most of the time. Now look at this is an unfortunate baby, a 4-month-old with a respiratory failure. He had fever since past 10 days. Cough past, patient was having cough for past last 6 days. There was an increase in respiratory distress. There were deranged liver function. Elevated ferritin, CRP was pretty high, D-dimer, LDH was high, hemogram showed anemia with leukopenia, chest X-ray showed bilateral infiltrate. I'm going to show you in the next ray. Patient desaturated when came, 70% saturation was there, required intubation. This patient required ventilator support for 1 month, and in fact more than 1 month. Various infection patient acquired, and ultimately the patient was lost. And look at these are the various chest X-ray, and this was a chest X-ray done before we lost this child. And you can imagine the patient not only had an acute COVID RT-PCR, but all the signs and symptoms of MIS-C. The ferritin was pretty high. There was a leukopenia. So ultimately, this patient has HLH also. So in less than 2 years, what we learned the lesson. you should rule out severe combined immunodeficiency and congenital HLH. In this patient, it was severe combined immunodeficiency, but congenital HLH, if you encounter a patient who is infant or less than 2 years, with severe, with critical respiratory involvement secondary to COVID, always think of HLH and SCID. Look at another child, 8-year-old, who presented to an emergency with lot of body weight, intense body weight. In fact, this patient called me online that everybody in the family is RT-PCR positive and this child is having intense body ache. Patient also had high-grade fever, 100, 300 for past 5 days. She was not able to move at all, not accepting orally. And he sent me the photo, he shared me these photos that patient has developed swelling all over body, especially on the dorsum of foot and the palm. This patient, I could diagnose on phone that probably she's having acute COVID, but there must be some component of MIS-C. So in this patient was admitted, and the issues here is, should we give remdesivir to this patient where there is no respiratory involvement? Probably there is no need. When to give steroid? Of course, whenever we are looking at these type of patients with MIS-C with hyperinflammatory signs, we should give steroid, and patient become fine after giving steroid, didn't show too much improvement, but required IVIG, and ultimately patient got okay. Now, we talk about acute COVID RT-PCR. As I told you, most of the patients who land up in ICU, they do have some MIS-C component. But there will be some patients who are just pure post-COVID MIS-C, RT-PCR is negative, and there are many intensive care issues related with these patients. And take my word, management of these patients is much easier than RT-PCR positive, because you have got a best tool in, you can say, which has revolutionized the whole management, that is ultrasound. This is a classical case of MIS-C. A 4-year-old with fever, high-grade fever for 4 days, cold extremities, look at the mucositis, look at the hypotension. Normally it is warm shock. Normally they are not fluid responsive shock. You just need to give norepinephrine. It is diastolic blood pressure is low. If narrow pulse pressure less than 1/3 of the systolic, you end up in giving epinephrine. Look at the mucositis in this patient. How we evaluate these patients in intensive care? I am not talking about ward. I am not talking about in my clinic. I'm talking about ICU related issues only. So clinical, we all understand. One, other than the ultrasound, one more therapy or intervention has changed the outcome. That is invasive arterial blood pressure. Normally, we put in all patients, we do arterial blood pressure monitoring, especially invasive one. Echo, as I told you, it gives you a lot of you can say help. It helps you in a lot of you can say parameters to find your therapy can be based on the ultrasound and echocardiography. How it helps? It can help in like diagnosis. Look at this is your coronary artery. It is well dilated. Look at IVC. Look at the IVC. It is well dilated. Look at the contractility. So 3 things I need to know when I do an ultrasound. One is inferior vena cava. Is it a dilated? Is it a collapsible? Ejection fraction, and second, coronaries. Coronaries at times helps in making the diagnosis if patient doesn't have classical features. This is another patient where ultrasound has helped in diagnosing pulmonary edema. This was a patient who was given fluid. This was our first patient last year, and patient was given little bit overzealous fluid therapy because we didn't know that these patients are fluid refractory. And patient land up in pulmonary edema. Patient had hypoxemia to start with. The patient was not hypoxemic. So X-ray was not very clear in giving you an idea about pulmonary edema. But look at your ultrasound lung. This is a typical ultrasound lung which is showing a lot of B line. We call it pulmonary edema. So this is below one is the normal one. Below 1 is a normal and above 1 is abnormal, that is B line. So ultrasound is one intervention which has revolutionized the whole management of COVID-related issues. Unfortunately, in acute COVID RT-PCR positive ward, we cannot take machine there. So it is limited to RT-PCR negative who land up in intensive care. Now look at this 6-year-old child who presented with fever for 5 days, loose motion for 2 days. This patient came this season. He had a shock with cardiac failure. CRP was 229, BNP was 26,000, ejection fraction was 45%. And this patient, as usual, required methylprednisolone, IVIG, epinephrine. And difference from other patient was this patient required to be in ICU for almost 9 days. Low-grade fever was persisting, right? And this BP is on epinephrine. Another point that CRP fell to normal, but after 7 days, again, there was a rise in CRP. And again, ejection fraction start dipping. So we thought of probably it may be refractory MIS. And on 7th day, we started giving second dose of IVIG, but blood culture, especially from the center line, grew E. coli. So actually, this was not a refractory MIS. This was due to your nosocomial infection. We'll talk how to chase this patient in intensive care. This is a recent patient. A month back, this child came, a 12-year-old who presented with fever for 4 days, neglected patient because for 1 day, patient was a little bit hypoxic and hypotensive, but at her home. And when patient came to us, he was in very, very bad shape. It's an altered sensorium, irritable, saturation was 92 on 10 liter. On epinephrine, 1 dose of methylprednisolone was given before the patient came to us around 6 hours back, but still patient had significant tachycardia and patient sensorium was very bad. Issues in this patient is definitely going to be the intubation, especially because patient is an altered sensorium. What you need to do, you need to reassess the preload before you intubate the patient. At times, not only they require fluid bolus, but they require good inotrope. Otherwise, patient can let up in cardiac arrest during intubation. So inotrope should be on flow. In this patient, there was persistence of tachycardia, neurological deterioration, as I told you. In fact, within next 12 hours, patient started posturing on ventilator. And there was a persistence of tachycardia even after 36 hours of starting therapy. And patient fever was persisting. It was high grade. Patient was very toxic. We thought of refractory MS in this patient, but what we found that CRP and other biomarkers started decreasing within 24 hours. So this type of diseases do create a lot of confusion when we deal with intensive care. If fever is persisting, CRP and procalcitonin has started dipping, but patient is very toxic. So you start thinking of giving biologic or something else. But instead of giving biologics, we thought of clearing probably we thought that IVIG and steroid is going to take time. So let's clear up the toxins. So one therapy helps in intensive care, that is renal replacement therapy with filtration. Filtration, if child age is more than say 5, 6, 7 years, where you can use auxiliary filter that is a little bit cheaper. Only one filter has to be used. So more than 30 kg, you can use auxiliary filter. And within 2 hours, these filter, whenever you do CRRT, within hour of starting therapy, patients usually become non-toxic and afebrile. So it gives you time for drugs to act like steroid and IVIG. So this patient, fortunately, despite of neurological handicap, this patient was ultimately extubated and 7th-10th day patient was discharged, and this was a child of a doctor. So the outcome of MIS, the beauty of these patients, the outcome of MIS with COVID RT-PCR positive or without RT-PCR positive is hugely good. This was a patient who was a small baby, around 4-month-old baby who presented with like Kawasaki with antibodies positive. This patient landed up in refractory MIS and needed your infliximab. This was the only patient who required biologics. When we talk about refractory MIS, the definition is very difficult, not clear at all. So when we talk about refractory, so classically it is defined as persistence of fever after 2 days or reappearance after 7 days. But usual defervescence is within 24 hours starting adequate therapy, whether it is your steroid or whether IVIG. In classical Kawasaki disease, normally we wait for 36 hours after finishing up the IVIG, right? But what happens to those patients if fever persists beyond 2 days? If there is no guideline which helps us. Let's take few of the example. If fever persists after 48 hours, but patient is clinically stable and fever is settling a little bit, especially CRP and procalcitonin is decreasing more than 50%, you can wait and watch. But if inotrope score is not high, but also rising, so initial inotrope score is very high and also it's increasing. CRP is rising after therapy, like you give IVIG and steroid. Next 36 hours, next 24 hours, you find that CRP, instead of decreasing, it is increasing. You need to change the gears. What gears we'll discuss. Many of the patients may become afebrile. Your CRP may started getting settled, but they land up in significant organ dysfunction because they came late to us. So may require renal support system, cardiac support system, and respiratory support system. But friends, when we talk about recurring fever after a gap of, you can say 2 to 3 days of without fever, patient is on invasive line or respiratory support, rule out nosocomial infection, what I told you, what I showed you in my patient. What is the second line of management? Irrespective of guideline, most of the patient do just require IVIG, or you just escalate the dose of steroid. If you're giving 10 milligram, increase to 30 milligram. Very rarely you will find drugs like anakinra, which are not easily available, or tocilizumab are being used in pediatric patients, especially if toxic shock syndrome like picture. But if there's a refractory Kawasaki like, you may end up in giving infliximab, which I showed you. They're very, very rare. Most of the time, second dose of IVIG is needed. Look at this 13-year-old female, fever for 3 days, loose motion and hypotension. She presented with a cold shock. She recovered from the shock by giving inotrope, by giving IVIG, by giving steroid, but on 6th day land up in major seizures. Her pupil became sluggish. MRI showed typical ADM-like picture. Already on methylprednisolone high dose, IVIG, she was referred here. When she came to our intensive care, though hemodynamically little bit stable, she was having significant tachycardia. Pupils were very sluggish in reaction. And next 24 hours, what we found that there was no movement of limb and diaphragm at all. There was a symmetrical large fiber motor axonal polyneuropathy. It was different from critical care neuropathy, myopathy, was behaving like a Guillain-Barré syndrome. She was given 5 cycles of plasmapheresis and she showed wonderful improvement, and ultimately she was off tracheostomy. Look at this another child who came recently, a 7-year-old with pain in abdomen for 7 days, rising liver enzyme, increasing irritability. So it looks like only abdomen is having problem. No, so see, she came last year in around November or December. There was increase in SGOT, SGPT, there was increase in irritability, and she'll end up in refractory cardiogenic shock. Look at the blood pressure, 52/35. Look at the child. And she was in hypotensive shock despite of giving epinephrine to 0.5 microgram per kg per minute and levosimendan. And this patient, within 18 hours, we need to start ECMO. And total time required for this patient for an ECMO was just 5 days. Again, the beauty of MIS-C is almost 100% recovery. So complete recovery is a rule unless proved otherwise, and patient was ultimately discharged. When we talk about organ support, there can be CRRT. CRRT we use very often, especially with filtration. As I told you, either it is a Xeris filter or cytosol filter if age is less than say 6 years, weight is less than 30 kg, and indication is whenever you find 10%, more than 10% fluid, positive fluid balance with toxemia, with or without renal failure. So we don't wait for renal failure, right? Now we come to ECMO. ECMO, again, rarely you will need, but you should know the indications, especially refractory cardiac failure. Normally, for respiratory reason, we don't need ECMO. Many of these patients will require respiratory support in form of non-invasive ventilation or high flow or invasive ventilation. This is our data of previous 90 patients, not last year, this year. You can view that, you can see that repeat IVIG was given in almost just not more than 7 patients. So these were actual refractory patients where just we needed IVIG. Nothing else. The patient of small baby where we gave infliximab was of last year. And inotrope was needed in 43% and respiratory support was needed in 48%. This was these were 90 patient and main age group was 7 years. This is being analyzed and going to be published. Main is the GI involvement followed by cardiac and the respiratory. Respiratory, it is the main, the pulmonary edema. And again, one point I want to focus is CRP. We are trying to correlate the severity of disease with the CRP and procalcitonin. Probably we are going to find a value of CRP that will, before these patients end up in refractory shock, we may be able to define, okay, these are the patients who require it, you can say a level 2 or level 3 ICU. Average stay, as I told you, outcome is a rule, is 8 days plus minus 6 days. And in the average financial burden because of IVIG is pretty high, is around 4.5 lakh. And very rarely we lose the patient. The patient which we lost, patient was discharged and developed HLH. There was a sudden increase in ferritin to 50,000. This was the only patient we lost. Now, regarding differential diagnosis, when these patients in intensive care, rest of we are going to discuss in MIS. 2 points I want to make. One is SLE, one should keep in mind. Second is a pancreatitis, especially if there's abdominal catastrophe and appendicitis. So DK, appendicitis, pancreatitis should not be forgotten. When we are making differential diagnosis, we land up in critical disease. And the very important differential diagnosis is hemophagocytic lymphohistiocytosis. You can say MIS is a sort of HLH, but it's a difference is there. There's an increase in ferritin, there's an increase in liver enzyme and cytopenia. And these patients, take my word, require long and prolonged steroid therapy. High risk feature for a clinician. If any patient with refractory shock, we all know that it belongs to high risk feature. But if you find CRP, especially more than 150 to 200, procalcitonin more than 5, even before they land up in major problem, they indicates this patient is going to land up in major problem. And again, very high ferritin, more than 1,000 to 2,000, that indicates a component of HLH. These require more steroid, high dose steroid, and prolonged steroid. A patient who is suffering from severe pain in abdomen, believe me, these are the patients should not be admitted in a small nursing home, should be referred to a patient hospital where there is a good ICU. So conclude my presentation with some take-home messages. Of course, early recognition not only saves mortality, but also saves morbidity. Overdiagnosis and misuse of IVIG and steroid are going to happen. Be careful before you start steroids, especially. Steroids only, people ask, probably MIS-C person is going to discuss about that. Pancreatitis with MIS-C and DK, you try to avoid steroid. And you need good prospective studies to define our queries, which are specifically Indian queries. And now we are going to have a lot of diseases like dengue and scrub typhus. So beware of these diagnoses. Just don't jump to the conclusion of MIS-C. Thank you very much.
Thank you, Dr. Dhiran. Very nice way of presenting the different case scenarios in the PICU. Now, very shortly, 5-7 questions are there. I think the panelists will be answering. The first question to Winsley Rose. Are you there, Winsley Rose? Dr. Winsley Rose?
Yes, sir.
Yeah.
Yes,
So somebody is asking, is it the spike protein is only pathogenicity? They are asking. Is it only the spike protein is causing all problem? This is the question somebody is asking. The next question is when we
So the spike protein is actually what attaches itself to. There's a receptor binding domain in the spike protein, the S1 part of the spike protein. I mean, that's what attaches to the host cell and gets entry into the cell. So the other proteins are all involved in other functions of the coronavirus cell itself. So, I mean, the spike protein is one of the components which is important for entry into the cell. So, if you have an antibody to the spike protein, which is what happens with vaccination, it can actually bind to the spike protein and prevent entry into the cell. So, that's how it will work.
Okay. And other questions are why MIS-C more children in compared to adults? Why MIS-C is happening in children in compared to, I think Dhiren Gupta sir can answer this later. And role of influenza vaccine, I think that could be discussed during the vaccination topic. And the very common social question is risk of sending children to school, vaccinated or not vaccinated. This was question asked. In fact, I can answer that question because what I say is called double protection. If the parents of the 18-year-old or below 18-year-old children are vaccinated, I think the children will have a protection. I think now we'll go to the questions to Tanu Singhal, madam. Tanu, why viremia, when viremia is there in a pre-symptomatic child, why serology is negative? That's the question they are asking. I don't know whether they're asking about IgG or IgM. What they say, when the child is pre-symptomatic stage, when the viremia will be there, but why the antibodies are negative?
So viremia is not so common. We talk about viral replication, but there is an overlap, So by day 7, day 8, you actually have both. You have still viral replication going on and you have antibodies appearing. So it is not that both the things are mutually exclusive. And in fact, what you find is that in children who are having severe disease or rather adults with severe disease, by the time they come into hospital and they're admitted, they already are antibody positive. So both the things happen together.
Okay, and somebody is asking, now many children are coming with gastrointestinal symptoms. Do you prefer any special investigations for doing that?
Okay, so gastrointestinal symptoms, in fact, at this point in time, most children have gastrointestinal symptoms not because of COVID, but because of viral diarrheas or bacterial dysentery, because there's a lot of water contamination happening, at least in Mumbai. So we are managing these children symptomatically. We are not really testing them for COVID because the COVID numbers have really gone down dramatically. So we just, if they have blood in stool, we give them antibiotics. Otherwise, we just give them electrol and zinconia, etc., zinc supplements.
Madam, this is my question. And you said in one of your slides that it is very difficult to predict MIS-C in children, whether the children is going to get or not. So some of the trials have shown that the children with the less viral load, where the interferon response will be very robust and very fast, which can clear the virus, those children are not getting MIS-C. Similarly, the children with excessive viral load, that there will be a delayed interferon response. That means the clearance of virus may not be happening that much, and those are the children can expect MIS-C. Do you agree with that?
Yeah, so maybe these are research-based findings, but in clinical practice, we don't have a way to estimate the viral loads because those quantitative tests are not available. The CT value is not a good surrogate marker for the viral load. So just by seeing what is the CT value of the child's RT-PCR, we won't be able to predict. So maybe we'll need more research data to predict which child will have MIS-C, but otherwise there's no way of telling.
Dr. Srinivas.
Yeah. Sir?
Yeah, just sorry. I just unnecessarily intervened. Just one point.
Yeah.
See, I think all these are speculation, right? If you look at 90% of the patient, but I analyze my data, 90% of the patients were asymptomatic then when they acquired this COVID infection.
Yeah.
If this would have been true, probably they should have some infective signs of infection during acute COVID time. Again, this is speculation. Why I'm saying so? Because this virus has proven everybody wrong over the time. Now, one question I want to ask, because, this is a very difficult question. I try to get an answer. A patient, an adult patient, lands up in inflammatory state within 7 to 10 days, 15 days, and had lung involvement. Now, a patient having MIS-C, after 2 to 6 weeks gap, 90%, 10% do land up in acute problem, but most of them do land up in post-COVID problem, where lung is not involved primarily, where other systems are involved. Why this difference is there? One. Second, why IVIG is a drug of choice for a patient of MIS-C, but steroid is a drug of choice for post-COVID inflammatory state in adult? Leave aside MIS-A, that is very rare and we are not talking about. Is there a major difference in pathophysiology? Because now we are looking at, even in pediatric MIS-C, steroid are going to be major drug of choice rather than IVIG. So is there a major difference in pathophysiology why lungs are not primarily involved in pediatric MIS-C and lungs are primarily involved in adult MIS-C?
Okay.
Adult COVID, post-COVID.
Fine, sir. And the question is for you, sir, Dr. Dhiren Gupta. Usage of remdesivir in children. Somebody is asking. Even I have an experience. I have treated around 1,500 children. In 3 to 4 children, I have given remdesivir. I have seen an excellent result, even though WHO and ICMR say that it is not at all indicated so far. In fact, in Tamil Nadu, the physicians, they really come and say that when they use remdesivir in the adult in the first 1 week, they have seen excellent results. That was happened in Tamil Nadu, where the death rate also is very low compared to the other states. So the physicians are of the opinion that utilization of remdesivir is a must in the adult when they use before 7 days. The results was excellent. But in pediatrics, since we have not have much experience, but I have treated a child with COVID encephalitis with COVID pneumonia. After giving remdesivir, I have seen an excellent recovery. The child went discharged after 14 days. So shall we say remdesivir should be based on the case, or it is not at all recommended?
Sir, first of all, first answer. In general, what is the status of remdesivir? Why WHO, government, state government, and you can say academicians prefer to get remdesivir when it comes to their personal level, but when they are on stage, they say about the guideline, okay, this is not indicated, this is not indicated. One is that this disease produces so much scare. People try to get whatever is possible in this world when it comes to themselves, right? Whether he's a top-level academician, whether he lives in AIMS or, whosoever is. I should not name the institutions. Now we come to the actual science. Actual science probably is not well, explored when we talk about remdesivir. There are small trials which indicates probably this may benefit, which may indicate like solidarity trial. It may benefit, but it doesn't affect the mortality. These type of confusing statements. Dr. Tannu Singhal will agree with me. Last year, I was on opinion that within 1 week, you should give remdesivir. This is the best time when you give remdesivir. So in many of the patients, I myself treated, I gave remdesivir within 5-7 days. They were high risk, they were obese, and they were having high grade fever on 3rd, 4th day, right? Around 35 patients last year, I gave remdesivir without having significant pneumonia or hypoxemia or early oxygen requirement. In those subset of patients, almost 20 patients lands up in late cytokine storm despite of early remdesivir and steroid being given at an appropriate time. So one thing is very clear, this virus is much smarter than what we thought, what we are. Second, this drug is a sort of compromised, repurposed drug. It's not very effective drug. I won't say that it doesn't benefit the patient. But this year, I had around 895 patients whom I treated online, around 400 patients who were on oxygen requirement, minimal oxygen like saturation 90, 91, 92. Around 400 patients didn't get bed. Also, they didn't got that remdesivir either. They were just treated by steroid. And what I could say, again, when I say I, it means I doesn't have data of a robust data, which has been taken from, big population, has been well analyzed. It is in my brain and my experience. So we cannot take it as a, final word. But my experience says that this year, there was no difference at all. Only one management differed, made the difference. That is the appropriate dose of steroid at an appropriate time. That is the only drug. So from my side, drug number 1 is steroid, drug number 2 is steroid, drug number 3 is steroid at an appropriate time with and without remdesivir. Now we move ahead to the pediatric. In pediatric, in most of the patients who land up in a significant respiratory problem, many of them have comorbidity. So we have given remdesivir to all the patients. So I cannot say without remdesivir what must have happened to these patients. So in nutshell, remdesivir, if possible, you can give it, but don't think that this is going to be a major tool against this virus. It is an appropriate dose of steroid, and probably in very high risk patient. I missed Dr. Tanu Sehgal those slides because I was on some other platform also. Early use of immunoglobulin, that is your the combination of monoclonal antibodies, may help. The number of patients required to treat is very high, but this is the only therapy which can be given in very high risk patient. At least 70% benefit of not getting into hospitalization may help, but probably it is the vaccination. That is the answer. Thank you.
Last question, sir.
I think these questions will be answered in Ramanan's discussion. The remdesivir. Quick comment on remdesivir from Dr. Tanu Singhal, and we'll wind up this session.
The last one question to Dheeraj, sir. Last one question. So regarding the CT test.
Please close the session in 1 minute. Please close the session in 1 minute.
Yeah. So regarding the CT chest, regarding Dr. Dhiren Gupta, I have seen comorbid children and children towards adolescent are showing peripheral ground glass opacity, which was not fixed up in the X-ray chest. Is it going to help in the post-COVID follow-up, whether the child is going to have a scar in the lung, something like that?
No, sir, because recovery, even in adult, means it is almost a rule, almost in 90% of the patient, though it may take 3 months, 6 months. And pediatric patient, it is, I haven't seen even a single patient suffering from lung morbidity after 6 months or 9 months. So probably it is unnecessary.
Thank you, and I will close the session now.
Comment from Tanu on remdesivir. Quick comment from Tanu on remdesivir, and we'll wind up the session.
So I feel that there is probably a role. So the truth is somewhere between no benefit and a lot of benefit. So if you have a carefully selected population of patients and you use it at the right time, you may get benefit. So that is what I would like to say.
Exactly, madam. I think I agree with that also. So we'll close the session. We'll go to the next session. Thank you.
Thank you, Professor Srinivasan, for the brilliant moderation. And of course, Dr. Winsley's presentation, Dr. Tanu Singhal's presentation, and Dr. Dhiren's were outstanding. Thank you very much. Unfortunately, we can't extend the timings because we started a bit late. Thank you, Dr. Winsley, Tanu, and Dr. Dhiren. Brilliant, outstanding. Thank you. We'll move on to the next session. This is on pediatric COVID vaccination. And the moderator for this session is none other than Dr. Jagdish Chinnappa. Dr. Jagdish Chinnappa needs no introduction to this august audience. The consultant pediatrician, head of the Department of Pediatrics at Manipal Hospital, a pediatric ENT physician, pulmonologist, and whatnot. He's going to conduct the panel discussion, and the expert panelists are Professor Jacob John. Welcome you, sir. I don't think it is necessary to introduce the father of pediatric vaccinology in India, and he'll be accompanied by Dr. Sanjay Srirampur from Hyderabad, who has held very important posts in IAP and in the ACVIP several times, and the vaccine man of Pune, Dr. Sanjay Lalwani, who was probably, as far as I know, he's one pediatrician who has probably been involved in most vaccine trials in this country. I welcome all of you and hand over the proceedings to the moderator for this session. That is Dr. P. Ramachandran, who's the professor of pediatrics at Sri Ramachandran College and infectious disease expert and a vaccinologist. Over to Dr. PRC. Thank you very much.
Good evening, everyone. Thanks, IAP TNSC and convener Dr. Balasubramaniam for this opportunity. The COVID vaccines is probably the only situation where we are the non-playing experts. Very, very unusual for the pediatricians not to be involved in actual vaccination against disease. Probably this is the only situation where we are having a lot of knowledge about vaccinology, but we are now applying it mainly for our own selves, our colleagues, and our friends, and all the nurses and other workers who are working with us, and also looking at it in future of this vaccine. So we have the experts on this. So without wasting much time, I will now hand it over to Dr. Jagdish Chinappa to take over the session. And I'll request the people to conduct the session in about 45 minutes. I'll give an indication 5 minutes before the 45 minutes, so that we'll have at least 10 minutes for the discussion and for people to participate. Thank you so much. Over to Dr. Jagdish Chinappa.
Thank you, Professor Ramachandran, for that wonderful introduction. At the outset, I must thank the government of Tamil Nadu, the IAP Tamil Nadu branch, and Dr. Balasubramaniam for inviting us for this very important session on pediatric COVID vaccines. My panelists, as you can see, are distinguished people. And is my screen visible?
Yes, sir.
Yes,
Yeah.
Jagdish.
Thank you. So my panelists have already been introduced. I think Dr. Jacob John, Dr. Sanjay Srirampur, and Dr. Sanjay Lalwani do not need any introduction to this august audience. So we'll straight away go in with the COVID vaccine. Basically, these are the three main discussants for today. Professor Jacob John, as you know, is from Vellore. He is a very prolific writer and a past president of the Indian Academy of Pediatrics, a retired professor, vaccine expert, and a WHO consultant. Professor Sanjay Srirampur is a consultant pediatrician, past CEC IIP head, member of the ACVIP. Dr. Lalwani is one of the premier researchers on vaccines in India. Basically, we will start this vaccine discussion by saying that we have got three groups of doctors and three groups of patients also. Basically, as far as doctors are concerned, very few of us are really against vaccines, but there are a large number of people who are skeptics. And there are some who are protagonists or who will promote vaccination. Now, what are the points which the protagonists or who say that all children should get the vaccine quickly say? One, they say that the significant disease burden in children, like adults, it's going to spread right across to children, right? And since it's going to be the third wave, children are more likely to be affected. So this is one of the hypothesis. The second thing is that if there is prolonged circulation of the virus in the community, it can promote dangerous variants of concern, and therefore you need to vaccinate children quickly. And finally, you have the costs of disease surveillance, testing, infrastructure, staffing, etc. if you continue with the disease for a very long period of time. And the only way you can bring it down quickly is by vaccinating. Now, if you look at the skeptics, the other thing is, of course, spread to the vulnerable population, the elderly and the people with chronic disease. Those who are skeptics come up with saying that trials in children are at a very nascent stage. We don't have any real robust trials. The vaccines are not even authorized for use in adults as yet. Most of the technology that is being used for these vaccines are new technology, like you had the mRNA vaccine, the DNA vaccine. The adjuvants are new. like what you saw in, let's say, the Novavax or even the Bharat Biotech vaccines are new adjuvants. Adverse events are not covered by compensation in any of our public health measures. And other thing is, children are at low risk. And why should they be subjected to some risk, primarily to protect adults? So there is a plea for vaccinating only high-risk children or older children who are likely to have disease like adults. And there is another statement which says that the natural disease produces a more efficient immunity than vaccination, which I'm going to come to in a little time. And the point is, right now we have some vaccines which may not be the best vaccines, and we may settle for an inferior vaccine and not allow the child to take a better vaccine in, let's say, 6 months' time. Finally, there will be issues of vaccine availability. Even now we have problems with vaccine availability, and we should still prioritize adults who are likely to get severe disease. And the other thing is that if you're going to spend a lot of money and logistics to mitigate the disease, you might use it for other long-standing child health issues. So these are some of the points which are for and against immediate vaccination of children. So first I will start with Dr. Sanjay Shrirampour. We already heard from Dr. Tanu Singhal that children are not at great risk for getting the disease. Neither are they very important in transmission of the virus, as many studies from the school transmission have been done in many of the countries. So can I ask you, what are the significant problems with COVID in children?
Jagdish, if you look at whether COVID is a significant illness in children, we need to look at into two perspectives. Till recently, we thought that children will not get affected with COVID as much as adults do. But there are now studies which show, even the recent ICMR studies and the CDC data show that children are equally affected as much as adults in terms of infection. Though the second point is children below the age of 5 years, the incidence of COVID is less, but it is as much as it is in adults over the age of 50 years. So in terms of COVID happening in children, yes, it happens. Now, the second part of the question is it significant in terms of morbidity, the disease? There are well-documented studies all over the world which show that children are mostly mildly affected or they are asymptomatic. Now, this is in terms of the severity of the disease, and the presentation in children is also different from adults. Now, are children implicated in the transmission of virus? Children are implicated in the transmission of virus as much as adults, though children may not be super spreaders. But we need to take into point two considerations, is that you have a large population of adults who are vaccinated, number one. Number two, a large population of children who are asymptomatic and they may transmit the disease. So this is my take, Jagdish.
Thank you, Sanjay. I would just also come in and ask you, since this is a new disease, do you think that there are some reports, long COVID in children with children affected by long COVID? That is, they are symptomatic about 3 months, 6 months after the COVID illness. So what is your take on that?
As of now, there is not much robust data of long COVID happening in children. We just heard Dhiren's experience actually. Children do not suffer from COVID or its long-term effects. There is no robust data, but children generally do not get long-term COVID.
Sir, Dr. Jacob John, would you come in and comment on that?
Let me say two things. Am I audible?
Yes, sir.
Yes, sir.
Okay. Let me say two things. One, that as far as transmissibility goes, it depends upon where the virus is amplified, in the lungs or in the upper respiratory tract. When it is in the lungs, even the air that you breathe out through the nostrils contain virus. But if the lungs are not infected, then the virus is not in the air. So why are we socially distancing to prevent transmission? Because the air that you breathe out or droplets that you produce when you speak are laden with viruses in adults, not so in children. Unless children have you have prolonged contact with children, and children have sneezing, coughing, or snuffles, then they are infectious. Otherwise, they are not as infectious as adults, merely because of the fact that lung fluids do not contain virus in children. That it's a continuum from young towards 18 years of age. The second issue, well, I think I will stop here unless you have a specific question.
Sir, I think that's very clear that there is illness in children, but however, they are not as infective as adults. So that is the bottom line here.
Long COVID is, I think, more or less the same frequency as adult long COVID.
Yeah. So I think there have been some studies which have come from Switzerland just about a week back, which have shown that the prevalence is almost about 4%. 4% of children who have COVID land up with long COVID, lasting for more than 12 weeks. Sir, regarding this vaccine trials, we are coming to Dr. Jacob John now. Regarding this vaccine trials of COVID vaccine in children, there have been a lot of ethical shortcuts. They've been combining phase 2 with phase 3. Then a point is about the informed consent. Getting in, there have been accusations of children who are not able to give, or parents who are not understanding the informed consent process being included in the trials. Any comments on these?
Yes. Of necessity, you will expect trials not to include children from the beginning. So it's a gradual work down from adults to children, and in children, lowering of the age, 18, 12, 6, then 2, something like that. The ethical issue is not a very simple question. It's a very complicated issue. There is ethics in giving a vaccine that is not well characterized. There is ethics in not giving a vaccine which is safe and it promises protection, but you have not measured protection yet. Okay, there is a range of issues in ethics. So the normal rules of ethics do not apply in a pandemic time, and we need clear thinkers without any conflict of interest. And such people will have to make a decision. So it's not an ethical shortcut, it's an ethical modification that we require. Imagine if the vaccines were allowed by end of last year, how many lives could have been saved during the second wave? So ethics cuts both ways. There is ethics in doing things and there are ethics in not doing things.
So what you mean to say, Professor John, is that we are moving into a new framework of ethics, which is going to fit into a public health response rather than individual rights. Am I right?
Absolutely right. That is, vaccine has two roles. One, to protect lives, and two, to control the infection so that everybody gets the benefit. Those who are at risk of death and those who are at risk of simply mild infection. Everybody gets protection. So the approach of these two are different. We always knew that a programmatic use of vaccine is for the latter purpose, whereas an individualized vaccine is for the former purpose. So as long as this vaccine is not licensed in the country for general use, it's only available for the government to decide what emergency use they will approve. So then it is the public health programmatic use of the vaccine that is currently going. I believe both companies have applied for full license, both Bharat and Serum Institute of India. When the vaccine, if they're licensed, then the question arises as to whether we should give the vaccine or not to individual children. We will not come to that if the questions arise.
The other problem which is there, Professor John, is none of the data which these trials have done is available in public domain. Still, it is with the government to bring this out. The phase 3 trials are not out as yet.
Phase 3 trials of the AstraZeneca is well known.
No, that is different, sir. We are talking about the Indian vaccine.
Indian vaccine. I've seen the phase 3 trial results. They have been submitted to WHO, to the government, and it's also pre-publication copies available. I can send it to you. Okay. It is more or less the same as this second analysis. It's against symptomatic COVID, it is 78%. It was within the 95% confidence interval of the second analysis. Okay, and even the first analysis. In terms of severe disease, ICU admission and mortality, 99%.
Okay.
Just like almost every other vaccine.
Right, sir. Thank you very much. Can we also just discuss quickly about the vaccines outside India? Because Dr. Lalwani will be discussing about the vaccines inside India. And the outside India, there are 2 vaccines at least which have been authorized for use in children. Recently, I think just yesterday, Moderna also got their vaccine for children authorized by the European Union. So what are the data? Do you think that the data which is available abroad is robust enough? I know for 12 to 18 it's available, but less than 12?
No data that I have seen in less than 12. And when they have used vaccine in the 12-year plus, they have identified a new side effect. Some cardiac problem, pericarditis, myocarditis. It is not that infrequent. That is, it's about, I would think, 1 per 15,000 or 14,000 adolescents. I'm talking about the Pfizer vaccine. Moderna, we'll have to wait after it's rolled out, and then we will know. Fortunately, these are short-lived, self-limiting diseases as of now. Whether this has any longer-term effect on the heart health, we'll have to wait and see. So caution has to be applied for simply extrapolating from adult use to children's use. Since you mentioned about Covaxin, I can tell you that from immunological point of view, being a totally inactivated virus vaccine, it should have no additional similar adverse events that we are discovering with the other vaccines in this vaccine. That's the expectation. And so far, children above 6 have received their second dose in the vaccine trial of Covaxin. And I think it's about 200 or 300 children. So far, so good. Now they're going to give the second dose to children about 2 years. A lot of children have been given first dose. They're waiting for the second dose. So we will wait and see whether that pans out to be safe and effective. There, if efficacy can only be measured by neutralizing virus neutralizing antibody correlating with the adult virus neutralizing antibody, you cannot look for clinical vaccine efficacy at all in children.
Now, while we are at this neutralizing antibody, there are a lot of objections saying that this is not a good way of assessing a vaccine response because there are so many factors which could come in, and this may be just one of the factors. What do you say to that, Professor John?
Which virus neutralizing antibody?
Yes.
Okay. No, virus neutralizing antibody is the gold standard in terms of assessing protection. Okay. The anti-protein antibodies, whether it is N protein or spike protein 1 or RBD, they do not seem to correlate because it's simply binding that is picked up in ELISA. This probably is a quantitative issue, not a qualitative issue, because it's positive, it shows you are infected. So once infected, you must have certain degree of immunity. So that's not a clear picture yet. And of course, nobody is measuring cell-mediated immunity in any of these situations. So that also is an additional factor involved. But the gold standard for every vaccine before it goes to human trials is the induction of virus neutralizing antibody. And anyway, if there are new variants, how do you assess whether there is protection against variants? Again, you go for virus neutralizing antibody and you see the gradation against various variants.
True, sir. So, Dr. Lalwani, you have been at the forefront for doing trials of vaccines in India. So what are the likely vaccines which are likely to be available in India for children in the near future?
I'm audible?
Yes, sir.
Yeah. So if you look at the COVID vaccines which are licensed in India at present, is AstraZeneca, Covishield. We have Covaxin by Bharat Biotech, and we have the Sputnik by Dr. Reddy's lab, and I think to get licensed will be Zydus Cadila. Now, if you look at the pediatric perspective of the trials, what has been done is Zydus Cadila. The phase 3 trial for Zydus Cadila is through, and the children between 12 to 16 years were included in this trial. And I think so the trial is over, and I hope so that this vaccine could be licensed, the first vaccine in the pediatric population. Now, the only hitch here is it's a DNA vaccine, and logistic wise, the 3 doses are required: 0, 28, and 56 days. And you have a special injector which has to be used in the field when you are going to give this Zydus Cadila vaccine. That's number one. Number two, as far as the second license which could get through would be the AstraZeneca, because they have finished the pediatric trial in the UK population. And because of the relaxation of the DCGI, if the vaccine is licensed in European Union or the other unions, then they would not be requiring bridging studies to do in the pediatric population. This being a pandemic time, I think there would be an emergency licensure of the Covishield by AstraZeneca in India. And the third vaccine, I think the trials are just going to start in another week's time, is the Novavax, which is the subunit vaccine, and the technology transfer has taken place. And I think Serum Institute of India would start this Nasovax, which will become Covavax in India. So, and of course, we have the Indian-owned manufactured vaccine, the whole kill vaccine by Bharat Biotech, which also are in the phase 2 and phase 3 clinical trial. So that the vaccine which could get licensure first, according to the data available, would be Zydus Cadila, above 12 years. The second, of course, would be the AstraZeneca if the UK trial gets through and there is no bridging study required. The Bharat Biotech phase 2/phase 3 studies are in, I think, few sites in India. And the last, of course, will be the Covax or the Novavax. I think these are the 4 vaccines, but I personally think so. Now, even if the pediatric vaccine gets licensure in India, we are a long way ahead before really looking at the pediatric vaccination, because we look at the numbers getting vaccinated in India, we are far behind the desired numbers which the government wants to roll out. So even if the vaccine gets rolled out in India and they get the emergency permission to use in pediatric population, they would not see the light in year 2021 is what I personally think so.
Thank you, Dr. Lalwani. Just a few clarifications from your excellent summary of the data. I think the AstraZeneca vaccine, they are put on hold as far as small children are concerned, primarily because of the thromboembolic complication, which has been noted in young adult females. So what do you think about that? Do you think that it's going to be easy to get this vaccine licensed in our country? With the risk of thromboembolism, especially in adolescents?
Yeah, I think the trial for AstraZeneca in the younger population, there has been a hold because of thromboembolic phenomena. And I'm sure the DSMB board would shoot at that. When we started this AstraZeneca trial also, if in the adult population, there was a hold because of transverse myelitis associated, and the trial was hold for 2 or 3 weeks, and then there was a European clearance, and we restarted the trial. Let's look at what's the data coming out. But suppose if this trial has to go ahead and gets licensure in the UK market, I'm sure looking at the pandemic, the DCGI would look at whether to sanction or not. But I think the first to hit next month, of course, from the clearance would be Zydus Cadila.
So according to you, in this race of, we have 5 vaccines in the race, I think the front runners will be Zydus Cadila and Bharat Biotech. Am I right?
Yeah, another vaccine which Pfizer is conducting a trial in the US, where they have enrolled 4,500 children between the age group of 6 months to 18 years. And I think phase 3 studies are on. If the Pfizer vaccine, the mRNA vaccine, gets its clearance in the pediatric population, I'm sure, and if the vaccine would be available to in India, then of course, that would be the another vaccine where it could be available to Indian population if it's imported and used in our country.
2 issues, Dr. Lalwani, regarding the Pfizer vaccine. One is the storage, because I know they have relaxed the storage for about a month. So by under normal circumstances, but do you think that creation of this cold chain is going to be easy?
I think the success of both the vaccines which are used in India of AstraZeneca and the Covaxin has been the temperature storage of 2 to 8 degrees centigrade. But the another vaccine which would find its easiest way, and I think I have been having a dialogue with the Serum Institute, is the Covax. The Covax is a very long shelf life as compared to the AstraZeneca and the Covaxin in India, which as on today, the printed shelf life is 1 year, but the Covax shelf life is much longer. So I think whatever data has been coming out for Novavax looks to be a promising vaccine if it gets licensed into the pediatric population.
Thank you, Sanjay. Dr. Jacob John, I have a little problem with the DNA vaccine in children. So do you think that it is safe to give it in children?
There has not been any precedent of a successful DNA vaccine that has been given in large numbers of children. There have been experimental vaccines and results have been disappointing with most DNA vaccines. So we don't know much about DNA vaccine. This DNA vaccine is an intradermal DNA vaccine. So it has got to be injected intradermally, and therefore for consistency of administration, as Lalwani said, you have to use an injector with a certain specific force so that it goes to the right level. We have to wait and see. The trial included children, and we'll have to actually wait and see what the trial numbers are, the trial results are. Just because it is a novel technology, we need not be skeptical about it. When if this is approved, it will be the first DNA vaccine and globally for a pediatric or any adult use. So we'll have to wait and see for more data.
So it is a novel vaccine with a novel way of administration. So we really have to wait and see how it is going to perform in the field.
Yes.
Right, sir. Thank you.
Jagdish, I think just of this thing, when we were conducting this trial for Zydus Cadila, and we were screening the children above the age of 12 years prior to giving a vaccine for the COVID antibodies, to surprise 1/3 of the population came out positive for antibodies, and I think they had asymptomatic infection. And I think the 1/3 of the population between 12 to 16 years in the cohort from Pune was already COVID antibody positive. That means a lot of virus has circulated into pediatric population, and a lot of them had asymptomatically got the infection and had the demonstrable antibodies in them.
Coming to that point again, I think the Delhi study, and which has shown from 5 centers, showed almost a 50 to 70% prevalence of the antibodies. So I think that's the antibody. Probably many children have had asymptomatic infection. Coming to my next question, and I think again I'm going to come back to Dr. Jacob John. See, normally if a patient has COVID, we say 3 months later you take one dose, single dose of the vaccine. Now here you're going to implement vaccination across children, and you're going to give multiple doses. Is there going to be any vaccine-induced problems because of that?
That depends upon each vaccine. We need to collect data. See, in our thinking, we try to accommodate without data, whereas in the West, they will not venture to give to children without clear demonstration of safety and immunogenicity. So we'll have to wait for all these vaccines for such data. As Lalwani said, and you repeated, after the second wave, there is hardly any difference in the seroprevalence according to age. Children below 18, children above 18, all have been infected very, very widely. And so many of the children whom we will be vaccinating would be children who already had been silent infection. So that's an issue whether we need to separate out already immune children to save vaccine or not. We'll have to wait and see whether we can use intradermal use of the vaccine so that it's both antigen sparing, and if there is any adverse reaction, we would be reducing by the dose of the vaccine. All these are in a flux. We'll have to wait and see for more data.
Thank you, Dr. John. So I think we'll move this. So I think we'll come to Dr. Sanjay now. I think he's been quiet for some time. So let's look at what do you think could be the possible harms of the COVID vaccines? I mean, we look at short term and long term.
Jagdish, what is very interesting about these vaccines is that in a short duration of time, large populations across the world have been vaccinated, and we have enough data about the adverse effects following vaccine. So the short-term effects of the vaccine, I wouldn't call it as harm, I would call it as side effects of the vaccine. Generally, these vaccines do not cause serious problems. Most often the side effects are, the adverse effects are non-specific in terms of pain, tenderness, fever for the people who have been administered the vaccine. There are some short-term harms described with specific vaccines. Anaphylaxis could happen with the antigen or with the promoters in the vaccine. In addition to anaphylaxis, there are reports of myocarditis with the mRNA vaccine, which are more seen in individuals who are young and more often in males than females. Whereas with the vectored vaccines, the TTS, the thrombocytopenia, thrombosis syndromes have been reported, especially with the AstraZeneca vaccine and the Johnson vaccine. They have been reported more in women and who are young. There are also some reports of adverse neurological syndromes like the Guillain-Barré syndromes and transverse myelitis, just like any other viral vaccines.
So I think the important take-home message is that most of them are safe. However, we need to keep a watch on side effects because these are new vaccines in a new population. So I think we need to be careful about and watch for any unusual symptoms or unusual signs that may come up. Thank you. So, I mean, this is a big problem which we have, that there are statements like natural disease produces more robust immunity than vaccination. So should we really, how do we really say what is the risk-benefit ratio of a vaccine?
Okay, the risk-benefit ratio requires assessment of the risk. So if you did not have adult COVID disease at all, and we look at pediatric COVID, it's not a vaccine preventable disease in terms of the prevalence or incidence. It's a, okay, COVID disease, not infection. So therefore, assessment of the benefit risk is not going to be easy. Because of the age determined severity of COVID disease and mortality, it's predominantly an adult problem. It's different from the usual diseases against which vaccines had been available for a long time. So the essential role of the children's vaccination against COVID is when you want to reduce the incidence of coronavirus infection in the community. That's when we like to roll it out to children for public health purposes. But before reopening schools, the Maharashtra state has vaccinated all staff of schools, teachers, ancillary staff, bus drivers, etc., in preparation for reopening schools. I think reopening schools without vaccinating children is going to be a bit risky. So we may have to think in terms of the extra benefit in terms of the vaccination in children for public health purposes also. The argument that natural disease is better than vaccine immunity is an age-old problem. People said it about measles, they said it about whooping cough, said it about rubella, and we have grown out of that. The whole idea of a vaccine is that you have a immunostimulant with no risk of disease. And no risk of disease is why we are interested in the adverse event. If adverse events are more in frequency or severe in or problematic in severity, then you have to stop back and think as to what is the safety issue. So in terms of risk and benefit as of now, with the available information, if the vaccine is safe, then the benefit far outweighs any possible risk as of now in our present day knowledge.
So I think here the question should be whether we can prevent basically community infection rather than the individual protection. So I think yes, that may be the okay. I was just coming to you, just mentioned about schools, and I said, can the government mandate vaccination, Dr. Lalwani, for especially prior to school? You're in Maharashtra, so can they make it compulsory? Supposing one school says we don't want to take the vaccine, what do you do then?
Yeah, when it comes to a pediatric and vaccination to a school-going children, and as Jacob John sir said, from the public health perspective, whether we like or don't like, pediatric vaccination would have to be done before the child goes to school for two reasons. The parents would not send the child to the school unless he gets the vaccine. And number, I think we need to break the chain by giving even the dose in the pediatric age group. The question is when it will occur. And I personally think so, this should be in the next year, the vaccination would be a part in pediatric age group. And which vaccine will come first, how it will be available, how it will be rolled out. I think we need to see about it. But vaccination would be a part of a national program before actually the school opens in every state. That's what I personally think so.
So I think what Maharashtra has done should be followed by other states also, that all teachers, all support staff, all administrative staff in schools should be vaccinated well in advance.
I think it will go the same way. That's what I frankly think.
Okay, so that's a very comforting thing. Okay, now Dr. Sanjay, there are large number of children in our country who are immune suppressed, chronic disease, malnourished. Should they be prioritized? Because as Dr. Sanjay said, we won't get vaccine for everybody. So I think should we start prioritizing children who have got problems with disabilities, immune suppression, chronic disease, malnourished, difficult to reach population? Should they be priority for vaccination?
Absolutely, Jagdish, but we need to weigh also that the response to vaccination may not be the same as it occurs in healthy children.
True.
These children need to be prioritized because these children are those with comorbid conditions whom the disease could be severe. But at the same time, we need to be sure that the vaccine is effective. So at the moment, we do not have any studies related to the use of COVID vaccine in immunosuppressed chronic individuals, though in adults in chronic diseases, COVID vaccines are found to be effective. So that is my take, Jagdish.
Yeah, I think the studies have shown that many of these patients who have been transplanted will need an additional dose or an additional couple of doses to keep their immunity going in addition to what has been recommended. Dr. Jacob John, do you think that the COVID vaccine will perform the same in a well-nourished compared to a malnourished child? Do you think there may be issues there?
From an immunological perspective, I'm not that worried about malnourished children. They usually have robust immune responses. I'm only worried about overnourished children, that is obese children, who have a greater risk of severe disease. We need to investigate whether obese children will respond to the vaccine as well as well-nourished, normally nourished children. And children with malignancies on chemotherapy and immunosuppression, all those kind of children are at risk for severe COVID, and therefore some kind of prioritization will have to be developed by clinical people in terms of giving them priority. And I suspect that all adults above 65, men, all people with comorbidities may require a booster dose for improving their protection. Again, that is also something to be investigated. Right now, people are looking at healthy people and their vaccination. Definitely, those with comorbidity are also protected, no doubt about that. But a lot of people, men versus women, there's a distinct difference in the immune response, better in women than in men. So can we get more benefit out of immunization by a booster in that small percentage of people who still have less protection than others? That's to be investigated and to be seen later.
Thank you, Dr. Jacob John. Dr. Sanjay Lalwani, any studies on boosters?
Not yet.
Not yet.
Okay.
Okay. So let's get to the thing. Now another problem is in adults we are tracking vaccination by with a COVID app and putting that in. In children, how do you plan to do it? Because many of them don't have Aadhaar cards. I mean, most of them don't have Aadhaar cards. So Dr. Sanjay Lalwani, how will they be? Are they planning a central registry where they can track all these children?
First and foremost, first time actually we have seen such a central COVID app by Government of India, and I think it was a Herculean task, and I think they have done it quite efficiently. That's number one. Number two, in the COVID app, if the particular individual doesn't have an Aadhaar card, they can link it with any other government, like their driving license, or it may be even his PAN card. Now, when it comes to, it is always better to have a central registry. I'm sure they are working on it. But I think if the child is lesser, they may have Aadhaar or may not have Aadhaar. They may probably link his to its birth certificate is what I personally think so. So I think making Aadhaar, I think most of them make Aadhaar card. But if there is no Aadhaar card, they would link it to the birth certificate of the child. And that's what I think so when it rolls out. But whenever the pediatric vaccination will roll out in the country, I think it will be through the COVID app only. It's going to be rolled out. And there would be a central registry. And if there is no Aadhaar card, the next important document, of course, would be the birth certificate.
Thank you, Dr. Lalwani. I think this is going to be a major challenge because tracking these children is going to be very, very challenging, especially if you're going to go in for a Zydus Cadila vaccine, which is going to be 3 doses. So tracking them over 3 doses may not be a very easy thing to do. Now coming to Dr. Sanjay Srirampur, another problem with our country is that the compensation is not there for an adverse reaction to a vaccine. So you think that that should be one of the things that should be highlighted to the government?
I think it should be there, Jagdish, because ethically also we have circumvented some of the steps which should have been followed. A compensation in some way is necessary because that will give more amount of confidence.
Dr. Jacob John, your thoughts on compensation?
It's a tricky issue, very tricky issue, because the moment the government agrees on a compensation, it's ipso facto declaring that there could be problems. We have always been saying the vaccine is completely safe, completely safe. And so our people are not that discriminative to understand that on the one side, vaccine is very safe, and on the other side, you have compensation for adverse reaction. So it's a very, very tricky issue, and we have to think through it very, very carefully. And no other vaccine has compensation in India, and which is also a problematic issue in terms of some vaccine. So I don't think compensation should be brought up with the COVID vaccination at this particular time. Compensation issue should be looked at it on a generic basis for all pediatric vaccines together, or all vaccines together, rather than specifically address COVID vaccine alone. I think that might backfire. So it's a very complex issue, right?
Yeah, Dr. Lalwani, please come in.
I think as far as the COVID vaccine is concerned, it's come in a span of 1 year, all the phases at one step. And I think rare adverse events will only come in the forefront when we have the phase 4 of the post-marketing surveillance program, and that also in a country which has a robust system. That's number one. Number two, all these vaccine manufacturers have written to government, including Serum Institute of India, that if there are any issues in vaccination in the phase 4, then those vaccine companies should not be held responsible, and even government would compensate. Please try to understand, this has been a specific situation of pandemic where the benefits outweigh far more than whatever adverse events if they surface out later on in the field. So I think as far as COVID vaccine and what Jacob John says, and I think none of the vaccine manufacturers, they want actually a free pass from the vaccine. Vaccine manufacturers really do not want to be responsible for it. And I'm sure government also will not look at the compensation part of it as far as the COVID vaccination to be rolled out in India. I think that looks quite clear to me actually.
Yeah, I think that's a very valid point. And I think both Pfizer and Moderna have asked for indemnity clause as with the government, saying that we should not be, if there is any court case or anything, we should be indemnified against any side effects. I think that's a very valid point. Now coming to almost the last part of our discussion, there was some discussion which was asked about, do vaccines against influenza protect against severe COVID? Dr. Lalwani?
Yeah, I think there has been a sudden rush of patients, of the babies' parents coming to a pediatrician to take COVID vaccine, saying that they have heard it prevents getting infected. I think the studies done and which are now available, they followed up the two cohorts, one which took the COVID, flu vaccine and they got COVID, and the one who did not take the flu vaccine and got COVID. I think those who did not take the flu vaccine, the complication rate due to a COVID was at 20% higher in those who did not take the flu vaccine. So the problem immunity, that's number one. Number two, by not having flu, by taking flu vaccine makes that particular candidate much more fitter so that he gets lesser complication of COVID. As such, flu vaccine and COVID has no common things in it, but whatever data is available, those who took a flu vaccine and they got a COVID, the complication rates due to a COVID were a much lesser. The simple explanation can.
Thank you, Dr. Lalwani. I think Dr. Jacob John should comment on this. Yeah. So, Dr. Jacob John, what are your thoughts?
Two things. One, the Maharashtra has a committee appointed to look at pediatric response to pediatric COVID, and that committee has recommended flu vaccination. And in Maharashtra, there is the demand for flu vaccination in children. And surprisingly, and I think Tanu Singhal referred to that, there are a lot of co-infections with influenza and coronavirus. Because influenza is a very fairly common infection. So the co-infections is probably the mechanism by which influenza vaccination reduces the severity of COVID in children. So influenza vaccination is good in its own right. I think we should not project it as a COVID vaccination. It should be an influenza vaccination, and influenza vaccinated people have less chance of co-infection with influenza and coronavirus, and therefore likely to be less severe morbidity, a combined morbidity of both are cytokine storm kind of diseases. So from a common sense point of view, that's a good idea.
Sanjay, what about MMR and BCG? Is it the last word, or shall we bury it now?
I think when we have other vaccines, when we are talking of COVID vaccines, talking on MMR and BCG as repurposed vaccines, whether we would like to bury or not, already they are getting buried.
That's good. Thank you. One last question to Dr. Jacob John. Should each state be given an exclusive branded vaccine? Like, for example, let's say Tamil Nadu gets Zydus Cadila, Karnataka gets Bharat Biotech, so that you can do a clinical trial over a period of time and see what happens with the COVID disease. Is this a possibility?
Possibility yes, probability no. Because that is not the way things should work out, because what language you speak, which state you live, therefore you get, no, that's not the, I think there should be a uniform approach, and some choice should be given to communities, essentially, when there's a glut of vaccine. When there's a shortage of vaccine, then of course the allocation depends upon the availability of vaccine. So it's a bit too premature to look in terms of whether an experiment can be done by giving vaccine A to state A and vaccine B to state B and see what happens. I don't think they'll be comparable also, because there are a lot of variables, and both in data collection, robustness of data, etc., etc. So it's theoretically seems good, but in practical issues, I don't think it will pan out to be a realistic issue.
So it's a utopian dream, huh?
Yes.
Okay. Okay. Now, quickly, I will just go through this now. This should only the government give the vaccine, or should all the private practitioners also be allowed to give the vaccine? Because right now the government is treating it as some kind of property which they want to hold.
That is because the emergency authorization still is valid. It's not licensed. So therefore, government is the agency that should decide who gets the vaccine and who does not get the vaccine. So the power is given to the government by the Drugs Controller General of India to choose who gets vaccine. So it's not, until licensing is done. As I said, both companies have applied for full licensing. It's only now Covaxin people have gone to WHO for WHO approval. We hope it will be through by August. They may get approval because they have already submitted the phase 3 trial data to WHO. So all these are in a flux. Let you wait and see.
Okay. So now I think before we end this, probably is my last question. Any future vaccines, Dr. Sanjay Srirampur?
Yes, they are in phase 1 studies, Jagdish. The nasal vaccine, especially the Bharat Biotech one, it's in the phase 1 studies. The advantage would be that it is supposed to reduce the transmission. It is supposed to give local immunity, and it is also easy to administer. The influ combo vaccine is by the Novavax company, which is also under phase 1 studies in hamsters, in animal studies.
So still long way off, at least another couple of years.
Yes. There's a rider.
Yes, sir.
As far as I know, the trial that is going on is 1 dose of Covaxin followed by 1 dose of intranasal.
Okay.
It's not a intranasal alone. Intranasal alone, I don't think had sufficient immunogenicity to take it forward. But when you give 1 dose of Covaxin followed by 1 dose of intranasal vaccine, I think they have excellent immune response.
Thank you. Thank you, sir. So I think before I end this session, I want 2 recommendations from each of you for everybody. So we'll start with Professor Jacob John. 2 recommendations from your side.
Recommendations to who?
To all the listeners.
Okay. Well, watch the horizon as to what developments are coming. One day, children's vaccine will be made available. So be prepared for that. But as of now, what recommendation can we give? Continue the COVID appropriate behavior and prevent infection as much as possible. Vaccine is yet not available. It's on the horizon for children. So no recommendation.
Okay, sir.
Except be prepared.
Dr. Sanjay?
Advocate vaccines in adults, Jagdish, that is recommendation 1. Advocate vaccine for the ancillary staff in the schools, because that is one thing which we are neglecting, because children are missing their schools since the last 2 years. Vaccinate adults, and as and when recommendations come for the pediatric vaccinations, advocate.
Right, sir. Dr. Sanjay Lalwani?
I first and foremost, as a pediatrician, we must sensitize the parents of the child to take the vaccine, and I think we should do our best to see that maximum of them whom we come in contact, we give a positive impulse for taking the vaccine. That's number 1, including the lactating mothers. And second, I think the world and a country like ours, each and every person on the country has realized the importance of vaccine. I'm sure the good way to take COVID pandemic would be the vaccination rate in India. Subsequently, post-COVID would really go up. And I think it will not be only a pediatric vaccine, it will open the other horizons like the adolescent vaccine, the adult vaccination, and geriatric vaccination in years to come.
Thank you, Dr. Lalwani. And I will stop here and hand it over to Dr. Ramachandran. I think we have finished on time, Dr. Balasubramaniam. So I will hand it back to Dr. Ramachandran.
We are trying to finish the question.
Thank you so much. Thank you so much, Dr. Jagdish. Really, I appreciate you and all the esteemed panelists for doing justice to the topic and doing it at time. Can I just roll through some of the questions? The question 1 is, can COVID vaccines come under the ambit of Pandemic Act in the interest of the community to protect the community? Just as you say, mask and other these things, can it be enforced? Because of the hesitancy and other issues involved.
Most unlikely, because you see, Supreme Court said something about the that religious pilgrimage right now, and people are objecting to that. So anything that is compulsorily mandated is not going to be a good idea. You have to educate people and get their goodwill and acceptance.
Thank you, sir. Dr. Sanjay Lalwani, what is the storage temperature for Zydus vaccine?
It's 2 to 8 degrees centigrade.
Okay, same as this thing.
Yeah.
I think this has been addressed, but if you think it has been taken, with high levels of antibody, nearly 50 to 60% children and adolescents, any vaccination is going to be act like a booster. Will it increase the reactions like MIS-C? So antibody enhanced reaction, will it be there?
Doesn't appear so. I think we have to just wait and watch. But I think anybody who has got COVID subclinical infection and antibodies, I think whenever the pediatric vaccination gets available, I think the adolescent needs to be vaccinated.
Right. I think Dr. Tanu Singhal also referred to this in a talk. Okay. If pediatric COVID vaccines are delayed due to availability, all not till next year, probably COVID pandemic will be no longer will be there. Just like H1N1, it may become a kind of endemic. What's your comment? Are we waiting? I mean, by the time it's taken up for children, it may not be required. Is it likely to be a scenario like that?
Let's pray for that and work towards the vaccines. Let's pray that it disappears by the next year.
Yeah. I have one question of my own. What about changing of the vaccine, especially with the viral vector vaccine? The inherent Sputnik is a different vaccine. The studies which are going on, what is the scientific information available so far? So mRNA to AstraZeneca's like this, or AstraZeneca's to mRNA, other way around.
I think
Is
there
there
are
any available
studies going-
information?
Yeah, I think
is it an advantage to give a different vaccine or no?
You
I
mean
think there is a-
vaccine? Is it one dose of one vaccine, second dose of second vaccine? Is that the idea?
Yes, sir.
Yeah. Okay.
Some studies are going on, and as long as all vaccines are spike protein specific, interchangeability is not a big problem. And there seems to be some advantages in the limited studies data that are available, that it broadens the breadth of coverage. That is, the coverage of newer variants seems to be slightly better when you give two different vaccines in the schedule rather than one vaccine as full schedule. These are very preliminary information that we have. But if you get one vaccine in a country and you travel to a second country, another vaccine is available, the recommendation is to take that vaccine in that country. So there is no immunological problem in giving different vaccines sequentially. Advantages, we'll have to wait and see. There seems to be some advantage, especially the coverage of newer variants seem to be slightly better.
Yeah, I think so. Dr. Ramchandra, I think the study which Dr. Jacob John said about the vaccine first dose and second dose, I think what they are looking at, the study of the Pfizer vaccine followed by AstraZeneca, I think that's the common interchangeability what they are seeing globally now. And as Sir told, likely their mechanism of action is different, and I think it's spike protein related. Ideally it should, but they are looking at the combination of the vaccine and does it have a better immune protection? We just have to wait and watch. It's too early to comment.
Can I answer this question?
Sure.
This is Tanu here.
Please come in.
Yeah, so there is the COMVAC trial, which was done in Britain, which was a randomized control trial in which they had 4 groups: Pfizer, AstraZeneca, Pfizer, and AstraZeneca. And what they found, that AstraZeneca best was with Pfizer, followed by AstraZeneca, Pfizer, and Pfizer followed by AstraZeneca didn't give any benefit. But the best T-cell responses were seen with when AstraZeneca was followed by mRNA vaccine. So the only problem is they found that when the second dose was a heterologous vaccine or a different vaccine, the side effects were a little more.
Okay. If I can add here, Dr. Tanu, they were only short-term side effects.
Yes.
May I see the last question, because Dr. Jacob John has to join the Telangana session at 8 o'clock. That will be the last question.
Sir, I don't see any other questions which are of very important nature in the question box. Other things have been covered by other topics. Dr. Jagdish, if you want to conclude by saying something, it's now it's your time.
Yes, sir. Thank you so much. I think I must thank all 3 panelists for a wonderful discussion on the COVID vaccine when it comes for children. And I think the important thing right now is that we still are awaiting a lot of data. We do not know too much about the vaccines in children. However, some of the vaccines have got good trials which have been done abroad. Some of the Indian vaccines also are submitting their data in children. So we'll wait closely in the next 2-3 months. We will know how this vaccine is going to roll out. But I suppose in the meantime, we should continue to vaccinate all adults and all people who come in contact with children, because that is very, very important, whether they are school, elderly, grandparents, servants, anybody coming in contact with children should be vaccinated with the existing vaccines. It doesn't really matter which vaccine, because all vaccines have been shown to be equally efficient in protecting against severe disease. So I think these are some common things. A lot of intricacies will be sorted out over the next couple of months or years, we really don't know.
Thank you. Thank you, PRC. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Ramchandran, for the excellent session. Thank you all, particularly Professor Jacob John, in spite of his busy schedule, he could join. Thank you very much, sir. We move on to the next session. We have an international speaker, Professor Ramanan, waiting for long. The moderator for this session is none other than Professor Thangavelu, the head of the Department of Pediatrics of Dr. Mehta's Children's Hospital. Over to Professor Thangavelu, who doesn't need any introduction. Over.
Thank you, sir. Good evening. Thanks for the opportunity. Next session has got two important topics. A time delay of 1 hour is not going to discourage us. We are going to sit and listen to the topic, but they are very important. First topic is MIS-C, Diagnosis and Management by Professor S. Balasubramaniam. And second topic is Therapeutics in COVID-19 and MIS-C, the lessons learned from the clinical trials. Both the speakers do not need introduction. I'll give a brief introduction. Professor S. Balasubramanian is the director and senior consultant in Kanchi Kamagudi Children's Hospital, Chennai. And he is a person who has produced large number of papers on COVID from India. And A.V. Ramanan is a pediatric rheumatologist from Bristol Hospital, NHS, UK. And he is the one involved in many clinical trials. So we have an important topic around. We'll wait for the interesting topics. Over to Dr. S. Balasubramanian.
Yeah. Okay, is my screen visible?
Yes, visible and audible, sir, both.
Okay, thank you very much, Professor Thangavelu. I'm going to run through the session in 25 minutes so that you will all listen to Dr. Ramanan in detail. The focus in this session, I would straight away go into some few case scenarios which we witnessed, where we had dilemmas and we found some solutions. I'm going to share the data from our hospital KKCTH, and I'm going to finally share the protocol we are following currently in KKCTH. This is a true story. April 2020, this 8-year-old boy had fever, cough, fast breathing. He was hospitalized outside. Dr. Christopher, the pediatrician, did the COVID PCR, and he took an X-ray. It showed the pneumonia on the right side. He appropriately treated with ceftriaxone. On day 4, he got worried about the child. This boy developed redness of the eyes, rash, and he developed hypoxia. And he referred to us. On arrival, he was tachypnic. He had hypoxia. He was hypotensive. We shifted him to ICU for fluid bolus and inotrope support. We didn't know what the diagnosis was at that point of time. COVID-19 had just started in India and in Chennai. And this boy had bulbar conjunctivitis like this. And he had maculopapular rashes like this over the limbs. And he had cheilitis glossitis. And he had pedal edema. And we repeated the X-ray. His fever was not coming down. As you see here, he had consolidation in the mid-zone. At this point of time, he also had a rash like this on the abdomen. We had a problem. We only knew Kawasaki as a diagnosis for this boy. We didn't know whether this was atypical pneumonia. We didn't know whether this was COVID pneumonia where the initial PCR was negative. We also thought of septic shock, COVID pneumonia, toxic shock syndrome, etc. And in the ICU, what we did was hit hard with antibiotics. And at that point of time, we gave IVIG thinking it could be Kawasaki disease. Of course, I made a call to Professor Ramanan and I asked him, some cases are being reported hyperinflammatory syndrome in UK and Europe. Is this that? He said it's exactly like that. IVIG, we gave the CRP 400 and odd. And then after giving IVIG, it did come down, that the fever never came down. He didn't improve. We called Dr. Ramanan and we gave tocilizumab, and then it was magic. In 48 hours, this boy completely recovered. And at that point of time, we had a question, is this KD or is this MIS-C? And then, if you look at the literature today, there is clarity. There are some differences where MIS-C has some findings and KD does not have. What are those? MIS-C, basically, age is higher, above 5 years, most common. GI symptoms are much more common when compared to KD. Myocarditis is more common in MIS-C. Cardiac involvement is more common in MIS-C. You don't get leukopenia and lymphopenia in Kawasaki, whereas you get it frequently. You get thrombocytosis in Kawasaki, whereas you get thrombocytopenia in MIS-C more often. Ferritin is more highly elevated in MIS-C. There is a lot of requirement for inotropes, vasopressors, ventilation, ECMO, and biologics in MIS-C. You look at the differences in KD. KD, we all know, is a disease of infancy and young children. Respiratory symptoms are highly uncommon. Myocarditis is extremely uncommon. Aneurysms are more common, but not ventricular dysfunction. We all know 10 lakh platelet counts in Kawasaki, not in MIS-C. High ferritin, high D-dimer, lymphopenia are extremely rare. And in KD, we give IVIG, most of them respond. We don't resort to steroids and biologics routinely in KD. Rarely does a child with KD go to the ICU. But there are some common features. There is an overlap between MIS-C and KD. That's what this boy had. Fever is common. Mucocutaneous lesions are common. Edema is common. Cervical adenopathy is common. Shock can occur. Macrophage activation syndrome can occur. Coronary artery aneurysms can occur. Well, the IVIG and aspirin are common for MIS-C as well as KD. And this is the first case of MIS-C we reported, first case in Asia itself. Then, originally, it was called hyperinflammatory syndrome. Then it was called PIMS-TS by the Europeans. The Americans deferred, the WHO deferred and called it as MIS-C. Whatever definitions are there, you follow one of them. Today, we follow WHO guideline. Earlier, we followed RCPCH guidelines for uniformity, but all roads lead to Rome. Case 2. This child, 3-year-old, had fever for 4 days, 2 episodes of seizures, rather unusual in febrile seizures. He had encephalopathy. He was normotensive, no focal deficits. We thought it is aseptic meningitis or some meningoencephalitis, viral or bacterial. CT was normal. CSF showed features of aseptic meningitis. Cultures were negative. CRP was very high. ESR was high. Surprisingly, we found the albumin was 2.7. OTPD was normal. X-ray was normal. Ultrasound was normal. At this point of time, does this boy have viral infection or bacterial or rickettsial, metabolic or inflammatory? Whether to give antibiotic or antiviral, we gave both, no response. Subsequently, day 6, conjunctival suffusion, perilimbal sparing, red lips, rash, peripheries are swollen. And then we investigated, everything fitted into MIS-C. At that time, we knew very little about MIS-C. And unfortunately, he had both PCR positivity and serology of IgG and IgM, both positivity. Cultures are negative, echo was normal. This was actually a neurological presentation of MIS-C. We didn't know whether this was acute COVID or MIS-C. We didn't know whether to give IVIG plus or minus steroids. We didn't know whether to give remdesivir. But then, in a given case like this, one must try to differentiate between MIS-C and acute COVID because the treatment might be different. If it is acute COVID, you might give only steroids. If it is MIS-C, you may even consider remdesivir as discussed earlier in the sessions. In MIS-C, your treatment is immunomodulation mainly. So the differences are, in MIS-C, in general, when compared to acute COVID, the counts are higher. If you find 24,000 total count, acute COVID is unlikely. Neutrophilia is very common in MIS-C. Lymphopenia is very characteristic in MIS-C. Hemoglobin is much lower in MIS-C. OTPD elevation is more common in MIS-C rather than in COVID. CRP, we have not seen such high levels of CRP at 200 and 300 in the previous years. In the last 2 years in MIS-C, everything had been more than 100. Ferritin is higher. PCT, unfortunately, which is says to be very sensitive for infection, bacterial infection, is also higher. LDH is higher. D-dimer, a confusing lab report, is always high in MIS-C. Can MIS-C present with neurological features? Dr. Shivabalan and Dr. Vasanthi published a case series of 3 in which 2 of them presented with febrile seizures, ultimately turned out to have MIS-C. So neurological manifestation may be the only manifestation in addition to fever and high CRP in MIS-C. Case 3. This 7-year-old boy who was previously healthy, he had 5 days of relentless fever, occasional loose stools, he had abdominal pain. On examination, he was toxic, spleen was palpable. Once spleen is palpable, you get a total count of 4,500, eosinophils 0, P72, platelet 2 lakhs, hemoglobin 11, but CRP is 60. Somebody had done D-dimer, which was 4,000. Somebody had also done COVID IgG antibodies, it was positive. Liver function, renal function was normal. The question is this MIS-C or our garden variety bacterial infection like enteric? Is it infection at all? How do you distinguish? And what is a broad differential diagnosis for MIS-C? And when do you start thinking of MIS-C? And how do you like to investigate? These are the questions we had. If you look at the differential diagnosis of MIS-C, if you write for a French index of differential diagnosis, almost any infection will come. Almost any disease will come as DD of MIS-C. All tropical fevers, dengue, malaria, enteric fever, scrub typhus, UTI, toxic shock syndrome, very similar to Kawasaki shock, Kawasaki disease, appendicitis, many of them may present with acute abdomen, HLH, MAS, viral infection, they can present with rash and conjunctivitis, bacterial enteritis, series were reported in Pediatric Infectious Disease Journal recently, vasculitis, especially SLE and all other conditions. So if you know the DD of MIS-C, you probably know pediatric infectious diseases. Whole lot can present. Case 4. This is a doctor's child where we had problems. This boy who was 5-year-old had fever for 6 days. He had a rash like this from day 3 with abdominal pain. He had a background of multiple drug allergies. We were scared because the mother was a dermatologist. He is allergic to cefixime, ceftriaxone. Counts were normal. CRP was 40, OT was 300, PT was 250, bilirubin was mildly elevated, albumin and sodium were normal. He received piperacillin tazobactam elsewhere after blood cultures. He was not better. The mother got a COVID antibody done. It was positive. He got admitted. Repeat labs, CRP went up. CBC RFT was normal. OTPT were elevated. Albumin was normal. And we did all hepatitis viral markers, septic markers, and typhus and typhoid, etc. We got an opthal evaluation. Ultrasound was done. Echo was done thinking it could be KD or MIS-C. And surprisingly, he got admitted and he became completely afebrile in 24 hours. Dilemma. Should you give this boy IVIG? Should you give this boy steroids on a diagnosis of MIS-C? He fulfills the criteria. And we didn't have alternative diagnosis. We waited for 24 hours. He completely recovered. 2-week echo was normal. And this was a case of spontaneous recovery of MIS-C. Why am I presenting this? Today, as Dhiren said, there's a lot of overdiagnosis as well as underdiagnosis of MIS-C. We are all confused because many a time we see antibody reports. We immediately diagnose MIS-C if there is fever and high CRP. But there is a group of children with MIS-C who have non-life-threatening disease could improve spontaneously. It is always better to admit these children, observe as inpatients rather than try outpatient oral steroids or immunomodulation. In fact, Elizabeth Whittaker, in the first series of PIMS-TS from Europe, she reported that 22% of children with MIS-C recovered with only supportive care. We have also seen quite a few cases. So in children who are not toxic, whose echoes are normal, who are stable, there's no need to hurry through immunologics. Having discussed these 4 cases, I'm going to share the data from our hospital. After having published the first case, we analyzed around 18 cases from our institution, and we published in Indian Pediatric the first case series. What did we see? All of them had fever. Surprisingly, mucocutaneous lesions were present in 3/4. So if you look at the skin and mucous membrane, you are likely to make an early diagnosis of MIS-C. Serious symptoms with hypotension, palpitation, tachycardia, sweating, autonomic instability, they were present in 2/3. Well, the next most common was GI symptoms and followed by respiratory symptoms. In fact, GI symptoms of appendicitis-like presentation, diarrhea, vomiting, right? Pain. That was very common in 40% of cases. 2/3 of the cases went into ICU. We also saw a few children with acute kidney injury and CNS manifestations. After having seen MIS-C over the last 15 months, our data suggests that we have had 150 cases. Of course, the score is 160 today, but I don't have all the data today. From April 2020 to June 2021, we have had 150 cases. All of them had fever for at least 3 days. Surprisingly, 8% of them were RT-PCR positive. The remaining 92% had IgG positive. We had started doing antibodies right from the beginning. The mean age was 77.2 years. Males were more commonly affected. Kawasaki signs, mucocutaneous signs were seen in 85%. Lymphadenopathy in nearly 1/5. Complete KD phenotype was present in 10%. Incomplete KD phenotype was present in half. In the larger series of 150 cases, GI symptoms were seen nearly in 2/3, 71%. Abdominal pain was present in 50% of cases. Cardiovascular signs and symptoms are present in 57%. Respiratory, mind you, were seen only in 1/8 of 150 cases. So MIS-C children don't present often with cough and cold and respiratory distress. And they can present with all sorts of rashes like this, with bulbar conjunctivitis, hemorrhagic conjunctivitis, facial rash with cervical adenopathy. One child had thrombosis like this, with gangrene of the toe and necrosis of the skin. And this child currently in the hospital with urticarial rashes on the face and limbs with features suggest to a MIS-C. Maculopapular or even vesicular rashes we have seen. Coming to the management we gave IVIG and steroids to nearly 2/3, 71%. IVIG alone in the initial stages we gave 19%. Spontaneous remission had occurred in 5%. Steroids alone were used only in 5%. Biologics, including anakinra, have been used in 3%. Fortunately, our mortality is 0. 160 cases till now, touch wood, no deaths. 47% cases went into PICU. Mean hospital stay was 7 days. Most cases were life-threatening, 54%. Then another dilemma we have, does antibody positivity confirm MIS-C in all fevers more than 3 days? If PCR and antibody tests are negative, does it exclude MIS-C? We started a study on antibodies very early in the month of May 2020, thanks to Professor Ramanan's suggestion. We did antibodies in 463 children. And we found that almost half of the seropositive children had MIS-C or PIMS-TS. The figures may be much lower now because of the increased antibody positivity in the community. Then we carried out biomarker profiling of these cases, and we found that almost all the biomarkers, many of them I can't even spell properly, are all much more elevated in MIS-C and COVID-19 rather than in controls. Somebody might be tempted to do IL-6 and D-dimer routinely. Is it required at all? We analyzed the biomarkers in MIS-C, and we found that IL-6 is definitely elevated in MIS-C as well as in COVID-19. But then, if you ask me, should you do it? There is no need to do it. It should be used only for research tool. CRP is a good surrogate marker of IL-6. We have done IL-6 estimation only as a research tool. Recently, along with collaboration from National Institute of Research in Tuberculosis, we did a study where we showed that children with MIS-C and those who went into ICU had higher levels of CRP and higher levels of alpha-2 macroglobulin and serum amyloid lipopolysaccharide. These may emerge as good markers to differentiate MIS-C from COVID-19. Recently, thanks to the suggestion and initiative of Professor Ramanan, who is going to speak to the audience after me, we published a letter, a correspondence in the Lancet Rheumatology. Why did we do it? Me and Dr. Ramanan have been arguing whether steroids alone can be given for IVIG. We worked out the costs, and we worked out the number of cases which are likely to emerge in India. And we wrote that steroids could be cheap. Steroids are cost effective. We don't have to use IVIG routinely. We also mentioned recovery trial will give the right answers. I'm sure Ramanan will talk about it in his presentation. Having talked about all this, what are we following today in KKCTH? Thanks to Dr. Janani Shankar, Dr. Dhanlakshmi, and Dr. Divya, my registrar, recently we, for our own hospital purpose, have formed the protocol. We have used a term called non-life-threatening and life-threatening MIS-C for convenience. What is this non-life-threatening MIS-C? We follow the WHO protocol now for diagnosis. Once shock is absent, or once there are no clinical symptoms and signs of end organ dysfunction, we make a diagnosis of MIS-C, we call it non-life-threatening. Once there is shock or end organ dysfunction, or any of this as seen in the slide, or anything like acute kidney injury also, we call it as life-threatening. We will see why this division is required later. If a child has got non-critical symptoms and signs, we recommend only level 1 workup, and if there is a strong suspicion of MIS-C, we recommend level 2. We'll see later. If MIS-C is not confirmed, we continue to work up for infections. On the other hand, if a child has got critical symptoms, we don't withhold antibiotic. We do give antibiotics after taking culture. We do both level 1 and level 2 tests, and we always do cultures for bacterial infections, viral serology like dengue, scrub typhus, IgM on clinical judgment when they review with lab reports. The tier 2, this is where cost comes up as a big issue. We do ECG and echo once we think it is MIS-C, and we do pro-BNP, which is a very sensitive marker of myocardial injury. And of course, we also, as a protocol, we do elevate troponin levels also. We do ferritin for completion, though it is not required routinely. And we do PT and PTT and D-dimer, fibrinogen and LDH for completion. Though this may not be useful for regular monitoring, it may not be required in peripheries. Coming to the management, if a child has got life-threatening disease, there is no question at all. You have to hit hard. We do give IVIG 2 grams per kg over 12 to 24 hours, preferably in 12 hours. And as a protocol in our institution, we have been following 10 milligram per kg, not 10 to 30, 10 milligram per kg for at least 3 days. And we give aspirin provided the platelet count is more than 80,000 or there is no bleeding. And of course, most cases, I would say 95% of the cases have received empirical antibiotics initially. Once there is a non-life-threatening disease, if the child is not in shock, echo is normal, the child has a non-KD phenotype, what used to be called as febrile inflammatory state, which is not being used anymore in literature, we do consider oral steroids on a select basis, 1 to 2 milligram per kg. And if the child has got abdominal pain, we give intravenous methylprednisolone for 2 to 3 days. The child has KD phenotype, particularly below the age of 5 years. We straight away give IVIG and we combine it with IV methylprednisolone. If there is non-life-threatening disease, KD phenotype, we prefer to give 1 to 2 milligram per kg. We have reduced the dose now for non-life-threatening disease. And of course, we give aspirin. If there is no response after 48 to 72 hours, what do you mean by lack of response? You have started treatment, IVIG and steroids. After about 48 to 72 hours, there is persistence of fever, there is persistence of end organ dysfunction, CNS, hepatic, renal, gastrointestinal, severe abdominal pain, terminal ileitis, the ultrasound. We do consider biologics. And earlier, we used to use tocilizumab. We have used for about 3 cases. Now it's more difficult to get tocilizumab. We have used anakinra in 1 case. We plan to use it if it's available as first line over tocilizumab. If it is a KD phenotype, we consider infliximab. In the last 115 months, we have not used infliximab even for a single case. All of them have got better with IVIG and steroid. Steroids, after 3 days of methylprednisolone IV, we change out to oral prednisolone and then give low-dose methylprednisolone IV if abdominal symptoms continue, and taper 25% every week, stop over 3 to 4 weeks. IVIG, we prefer to complete within 12 hours. Most of them tolerate unless they have cardiac failure in the ICU. Slower infusion, only if there is cardiac dysfunction or fluid overload. IVIG dosing is best done as per ideal body weight. We always have give standing instructions to the nurses to preserve a serum and a whole blood plasma sample for future studies, immunological studies, viral markers before starting IVIG. This is a must. And IVIG is not available. There are a few patients who cannot afford IVIG, and now the cost has gone up. Only 5 grams are available. Only one brand is available. The parents refuse to go out. In fact, ICH and government hospitals have adequate stocks of IVIG, I am told. They refuse to go, or if it is not possible in the middle of night to start IVIG, IVMPS alone can be used, but we prefer to obtain parental consent. We explain to them that we are not giving IVIG for such and such a reason. And studies have shown, in fact, in the Bristol Hospital protocol, 70 grams is the highest dose of IVIG. We tend to restrict, even if the child is obese, to 70 grams. And over 5 years, we are moving towards steroids alone and avoiding IVIG, particularly in non-KD phenotype. Enoxaparin, we have used very rarely, and we follow the recommended guidelines which say that if we have an Z score of more than 10, or if there is documented thrombosis, or if the ejection fraction is less than 35, we give enoxaparin 1 milligram per kg BD subcutaneously. And prophylactic dose has to be given in consultation with a good hematologist. It's not an easy decision to make. And while discharging the child, what advice should we give? Child is recovered with IVIG or with steroids. We give aspirin unless there is a contraindication for 4 to 6 weeks, maximum of 75 milligram. We recommend echo and follow them up to 2 weeks, 6 weeks, 6 months, and 1 year. An ongoing cardiac follow-up study is on. Anticoagulants, if we had started, we continue with hematology consult and clinical assessment. We always counsel them regarding vaccination after IVIG and high-dose steroid therapy. Of course, the parents should be advised, after a diagnosis of MIS-C, vigorous exercise should be avoided for at least 2 weeks, or at least 6 months if there is myocarditis. In the end, I would say MIS-C has been only partly understood by pediatricians, infectious disease experts, rheumatologists, virologists, immunologists, research scientists, pediatric intensivists, and cardiologists. But there are several unanswered questions which should be taken up by youngsters listening to this session. Is there a genetic predisposition? If so, can we predict it before it occurs? We may find answers. What is the immunopathogenesis? You would have all listened to Winsley Rose. There are more questions than answers. That's the status today. Is MIS-C going to remain like KD in children, or is it going to go off from our community next year? Nobody knows. Immunomodulatory therapy. Are we going to fix up the therapy based on the phenotype or based on the severity of illness? Steroids or IVIG or both, or steroids plus IVIG plus biologics, or biologics? The answers are not known yet. Long-term sequelae. Is it going to be like KD or different? In fact, yesterday there was a report in Pediatric, recent paper, still not out, which says that 11-month follow-up of these children with MIS-C, the cardiac outcome has been extremely good. But we don't know yet whether it is going to behave the KD way and cause future deaths in young adults due to coronary aneurysms or silent myocardial damage. Vaccination. There is a chance that vaccination could increase the risk of MIS-C. We don't know yet. You would have all seen messenger RNA vaccines causing myocarditis in the US. What is going to happen? We don't know in pediatrics yet. I will thank If I don't thank my colleagues in KKCTH, pediatric consultants, PICU team, microbiologists, pediatric cardiology team, infection control team, and the team from NIRT, particularly Dr. Aishwarya Venkatraman, who had carried out so many research studies, and of course, my close friend, Professor Ramanan, who is on call every day with me for my difficult cases. Thank you for patient listening. Please mail your feedback, negative or positive, to sbsp@gmail.com. Over to Dr. Thangavelu. Thank you very much.
Thank you, sir. Excellent talk. Even though it took us very fast through you took us a tour through the MIS-C. Like when it started in April 2020 with difficult to make a diagnosis. It took us all through a tour of 150 cases. It's amazing, sir. Amazing for a pediatric hospital. So many cases. I think it is comparable to Children's Hospital ICH, I think, sir. Great, great. Really, amazing number of cases. There are some questions. We'll keep the questions after Professor Ramanan's talk. Over to Dr. Ramanan. I've already introduced Dr. Ramanan is a pediatric rheumatologist from Bristol Royal Hospital Children. And I think he is involved in many studies and many clinical trials all over the world. Over to Dr. Ramanan.
Thank you very much, Dr. Thangavelu, and thank you for Dr. SBS for inviting me. You can hear me fine, can't you?
Yeah. Can hear you and see your slides.
And you can see the screen. Thank you very much. I've only joined for the last talk, so my apologies if I'm repeating some of what's already been mentioned. After that excellent exposition by Dr. SBS, I'm not sure what I'm going to add. What I've decided to do in these 20 plus minutes is try and tell you what lessons we have learned because of my involvement in the recovery trials in adults, as well as try and give you some guidance on whether you can use steroids as first line. So this is the pathophysiology, and I'm sure it's been addressed by previous speakers, so I won't dwell on it. But one of the reasons we know that primary COVID is of low incidence in children is, we believe, due to the ACE2 receptor disposition. We also know that type 1 interferon is a pivotal cytokine, which is key for antiviral responses. And we know from adults who die using genetic studies that a blunted type 1 interferon response, or having anti-interferon antibodies, is what gives you severe COVID. And this might have some, in answer to Dr. SBS's first question, is there a genetic predisposition? We may think that there is, and I'll come to that again. And then whether it's severe COVID and primary COVID with respiratory symptoms or in MIS-C, the damage is mediated by an overdrive of the immune system with the release of a lot of pro-inflammatory cytokines, which is what you're targeting with either IVIG or tocilizumab or steroids. So this probably has already been addressed. Primary COVID, which is COVID involving the lungs as it affects adults, is extremely rare. Most of the children do have symptoms which are very mild, which is why there are major dilemmas on whether to vaccinate kids when COVID itself is not a condition which causes significant morbidity or mortality. And I'll show you some preprint data on what the morbidity and mortality is in the UK context. So UK is probably almost the size of Tamil Nadu. So this being a Tamil Nadu pediatric society, you can have some level of extrapolation. In answer to the question, we think that SARS-CoV-2 related MIS-C might actually give us some clues in understanding Kawasaki, even though, as it's been pointed out to you in the previous lecture, there are some similarities and there are some differences. We know that a lot of people get exposed to the virus. Why is it only a tiny number of children go on to get this multi-system inflammatory syndrome? And the clues will certainly lie in the genetics, even though we haven't got the answers yet. I'm fairly confident in the next 12 to 24 months, this disease will enable us to understand more about the immune interactions between the immune system and the virus than 3 decades of research in Kawasaki. This has already been pointed out that there are certainly some similarities with Kawasaki, while there are some distinct differences. And I think the differences is what you need to focus on. The fact that most of the kids with MIS-C tend to be above the age of 5. And if you see someone under the age of 5, you treat them as you would treat Kawasaki. the significant GI involvement, which was shown to you in the KKCTH cohort, is what's been seen in the UK cohort and worldwide as well. And the significant proportion of kids presenting with shock and cardiac dysfunction, again, is at odds with what we see with Kawasaki. So this is preprint data, but I'm going to show you, this is just hot off the press. We're going to look at deaths in children and young people in England, which is just a population of about 55 million, during the SARS-CoV-2 infection in the first year. So this data was cut off at about February, which is at the peak of our second wave. So in fact, what we are showing here is that there were only 25 deaths in the period from March 2020 to end of February 2021 in children, which is reassuring compared to the huge number of deaths in adults. And this 25 is between both primary COVID infection and with MIS-C. We call it pediatric inflammatory multisystem syndrome, temporally associated with COVID-19. We were the first in the world to identify MIS-C, and that's why this name stuck. And we put out an alert in April, and I was part of the Royal College group which did this. But I think MIS-C is a much better term. And if you see, most of these are primary COVID deaths in those with life-limiting neurodisability and those with other life-limiting conditions. So these are probably children and young adolescents with severe immunosuppression or severe neurological problems, which means they will have a compromised respiratory system and therefore are highly susceptible for a primary COVID pneumonitis. And really some of the other things we worried about initially, such as asthma, hasn't been a problem, or those who have ALL and are on chemotherapy. So what we are showing here is all deaths in the same 1 year period. They looked at actually a 5-year period, but mainly this March 2020, which is when we started recognizing cases, to February 2021, which when we cut off. And then these orange line is deaths in children with positive SARS-CoV-2. And the bottom line is that mortality from all forms of COVID, whether it's primary COVID or MIS-C, is extraordinarily rare and low, which is why there is a huge ethical question on whether vaccination is the right way forward when the impact of this virus in children is of such low magnitude. And of these 25, and it's only a small number, of these 25 deaths, the main ones are in the age group of 10 to 17, and that's the age group where both MIS-C predominates, as well as you have some children who are severely disabled from genetic neurological conditions, as well as other life-limiting conditions. But what is interesting, and this comes back to the issue with India, is in UK, we have out of a population of 65 million, about 3.5 to 4 million who are of Indian, Pakistani, or Bangladeshi origin, and then another million of Afro-Caribbean origin. And we see that the mortality is disproportionate in these two ethnicities. So whether there are underlying genetic predispositions or whether these are just socioeconomic variables, we don't know. But it's certainly something that will become more apparent. And that has some important implications for us in India, because if there are genetic predispositions from those of Indian origin, then we need to understand better and more, be more vigilant for MIS-C. So the next preprint paper I'm going to show you, and I'm going to only summarize it, was the risk factors for intensive care admission and death in all children, again in the period from March 2020 to February 2021. And the summary of this is, in this period of almost 10 months, we had 6,000 hospital admissions. These are 6,000 hospital admissions for children, of which there were 250 PICU admissions and 8 deaths from primary COVID. If you take MIS-C, we had about 700 hospital admissions, about 300 of which were in PICU, and less than 5 deaths. So this gives you a further reflection. And as I said, this data is for England, and England's population is about 55 million. So just, I would say that's 5.5 crores. So not far off from the size of Tamil Nadu. So this is what one can expect for Tamil Nadu as well. You probably will have a slightly higher, younger population. So what I'm going to do now is, even though we are pediatricians, most of you will get sucked into treating adult COVID or getting requests from friends and family about how to manage adult COVID. And I want to dispel some myths, because in the last 10 months, people use a load of medications in adult primary COVID, from which we derive the evidence base for pediatric COVID. So this was the original recovery protocol. When COVID first hit our shores in March 2020, we wanted to study these 4 drugs. These were drugs which people thought might work: an antiretroviral, steroids, hydroxychloroquine, and azithromycin, and those who didn't respond to a randomization in this, tocilizumab or not tocilizumab. Then we went on to look at convalescent plasma, continuing with tocilizumab. Then we went on to look at the Regeneron, and there are 2 monoclonal antibodies. One is the Regeneron, which I think is approved for emergency use in India, and another one is the Lilly's. I've been involved in studies of both of those in one form or fashion. And we also looked at colchicine as well as low-dose aspirin. And I'm going to summarize all of this, and all of these studies are in adults. The first one, and this report really revolutionized the management of COVID across the world, and this came from the recovery trial in UK. And what they showed was, if you had dexamethasone, you had a significant reduction in mortality. But this reduction in mortality was only if you were on oxygen or on ventilation or any form of therapy beyond oxygen. So if you are PCR positive and an adult with COVID, but you're not requiring oxygen, you do not need steroids. But if you need oxygen, then steroids will significantly reduce your mortality or your need for ventilation or further care. And that's what I'm showing here using the odds ratio, saying that if you had dexamethasone versus just having supportive care, then you had much lower incidence of mechanical ventilation. But if you didn't need oxygen, you didn't need steroids. And in fact, there was a trend for harm in terms of side effects in patients who were PCR positive, had COVID, but didn't need oxygen. So the moral of the story is, do not take steroids if you do not need oxygen or any other form of supportive care. And what we showed, and this was published about 6 months ago by my colleagues, but we showed that since the dexamethasone data was published, in UK alone, we've managed to avoid 73,000 deaths. So we have saved at least 12,000 lives and about 100,000 life years gained for a very small proportion of cost, because dexamethasone is a generic drug. So probably in the last year, the drug which has saved a lot of lives is steroids, but do not use steroids if you do not have significant illness, and significant illness is classed as needing oxygen therapy or needing ventilation. I don't need to remind any of you about the hype surrounding hydroxychloroquine. And this is a large study we published showing that when 1,561 adults were randomized to hydroxychloroquine versus 3,000 to standard of care alone, there was no difference in the 28-day mortality, showing hydroxychloroquine does not have any role to play in primary COVID-19 infection. So among hospitalized patients with COVID-19, there is no difference in mortality between those who received hydroxychloroquine and those who got just supportive care. Next is the retroviral combination. Again, no difference between standard of care and those who got the retroviral for 28-day mortality. So this again is an ineffective therapy, do not use. Azithromycin, and I know loads of hospitals around the world still use azithromycin. This is again a large randomized control trial from the recovery group, 2,500 patients in the azithromycin group, 5,000 in standard of care. Absolutely zero difference in 28-day mortality, showing there is no role for use of azithromycin. So just to recap, I've said no role for hydroxychloroquine, no role for retroviral, no role for azithromycin. I know most of you would know of stories of people scrambling to get convalescent plasma. And this randomized control trial has just been published about 6 weeks ago, again from the recovery trial group. What they did was they took almost 6,000 patients were allocated to the convalescent plasma group, another 6,000 to standard of care. So these are large samples, not just 10, 20, or 50 patients. 28-day mortality. And this is high titer convalescent plasma, because someone would ask, is the titer low? All patients had high titer convalescent plasma. And there is no difference in 28-day mortality between the hospitalized patients with COVID-19 who got convalescent plasma to those who just got standard of care. So this is an 11,000 patient study, clearly demonstrating there is absolutely no role for convalescent plasma. Colchicine, there was a lot of hype around colchicine because of one Canadian study. This again is preprint, but it's going to come out anytime now. 5,000 plus patients randomized to colchicine compared to 5,000 plus patients to usual care. No difference between the group which got colchicine to the group which got just supportive care in either 28-day mortality, duration of hospital stay, or the need for ventilation. Again, colchicine is ineffective. It might be inexpensive, but it's ineffective as well. And then this is the Regeneron's monoclonal antibody cocktail, which if given early, there was a lot of promise, and I know of some famous American personalities like the previous president got this. This study is slightly relevant to us as pediatricians because it did include children about the age of 12. This again is from Recovery, and I was associated with it closely. So they took 10,000 patients who were randomized to usual care or usual care plus this Regeneron monoclonal antibody. And what's important here is half of these patients were seropositive at baseline, and a third of the patients were seronegative. And in about 15% of the patients, we didn't know the antibody status. And what this study shows is if the monoclonal antibodies are given early when you are seronegative, then you certainly will have an impact in reducing mortality. But it has to be given early, and it has to be given in seronegative. The seronegativity goes with being given early because you haven't had a chance to mount an immune response. But it's an highly expensive therapy. Nonetheless, it does show a reduction in 28-day mortality. And this is the Regeneron cocktail. I have no reason to believe that the Lilly's monoclonal antibody will also be similar. Then come the major immunosuppressants, tocilizumab. And everyone at this time, including lay press, was talking about the immune overdrive and the cytokine storm you see in association. Why IL-6? It's a perfect cytokine to target in primary COVID infection because we know that IL-6 has a major role in elevation of CRP, working on the liver and the hepatocytes. It leads to the increased thromboembolic manifestations that adults with COVID-19 get because it increases the VEGF and increases the vascular permeability and causing a vasculitis or a vasculopathy. It acts on the complement pathway, and it activates the clotting cascade as well. So I'm going to only touch on 3 major trials which unequivocally show that after steroids in July 2020, the next drug which has been shown conclusively to reduce mortality is IL-6 blockade. And the first one is again a UK and Netherlands-based study, but the bulk of patients recruited in UK. Here they recruited patients, mainly adults who are in ICU. And they looked at tocilizumab versus sarilumab, another IL-6 blockade versus control. And the primary outcome was seeing if they can have an impact on death, as well as days free of organ support. They had 350 patients to tocilizumab, only a small number to sarilumab. But these are all very sick, in intensive care, and they had to be within 24 hours of being ventilated. The mortality was 28% in the tocilizumab group, 22% in the sarilumab group, but 35% in those who did not get IL-6 blockade, thereby showing that IL-6 blockade on top of dexamethasone reduced mortality by a further 8.5%. So this is additive to dexamethasone. And this was in very severely ill patients, whereas Recovery trial took 2,000 patients in the tocilizumab arm compared with 2,000 who got only standard of care. And they showed that for every 25 patients you treat with tocilizumab, 1 additional life will be saved. And this is on top of dexamethasone. 80% of these 4,000 patients received dexamethasone. It also had an impact on the need for oxygen and mechanical ventilation, and it reduced the demand for mechanical ventilation if you manage to give tocilizumab early in the illness when they only need oxygen. We also did a randomized control trial, which I was part of with Arvinder Soin, which we published in the Lancet, which was 180 patient, and we replicated showing that in the severely ill patients, if you give tocilizumab early, this was done across multiple hospitals, including in Apollo in Chennai, showing similar to the other data. This is a study which we just published 2 weeks ago, which I was part of. It's a WHO meta-analysis of all the studies. And if I summarize it, there was a total of 10,000 patients from 27 trials. And using complex statistics, we showed that all of them together have the same effect, that IL-6 blockade is associated with a reduced 28-day mortality. So WHO has come up with very few positive trial evidence for therapies after steroids. The next one is IL-6, where they've clearly shown in a meta-analysis that it does reduce 28-day mortality. And then comes JAK kinase inhibitors. Why were we interested in Janus kinase inhibitors? Because we think they are only anti-cytokine because they block a host of cytokines, including gamma interferon and IL-6, but they also may have a putative antiviral role by acting through these AC or NUM kinases. So I was part of a large randomized control trial, which was run across the world. This paper is about to come out in the Lancet in the next couple of weeks. This is the preprint data, which I'm authorized to show you. It's a 1,500 patient study showing that when baricitinib was given on top of dexamethasone, there was an additive 38% reduction in mortality. So I know the cost of baricitinib has come really down in India, and you can get it for 40 rupees for a 14-day course. It will probably only be 500 rupees. So if you need oxygen and you've tried steroids, baricitinib is a much better drug than tocilizumab, which is expensive and hard to access. So what about children? Dr. SBS has already pointed out to you that we wrote this recent editorial in Lancet. I firmly believe that IVIG was used in MIS-C only because we saw the features of Kawasaki. Perhaps had we started using steroids, we would have seen the same responses as we're seeing with IVIG. IVIG is expensive, it's in short supply, and a lot of children with MIS-C are older, so you will need to use large doses. They may be 30, 40, 50 kilos, costing huge amounts of money, whereas steroids is safer and cheaper. So I will show you a host of retrospective data to back up my argument. This is a French data where they divided the patients into two groups, those who got IVIG versus those who got IVIG plus steroids. And then they used complex statistics using propensity scores. If you give somebody IVIG plus steroids, it means you're more worried about them, but you can factor that in your stats analysis. And what they did in this 100 plus patients is divide them into a third who got both steroids and IVIG, and 2/3 who got IVIG. And they showed that if you're very ill, IVIG plus IV methylprednisolone, exactly as was pointed out to you in the previous talk in their life-threatening patients, worked much better. It decreased the intensive care stay. But the question we want to answer is, would these patients have done as well by just getting steroids? And that's the point that Mike Levine, my colleague in London, was trying to address in this paper, which was published 4 weeks ago in New England Journal of Medicine. And this again uses complex statistics. It takes a whole host of almost 1,000 children from all across the world. It's a retrospective study, and it takes into account whether they've had steroids and then IVIG, or IVIG and then steroids and other drugs. And what they divide them into groups of IVIG alone, IVIG plus steroids, steroids alone, and other immunomodulators. And is there any differences in the age-adjusted Z scores? Nothing massive. And the SARS-CoV-2 antibody positivity rate is similar in all of them. About 70 to 80% are antibody positive, as you would expect in MIS-C. And what they're showing here is if you compare IVIG plus steroids versus IVIG alone, certainly these patients recover earlier. They need lesser support, either in intensive care or with inotropes, and less complications and less mortality. And that's the time to stop inotropes, time to stop ventilation, time to stop oxygen are all better in the group which got both drugs versus just IVIG alone. But the comparison we're most interested in is steroids alone versus IVIG alone. And those who got steroids alone did show a trend, a clear trend to having less inotrope support, less mechanical ventilation, or getting weaned from mechanical ventilation. Shown much easier in this, showing that those who got IVIG alone took longer to stop inotropes, took longer to stop ventilation, needed oxygen for longer, and were, in terms of severity, both groups were similar. So I would put it to you that it's not just in those who are economically disadvantaged, but in anybody about the age of 5, IV steroids or oral steroids is as effective as IG alone. So we are doing a large trial. We have recruited more than 275 children, and I think by end of August or early September, we'll have the results. What we do here is we took all kids with MIS-C in UK, and at entry, they will either get usual care or IVIG or IV methylprednisolone. And for those who are not better after 24 hours with the first-line randomization, they can then enter, or immediately, even if the physician's worried, to either tocilizumab or anakinra or usual care on a 2:2:1 allocation to make it more attractive for families to participate in the study. So this is the pictorial design for anybody entering the recovery pediatric trial with MIS-C. You will either be randomized to no treatment or to IV methylprednisolone 10 milligram per kilogram for 3 days, or IVIG 2 grams per kilogram. And for those who are persistently febrile or have a CRP of more than 75, you can enter the second randomization of anakinra or tocilizumab or standard of care. As I say, we have recruited almost 275 children. We are doing our final data clearing, and I hope if I'm invited again, I'll be able to show you the results, which hopefully will conclusively demonstrate that an inexpensive drug such as steroids is as effective, if not more effective, than IVIG. I'll stop there and take any questions. Thank you very much again for your invitation, and apologies if I overlapped with other speakers.
Thank you very much, Professor Ramanan. Brought a very nice, lot of analysis, analyzed almost every drug used in COVID, both in acute COVID as well as in MIS-C, and brought out a fantastic support from your clinical trials. Definitely, if you are going to say that steroid is equally effective like IVIG in children above 5 years and echo doesn't show coronary aneurysm, we'll be too happy to have it, because the MIS is a disease presenting with very serious illness. They recover faster within 4 or 5 days, but the parents are very unhappy. And I mean, the amount, they can't face the burden of financial burdens. If you say that probably steroids are equally effective, it will be a great blessing for all these kids and their parents. We have some questions. So do you have any long-term problem with the tocilizumab?
No,
like
tocilizumab stays.
Incidence of tuberculosis or infection, all that long-term?
Yeah, so the TB question I can't answer only because we have very low endemicity for TB.
Yeah, there's a country
UK.
like India where.
But I would not expect a huge problem because you're only giving a single dose, and it tends to get with a half-life, probably within 4 to 6 weeks, you've completely left the system. The only thing I would do is avoid giving vaccinations for about 3 months in order to prevent a blunted vaccine response. In the children who get tocilizumab, you would avoid vaccines for 3 months.
The theoretical risk of tocilizumab aggravating tuberculosis is very small because in MIS-C we are going to give 1 dose.
Okay.
You know, most severe MIS-Cs are all either well-nourished or obese children. They are not malnourished children with high propensity for tuberculosis. And of course, in a child who's got a severe MIS-C, you first worry about saving the life than about tuberculosis.
Yeah, immediate safety of life. Thank you, sir. Thank you. It was a practical solution, this dilemma. Again, to Professor Ramanan, what about, we had a mini epidemic of mucormycosis in India, including kids, adult and kids are affected. Did you see mucormycosis in your population or other Western country population? What could be the reason for mucormycosis in our country?
That's a fascinating question, actually, because initially when there was a huge incidence of mucormycosis, people said it's because there were a lot of them were diabetics. But the proportion of diabetics in the 35,000 plus adults recruited to recovery is 30%, similar to the proportion of diabetics in India. So it's not more or less, but we don't see much mucor. So I'm not sure if the reasons could be more local, such as greater background prevalence of mucor, probably new onset diabetes, I'm just speculating, and probably more indiscriminate use of steroids for longer periods. Here we just give steroids only if you need oxygen, and that was only till discharge. So you don't get steroids if you're not on oxygen.
There is another question is, Professor Ramanan, how do you justify no treatment arm in your current study?
Yeah, so, you know, this is, as Dr. SBS pointed out, our experience as well is in the child or adolescent presenting with MIS-C who is not in shock. there are about 1/5 of the patients who settle spontaneously. Okay, we have limited evidence on what the long-term outcomes are, both from a quantitative echo and qualitative. But the UK system allows us to do this sort of randomization to address and get questions. But imagine 15 months ago, it was thought unethical to not give hydroxychloroquine if you got COVID. We've now shown by doing trials it doesn't work. 12 months ago, everybody was hunting for convalescent plasma, and it would have been considered unethical to randomize them to plasma versus no plasma. Now we have shown it doesn't work. And I think we can make progress only by doing randomized control trials, but with appropriate safeguards. So, and I think the discretion for randomizing a patient into a trial is always with the pediatrician. If the pediatrician is concerned that this patient needs treatment because it's life-threatening, they wouldn't randomize the patient to the trial. They would go as per normal. And there are enough ways of still recruiting to the study, even if you've managed to give one dose or the other.
Dr. Tangavelu, I want to add something here.
Yes, sir.
In fact, like you, I like any disease where the role of the clinician is most important. So I like MIS-C that way.
Yeah.
In fact, the WHO said the CRP is 50. What if it is 45? Is MIS-C ruled out? No. What if it is 60? Is MIS-C confirmed? No. What if antibody is positive? Is MIS-C confirmed? No. So MIS-C is entirely a clinical diagnosis of exclusion, which has to be made by an experienced pediatrician. But as you would have seen, in fact, I didn't have time to talk about IAP protocols. The IAP protocol, we had a lot of discussion. Dr. Tanu Singhal also was there in the discussions. We put up a statement saying that if there is a doubt, you refer to an expert, bar pediatric rheumatologist, bar infectious disease expert. I think that is true for difficult cases. In fact, we have had a diagnosis of MIS-C initially, ultimately turning out to be typhoid fever or tuberculosis or dengue or scrub typhus. But I remember in one of our cases where we had admitted as MIS-C with CRP of 100, the junior most first year PG picked out eschar in the scrotum. We didn't investigate further. We gave only doxycycline, the fever crashed. I think it's pure clinical judgment. MIS-C is one more reminder to clinicians like you and me that it is good history and physical examination, of course, supported by rational investigations, which is going to take you to the finish.
Thank you, sir. 100% I agree with you. Anybody with a bald head and white mustache will agree with you. The clinical examination completely overrules the laboratory misleads. Even we also had a child admitted as a MIS-C, turned to be culture positive entry fever. So it's all we have seen that happening. I have some more questions for Dr. Ramanan. Before that, to Dr. SBS, sir, the child steroid is a really attractive option for a very costly IVIG. But a child got admitted on day 3 of fever with a CRP of 100 or 200, where we can't exclude any of this. All the cultures are going to be available for us for next 48 hours only. Is it safer to start steroids? That is a big thing. Because many of the investigations, including strep typhus, all the investigations may not be available immediately for us. It will definitely take at least 48 hours.
This dilemma...
I'm not questioning you. I'm just telling my difficulty.
You are asking an extremely relevant and important question. Right now in the hospital ward today, I went for rounds before joining the session. There is a child who's 2-year-old who was admitted yesterday with the 4th day of fever, not given any antibiotics outside, with rashes from day 3, questionable cheilitis, no glossitis, no conjunctivitis, rashes which I showed in the presentation, almost like articarial wheals over the face and limbs, no itching, fever 105, CRP 150, counts normal, platelets low normal, antibody positive, echo normal, D-dimers high, BNP borderline elevation. And yesterday I started on ceftriaxone, doxycycline. I was so confident about my diagnosis, I stopped ceftriaxone, doxycycline and started IVIG and methylprednisolone. Morning, the lab has called me and told me gram-negative bacilli is growing. I restarted ceftriaxone. I reduced the dose of methylprednisolone from 10 milligram per kg. That's a usual thing we give. We do 1 to 2 milligram. We have completed IVIG. The parents are angry. I don't know. I mean, this is a dilemma which is going to be there. I think in a sick child who has got hypotension, who goes into ICU, who fulfills the criteria of MIS-C, I don't think you or me will have the guts to withhold antibiotics.
Definitely.
Start a feeding culture. I always believe that there are two troubles. One is starting trouble and another is stopping trouble. You decide to start, okay, you stop. If you are convinced it is MIS-C and infections are ruled out, otherwise you continue. But in a sick child, it is a difficult decision. It is basically a clinical judgment. In fact, I often tell that in my discussions, Dr. Ramanan, we always say, we can't offer tailor-made solutions for every case which is going to come to our practice. But these children have not read the lit COVID, then they are not going to present you the classic MIS-C way. So it's essentially a holistic clinical judgment. You should think twice before starting high-dose steroids, or for that matter, steroids. And the, what you call threshold for antibiotics should be low in MIS-C. That's my comment.
Sir, Rajendran, can we have another 5 minutes, sir? Because you look very anxious. You look very anxious.
Before that, yes, per ICMR report, almost 60% children have antibodies. How will we use COVID antibody in diagnosis of MIS-C? Dr. Satish Kumar from CMC.
Yeah, that's what is going to confuse us.
Yeah, very, very simple answer. You must remember the WHO criteria does not mandate that you must have a COVID antibody positivity for diagnosis. It is essentially a clinical diagnosis. Antibody positive or negative, it is clinical diagnosis based on the algorithm given. And the algorithm is, I am afraid, is not perfect. We are going to see, like Kawasaki, incomplete MIS-C, complete MIS-C, atypical MIS-C, and we will have refinement of these criteria as more and more data emerge. You must also remember holistically that 1/3 of Kawasaki may have associated infections. We still do not know what percentage of MIS-C have associated infections. We do not know. So antibody positive or negative,
it's not going to
MIS-C
change
is
the diagnosis.
a clinical diagnosis and a holistic diagnosis. That's why I said I like this disease.
See, unfortunately, with us, all the old diseases are staying with us. Tuberculosis, malaria, typhoid, scrub typhus. New diseases are getting accumulated. Nobody is vacating the room. So that's why we have a lot of problem making a diagnosis. We have to do a lot of investigation, a lot of treatment, confusing us. Compared to those in UK and Western countries, they have only 1 or 2 diseases. That's the problem with us. There is one question for Dr. Ramanan. Dr. Ramson asked this. RCT, you're able to do so much of RCT in such large numbers. Any suggestions for us, Indian colleagues, to imitate you and how we should make it possible?
Yeah, I think probably one of the biggest success stories in COVID was that we recruited 45,000 adults and almost all major do's and don'ts of drugs which work and don't work. It's because we have a single healthcare provider. Everybody is under the government healthcare system. And at the start of the pandemic, the government said that through the chief medical officer, that you can only access drugs through the hospital almost always in a trial. So if you wanted tocilizumab, you had to be in a trial and you have to accept that you'll have a 50% chance of not getting it. That was your only way for every drug apart from oxygen and supportive care. I think so much could have been done if we had a network of hospitals and there was clear direction, because the numbers in India, you would have answered all these questions in 1 month. But
I think I didn't hear anything about mucormycosis from you. Mucormycosis.
No, I explained that even though 1/3 of the adults of the 40,000 had diabetes, we didn't see the same prevalence of mucor in UK. So just to say it's because of diabetes is not possible. So I have 3 possible explanations for which I haven't got evidence. One is a putative, that whether the virus was destroying some, in an immune-mediated process, the pancreas, leading to new onset diabetes, which was resulting in the mucor. The second is indiscriminate use of steroids. I don't have any evidence for that. And the third is poorly controlled existing diabetes. We probably had in the whole country only less than 10 cases of mucor. So it's inexplicable, and I hope somebody looks into it in greater detail to why there is so much mucor in India. But it needs a very careful investigation.
And just say just one thing. I just congratulate Professor Ramanan for his lot of research work, and I think it has given a lot of useful information to the entire world, I would say. And I'm pleased to say that he was my college mate in Stanley Medical College. Thank you.
Dr. Ramana, one question. Regarding MIS-C management, do you have any trial with RCT trial DEXA versus methylprednisolone?
No, but in our trial we gave equivalence. So we put a table. You could use either methylprednisolone or dexamethasone or hydrocortisone on equivalent doses. We involved some pharmacologists who said that the dosing can be just extrapolated. So we think if we show one works, you can use any of the 3. There are some small benefits of DEXA, such as better CNS penetration and so on, but we don't think there's a big difference. For the under 1 month, that is the infants and neonates with primary or COVID or MIS-C, which are very small numbers, we used hydrocortisone because of the reluctance of neonatologists to use steroids, and so we used hydrocortisone, but they're all proportionate to the same dose. So we did equivalent studies. So much milligrams of dexamethasone equals so much of hydrocortisone equals so much of methylprednisolone.
Ramanan, if I might add, I don't think there is enough data to say that one is superior over the other. Theoretically, methylprednisolone may have better lung penetration, may work better in COVID pneumonia, but in your recovery trial, you have used dexamethasone and shown results. Ultimately, I don't think it is going to matter at all.
No, I think dexamethasone and prednisolone and methylprednisolone are fairly comparable. The differences are very minimal in terms of the mineralocorticoid effects. So nothing that should cause us any concern. So you can use any of the... Dexamethasone and prednisolone are interchangeable. Hydrocortisone probably has got slightly different profile in terms of its mineralocorticoid activity.
In fact, I always used to wonder, Ramanan, several diseases, 10 milligram per kg MPS, 15 milligram per kg MPS, 30 milligram per kg. Have all these been arrived after RCT or just after teacup discussion?
The 10 to 30, there's no evidence base, but I've said this before in my talks that low-dose steroids work by a mechanism which is called genomic. So when you give somebody 1 to 2 milligrams of steroids, they bind to the steroid receptor, the glucocorticoid receptor, and then from there you will get downregulation of the pro-inflammatory cytokines and upregulation of the anti-inflammatory cytokines. But when you give 10, 20, or 30, and we don't know what the right dose is, we use 10. They work by a different mechanism, which is called non-genomic. So we shouldn't confuse the dosing. But whether you use 10 or 20 or 30, we have no evidence base. But 10 is different to the way, the mechanism of action is different to the way low-dose steroids, 1 to 2 per kilo, work.
The SPS on the lighter side, do you think somebody will start a certificate course or diploma course on COVID, like diabetes, tuberculosis? Or you have any idea of starting a certificate course on COVIDology?
My God, I'm only praying. I'm only praying that the third wave doesn't come, and me as well as my hospital escapes from financial crisis.
All the pediatricians.
Yeah. In fact, in one of my presentations to the Star Health Insurance, I showed a figure of an old man looking at the sun with the dry land, waiting for rain. Is none other than a pediatrician, because many young pediatricians are getting out of business. In fact, I read an article in Medscape that the maximum reduction in the professional fees to doctors has been amidst pediatricians. They had also done a survey amongst young pediatricians. 90% of them feel that their future is bleak. So if COVID continues, it's going to be bad business for us.
If I can come in for a minute.
Yes, sir, Jagdish. Yes, please, sir.
Excellent lectures from both Dr. Bala and Dr. Ramanan. Dr. Ramanan, you very briefly mentioned in the introduction of your talk about interferon, and there are two genetic studies which are shown now that those who have either low interferon or those who have interferon antibodies are those who are predisposed for severe COVID, and especially in the younger age groups. So has there been any study on the use of early interferon for high-risk patients?
No, I mean, you're absolutely right. We know that you're predisposed to getting severe respiratory COVID if you are either blunted in your interferon response or if you have anti-interferon antibodies. And you allude to the two studies which have been published. There haven't been any studies, but there is, as you know, now JAK kinase inhibitors work through the interferon pathways. And now tofacitinib and baricitinib have both been shown to be very effective. And I think for respiratory COVID, at least in adults, after steroids, JAK inhibitors will become the next line of treatment. And as you well know, there's huge cost differential. Tofacitinib and baricitinib, a 14-day course will only cost you between 200 to 500 rupees compared to tocilizumab 8 milligram per kilogram for a 70 kilo adult, if you can access it. Is huge. So that's the only data we have. Nobody else has done any other interventions. But I think I come back to the point I said, we'll understand more about Kawasaki through MIS-C because there is a clear genetic predisposition. We just haven't identified it. Because with 70% of the pediatric age group children being positive, as Dr. Satish alluded to, why is only a tiny proportion getting MIS-C? Must be a genetic predisposition.
Chromosome 3?
I don't know, to be honest.
So there was a study which came out from the UK and from the Europe, which showed that the predisposition for getting more severe COVID is located on chromosome 3. So
it might be. I'd be cautious in drawing too many conclusions because they're all kind of early data. What we need is large scale. And so maybe in the next 6 months, you'll have more clarity.
The second question I had was regarding tuberculosis and coronavirus. So because we have seen a huge surge of tuberculosis across India in patients who are post-COVID. Is this only because of lockdown and they didn't seek care, or is it because there's an immune suppression secondary to COVID?
I can't answer that because I lack that experience.
Jagdish, I will answer this question.
Yeah,
I will answer this question. Somebody was walking on the Marina Beach on a Sunday evening. He saw 10 people, out of which 4 were smoking ganja. The next day, he concluded that 40% of Madrasis are ganja addicts. I think such observations, in fact, even in our own hospital, we have had gross reduction in admissions, but we have not seen much reduction in TB cases. We have not seen much reduction in scrub typhus cases and enteric fever cases. I think such hospital-based data does not say anything. In fact, from the National Institute of Research in Tuberculosis, they have submitted a project for studying the comparison of antibody and infection status of children with and without tuberculosis. I think only after such a study that will be known. But it is postulated in a few case reports that COVID can suppress T cell function and tuberculosis can manifest. But it's very difficult to conclude that COVID has been responsible for the simple reason, different forms of tuberculosis have got different latent periods. For example, bone tuberculosis presents after 7, 8 years or 6 years, renal tuberculosis 10 to 15 years, endometrial tuberculosis 15 years. So I think just by seeing a marginal increase in numbers, to blame it on COVID without data, you may be right, but there is no evidence in literature.
So that's why I'm asking for evidence.
There is no evidence today.
Okay.
Dr. Satish Kumar, CMC Vellore, do you have any data regarding MIS-C cases? Dr. Satish?
Satish, are you available, Satish?
He's muted. Satish, he's muted.
Your MIS-C data and your comments.
Actually, they have published their MIS-C data in Indian Pediatrics.
So, sir, that is the last year's data we have published. This year's data, we are just doing an observational study by using our protocol. So once all the study is over, we will publish in that.
Okay, great. I'm sure they will do.
Yeah.
Roughly, how many cases, Dr. Satish, we are having this year?
So this year we are almost 70, sir. 70.
I also tell you, Satish.
Yes, sir.
Vince presented the data in the Lancet Commission discussion. The data that he showed was far different from the data we had. Most of the cases you had all seen have been very severe with quite a few deaths. And most of the severe COVID have been in immunocompromised children. Whereas in our hospital, that we have data on immunocompromised children, they have all done so well. No direct deaths due to COVID-19. In fact, 260 positive children hospitalized, only 2 deaths, and both the deaths were due to non-COVID morbidity. One was an acute myelocytic leukemia dying of tumor lysis syndrome. Another was an undetected vasculitis who died of renal failure. Whereas in your series, you had seen, of course, it may be something to do with the referral bias of your institution, which sees large number of chronic patients coming there. In fact, I was even asking Winsley about it. He presented the very interesting data from your institution in the Lancet Commission, which showed that large number of children had succumbed because of underlying illness due to COVID.
Yes, sir. So most of them are our hematology patients. Few of them are post-transplant patients. That's the data Winsley would have showed you. Almost 9 children. They're not, most of them does not die because of the primary COVID, as you correctly said.
Just one brief question.
There are 2 questions in the chat box. One is whether EBV can also lead to MIS-C. There are any scope to study like COVID, whether EBV can lead to MIS-C. That is one question. Second question is what is the influence of HIV? Whether it is mutual acceleration or deceleration of HIV by COVID.
So
COVID and HIV.
Yeah, I don't know the HIV one. We haven't got any data to answer that. The EBV, we already know EBV can give a hemophagocytic syndrome. EBV HLH is well recognized. In fact, rituximab is used. So I'm not sure it gives a multi-system inflammatory syndrome, but it gives more a hemophagocytic syndrome. In terms of long COVID, people are looking at EBV is well recognized to give chronic fatigue syndrome, and people are looking at the role of SARS-CoV-2 for a similar long COVID. Our own hospital is running a long COVID clinic, but it'll take months, if not years, before we get some clarity on what the incidence prevalence is.
Can I just ask a brief question?
Yes, go ahead.
Just I want to know, Dr. Winsley mentioned in his lecture that about 30% in ileum, 30% of ACE receptors are there. If that is the case, I would expect to see more of GA symptoms even in adults. I just want to ask Professor Ramanan also, whether do you have any sort of outcomes just based on the symptomatology, like GA symptoms do better than those who present respiratory, anything like that?
No, we don't see much people call as MIS-A, which is multi-system inflammatory syndrome in adults. There is a small number of adults who get multi-system inflammatory syndrome. They tend to be between the ages of 18 to 30. So why don't we get abdominal symptoms in primary COVID in adults is not clear. And I don't think you can go just by age distribution and symptomatology. The multi-system inflammatory syndrome is not necessarily correlated with ACE receptor distribution. Thank you.
One last question.
Dr.
From chat bar, can we use baricitinib in children? Usage of baricitinib in children.
Yeah, so we are running the trial from age 2. So the short answer is yes, from about 2 you have data, but that's only for primary COVID, not for MIS-C. So if you have a 15, 16-year-old, 80 kilo adolescent who comes in positive with, for PCR positive, is in oxygen requirements and you've given dexamethasone, then I think it's appropriate to treat him like an adult and give him baricitinib or her baricitinib.
Before concluding, our DME, Dr. Narayana Babu sir is there. I think I invited Dr. Narayana Babu sir to come on. Dr. Narayana Babu sir. I think he's not. Dr. Narayana Babu sir.
He's muted. Rajendran is muted.
Yeah, muted. Sir, muted. Yeah. Okay, sir. Shall we conclude, sir?
Yeah, it's a wonderful talk. Both at SBS and A.V. Ramanan, we learned a lot of new things. Wonderful, sir. Even though the time exceeded, we, in fact, we stuck to the chair to listen to every slide of both the SBS as well as A.V. Ramanan. It was very, very useful talk, practically useful one. And also a lot of interactive discussions which has thrown light on practical things. Thank you very much at SBS for organizing such a wonderful CME on COVID update. When is the next COVID update? In the way in which progressing.
Thank you, Dr. Rajendran and Ismail for giving me the opportunity to organize. And I have no words to express my gratitude to all my friends who made this possible. I'm extremely sorry. As you all know, I'm a stickler to timing. I hate any delay in initiation as well as completion, but it is unavoidable. And I thank Dr. Rajendran for having it. In fact, the function which is organized is very much necessary for IAP and for Tamil Nadu. Thank you very much for organizing it so well, Dr. Rajendran and Dr. Ismail. Thank you very much.
Yeah, before concluding, I invite our dynamic president to Ismail sir, few words. Tell few words.
Thank you, Rajendran. I think it was a wonderful session, very well organized. And I thank Dr. SBS sir for having roped in so many good speakers and good sessions. It will be really benefiting all the doctors who had attended today. And I congratulate Dr. Thangavel sir, Dr. PRC sir, and Dr. Jagdish Chinnappa sir for doing an excellent moderation. And especially I'm very much fascinated by Dr. Ramanan, who had done a very beautiful and a very lucid lecture. Really, we were astonished by the knowledge you possess, sir. Thank you so much. And I thank all the delegates and I thank all the IAPians for giving their support. Thank you.
Sir, thank you, sir. On behalf of IAP TNSC, I thank our Dronacharya, Bhismar, Dr. S. Balasubramaniam, sir. Helped actually is part 1, Bahubali 1, 2, Mari Poetry.
Yeah. RRR.
Yeah. So really, really thankful to you, sir, and because you organized a wonderful meeting. And every time, because hero is okay, I think for director easy for us. I think you are under your leadership. I think you are organized very well, and seniors like Jagdish Chinnappa and Dr. Ramana and Dr. Thangavel sir and Ramachandran sir and all stalwarts. I think you catch everybody. I think it's a wonderful and it's well appreciated also, and a lot of comments also I'm getting. And on behalf of IAP TNSC, I thank one and all. I thank our team, our Dr. Ismail sir, Dr. Ramesh Babu, Dr. Saram Sendil sir, and my strong support and as well as my pillar of success, Dr. Thirumurugan, and who has helped me a lot, and my treasurer, Dr. Gopal Subramaniam, and I thank one and all for this wonderful event. I once again thank everyone. Thank you.
Thank you, sir. Thank you. Thank you, sir.